morning, everyone. It is my privilege to welcome you all to this August gathering here at Lokmanya Tilak Municipal Medical College and General Hospital, Sion. Ocular trauma is a significant concern as it directly impacts vision, and today we have come together to address its effects. I would like to extend my heartfelt gratitude to all the speakers and audience for contributing to this event.
I now request Dr. Chaya Shinde ma'am to deliver the welcome address.
Thank you, Priyanka and Khushi. Good morning. Professor Dr. Ferenc Kuhn, welcome sir. Professor Dr. S. Natarajan, Honorary Professor Emeritus, Lokmanya Tilak Municipal Medical College. Esteemed colleagues, panelists, speakers, undergraduate and postgraduate students, interns, senior residents. I extend a warm welcome to you all. It is with great joy and privilege that I welcome each one of you to Vision Under Siege, Advances in Ophthalmic Trauma and Polytrauma CME in LTMMC and GH Sion. Today, we gather here united by a shared passion, that is learning about ophthalmic trauma and polytrauma. This CME is not just an opportunity to share the knowledge and ideas, but also a platform to build meaningful connections, explore innovative solutions, and inspire each other to reach new heights. We are honored to have such an impressive array of speakers, panelists, and participants who are here with a wealth of expertise, experience, and perspectives. I am confident that the learning sessions will spark new insights and collaborations. To those of you who have traveled from near and far, especially Sir Dr. Ferenc Kuhn, thank you for making this journey. Your presence is a testament to your dedication to advancing ophthalmology. I also thank our organizing committee, Dr. Karabilari, Dr. Usha Jori, Dr. Nikhil Smith, especially Mr. Joseph, Shubha, Samir, Namrata and Ashlesha from Aditya Jyoti Hospital. Sponsors Alcon, Entodd, Care Group, Reticare, Bosch and Lomb. Your hard work and support have made this event possible, and we are deeply grateful to you all. As we embark on this journey together, I encourage all of you to engage actively and make this CME a memory to cherish. Welcome to the CME, and Priyanka, now take over.
I now invite the panelists for our first session. Chairman, Professor Dr. S. Natarajan Sir, established Public Charitable Trust Kamala Sundaram Foundation. Co-Chairman, Dr. Naina Poddar Ma'am, Professor and Head of Department of Ophthalmology, Nair Hospital, Mumbai. Moderator, Dr. Mayur Morekar Sir, Associate Professor of Ophthalmology at Bombay Hospital. Convener, Dr. Twinkle Choksi Ma'am, Cornea Specialist and Associate Professor at Nair Hospital, Mumbai. Co-convener, Dr. Purva Valvekar, Assistant Professor, VR Services, JJ Hospital, Mumbai.
With Dr. Naina Poddar, Professor of Ophthalmology in Nair Medical College, and also our pride of Maharashtra because of she's the Leadership Development Program. Now she's organizing in Maharashtra Ophthalmic, and I have Dr. Mayur Morekar, again a UAT specialist and also involving in ophthalmic trauma. And that's the only thing I want to tell Priyanka, that we are calling this ophthalmic trauma because we represent Asia Pacific Ophthalmic Trauma Society, and also everywhere they are using oculus, and oculus is eyeball, and ophthalmic is including the orbit. Otherwise the lid and other things are missing. And we have Dr. Twinkle, who was a faculty with me, and she's from AIMS and now a consultant. Purva is missing. One more chair has to be put whenever Purva comes. And I invite the first speaker, Dr. Naina Poddar, to talk on pediatric ophthalmic injuries and emergencies. And I think we are starting a few minutes early, so if we have time for discussion.
Good morning all. Thank you sir, thank you madam. And I'm privileged to be here to speak on the topic of pediatric ocular trauma and emergencies. It's a very vast topic, and most of the things will be covered eventually in the entire day. And I'll try my best to enlist whatever surgeries, whatever traumas, whatever emergencies I came across, mostly during my tenure here as a faculty in Sion Hospital for 17 years. Right. You are all aware that the children are involved during sports, fights, and recreational activities, and this can be the leading cause of visual disability and blindness in children. But is pediatric trauma different from adult? Yes, it is. Why? Because it is difficult to elicit proper history, the mode of trauma, difficult to assess the vision. Thorough examination in child is challenging and it may require sedation or short GA. Diagnostic delay can lead to end of amblyopia and cosmetic disfigurement. Also, the prognosis is very guarded. Therefore, we have a special scoring system for the pediatric trauma, that is the POTS. Now, various types of traumas as an adult are encountered in the pediatric population: the open globe injuries, closed globe, adnexal injuries, and the chemical injuries. Here's a list of all the injuries. Then the main thing is history and assessment. Thorough history is very important as to how it happened, what happened, where it happened, when it happened. This not only helps in diagnosis but also for medico-legal documentation. Examination is also mandatory and try to attempt visual acuity assessment. Look at the pupils, the eye movements, and if possible, do slit lamp examination with fluorescence staining. And if there is suspicion of anything else, you may further require imaging processes. As I said, we have a POTS, and there are various raw points depending on the findings, and maximum raw points which are added. Higher the points, better is the prognosis in a child. Coming to management, all traumas in children, you need to keep the child NBM because you may require examination under evaluation, anesthesia, and exploration at times. Do not forget the tetanus prophylaxis or vaccination. Counseling is the mainstay here. You have to always tell the parents about the guarded visual prognosis, the need of multiple surgeries, the need of multiple general anesthesia, and further amblyopia management. The commonest injuries we see is corneal abrasions, nail injury, foreign bodies. Do not forget to do double eversion and look for hidden foreign bodies. Then the corneoscleral tears are plenty because of pencil, scissors, bow and arrow. Herein again, to assess the injuries, do not force the child, do not exert undue pressure, but do it under anesthesia and do the requisite primary surgical repair. If the iris is seen and if it is more than 24 hours old injury, we have to abscess the iris, and while doing so also look for the occult lens trauma. You also get lots of lenticular traumas, both in penetrating as well as blunt traumas. Here you see a penetrating trauma wherein the anterior capsule is ruptured. Here you need to go for early surgery with intraocular lens implantation, and if the child is less than 2 years old, we need anterior vitrectomy with PCC. Here you have to remember that there is very high risk of fibrinous reaction. Chemical injuries are the mainstay of injuries. 1/3 of injuries occur because of alkali burns. Here you have to note that you need copious irrigation and meticulous removal of those chemicals, especially the lime deposits. Here you can see, I have a video here. Can I play this? Yeah. Wherein in the OPD without anesthesia, we do prompt removal of the lime deposit, because this can further lead to continuous damage. Blunt trauma can occur because of tennis ball injuries, fist fight among the kids, and then the child can come with hyphema, iridodialysis, early rosette cataract, dislocation of lens. Here in this picture you see a child came with trauma to the orbital floor and wherein the inferior rectus is trapped, and you can see in this photo that the child had diplopia because of incarceration of inferior rectus. Canalicular tears. I have seen plenty of canalicular tears here, especially in infants, because of blouse hook injury. Here you can see a child wherein the hook got stuck and it led to canalicular tear. Here again we have to do examination under anesthesia, do probing, look for the extent of damage, do canalicular repair with lid tear suturing with insertion of mini monoqua stent. Dog bites. Yes, in Sion I have seen plenty of dog bites, provoked, unprovoked. Dogs have been, attacking kids, especially those who are less than 5 years old. The dog attacks the face and they come into the category 3. So it can lead to, as you see the lacerations here, canalicular tears, sometimes even open globe injuries. What you need to do is do a thorough wound toilet, thorough cleaning with iodine povidone solution, do debridement. Second, do a good exploration with surgical reconstruction without forgetting to give vaccination, rabies vaccination as prophylaxis, and also you have to inject intralesional human rabies immunoglobulins to counter the effects. Firecracker injuries. In India, we see lots of firecracker injuries, and it is the innocent bystanders that are mainly affected rather than the active users. This can happen because of bomb explosions, use of sparklers, rockets. Sparklers, they burn at a temperature of 1800 degrees Fahrenheit. They lead to chemical and thermal burns, and sometimes the child needs admission. Here you can see the burns as well as involvement of both the eyes in the children. So these are the various involvements. Do not forget exploration under GA here. Finally, I have seen lots of cases coming with acute proptosis and lid edema. You see a child with an injury, needle injury coming with proptosis, whereas on the left side you see a child with bilateral preseptal cellulitis because of insect bite. And then there was one case, a 5-year-old child who came with the proptosis lid edema, but it was a masquerade, and it turned out to be a case of rhabdomyosarcoma. So finally, I will end by saying, to prevent pediatric ocular trauma, you need to educate, and pay emphasis on prevention. You have to educate children, parents, family members, and school teachers. Tell them about the safety, the need of supervision, and the use of eyeglasses and safety eye gears. So I end by saying a good history, thorough examination is crucial, with prompt, appropriate, systematic management, followed by rehabilitation in a child. Thank you.
Thank you, Naina. And I think we have Dr. Ferenc Kuhn here, and he's the one you quoted. You quoted the terminology of mechanical injuries, the Birmingham eye trauma. He's the author, which is published in '96 and later in France Journal in 2004. So, can you comment, Ferenc? Can you give a mic to him?
Thank you very much. First of all, it was an excellent lecture. The only comment I have is that in the last couple of years, we moved away from excising the iris and not pay attention to this classic 24-hour rule. Instead, we look at whether the iris can be cleaned or it remains contaminated, because the iris has a lot of functions, not only beauty, but a lot of functions in the eye. So we try to preserve that as a diaphragm. So if it can be cleaned, which is the vast majority of cases, we will not excise it even if it's after 24 hours. So that's just a small comment, but again, overall, this was an excellent lecture.
Actually,
and you made all the right points about how to manage these very difficult, complex cases.
Thank you, sir. It's an exhaustive and extensive topic. I did not know what to, take in and what to, leave away. Thank you so much.
I think the main idea of this whole program, I know it's a working day, it's a weekday, but only day Dr. Ferenc was available. But I'm happy, thanks to Dr. Chaya Madam and the entire ophthalmologists of Bombay and Maharashtra for doing. But your conclusion was great. Educate, and that's the reason we are doing the meeting. And I'm also doing a public lecture every CME. I have a evening public lecture mainly to educate the public, because the public should know how can they prevent. And in spite of everything, I saw an excellent talk today we have. Only thing I have to talk, Ferenc, after that talk, what is the sports protective goggles which we can have, which is standardized? Because in India, we don't have any protective goggles, nobody is making. And we also not able to get regularly from the US certified or the Canadian board. I think Canada was having a certified preventive glasses for injuries a long time, even before US, I know that. But we are not able to get it, so I need some source so that we can ask some of them to stock it here. But I think the whole idea is to educate. Now you can invite the next speaker.
Yes, sir. Yes, sir. Now our guest now our next speaker is Dr. Charuta Mandke, Professor and Head, Cooper Hospital. Is Madam around?
Yeah, she's there.
Yeah. Yes. And she'll be speaking on approach to a case of ocular trauma, triage in any setting. Welcome, Dr. Charuta.
Hi, Charuta. So every professor here looks like a resident, except Ferenc. No? Ferenc is the father of ophthalmic trauma in the world.
Very lucky to have you here. Thank you so much for the organizers of this Polytrauma CME, Dr. Chaya Madam, Dr. Natarajan Sir, and Sion Hospital. I am very lucky to be here, and thank you for the opportunity. So without further ado, let me start. Yeah, I can do it from here, right? Yeah. So I have chosen a very basic topic which can be useful for all postgraduate students and also non-ophthalmologists, because sometimes this is seen in the casualty, the trauma, and by the time the ophthalmologist comes also sometime they need to know what to look for. So let's go on to it. We know what ocular trauma is, so I will not get into it. In India and globally, it is a big burden because it leads to a lot of functional disability, psychosocial impact, as well as economic burden. This is the basic classification of ocular trauma. We already know that, so I'm going to go ahead. We had this a few days ago, and this is something that came to the casualty, so they did not know whether the ophthalmologist should look at it or the surgery people should look at it. And a tertiary care setting, it's very it's good but that he reached in the tertiary care setting, and he is perfectly fine. So the primary survey has to be done. More than anything else, we need to look at, we do not only look at what is for us, as like Arjuna, in such a case, we do not only go towards the eye, we have to look at whether the patient is stable. So A, B, C, D, E, airway, breathing, circulation, neurological status, the Glasgow Coma Scale, and the environment or exposure, like whether there is any burning material on his body still, or whether there is any chemical on his body or eye still. So that is our first responsibility, to see that the patient is stable. Then we will go on to the ophthalmic examination. While we are doing everything, it's the patient we need to know what exactly happened. So we need to spend a few minutes in taking a proper history on what exactly has happened, because sometimes we miss very basic things regarding his environment or exposure. Then the visual acuity will be done. Then we do the periorbital assessment, and then we go into the eye and everything else. But for ophthalmology, once you have stabilized the patient and once you know that the patient is stable, the second most important thing is the visual acuity. So we do not go ahead until we know what the visual acuity is. It is not only important for us to prognosticate later on, but it's also important for us medico-legally, that we know what if he has taken any treatment earlier, whether the visual acuity has dropped since the trauma happened, and what he has come to us with. After we have done the primary triage, we will go in for investigations. Basically, if there is availability of slit lamp in the casualty, we do a slit lamp examination, because that will give us a lot of many details about what has happened, and we would be able to also check his intraocular pressure if it is a closed globe injury. And it is also important for documentation, because we need to know before we plan the further intervention. Fluorescein staining for any kind of leaks, or sometimes there's a partial tear, and of course corneal abrasions and the such. B-scan ultrasound if it is a closed globe injury, and then CT and MRI, depending upon whether there is a metallic foreign body or not. And for that we have already taken the history, so we kind of know what has gone on before he came to us. So the emergency management would be according to our classification: closed globe, open globe, then foreign bodies can be in both types, and chemical injury also can be in both types. So we'll go directly into the two types of globe injuries. The closed globe injuries mainly is corneal foreign bodies, hyphema, blunt trauma, blowout fracture, and also chemical burns. So For that, the corneal abrasions and foreign bodies, it's better if we have a slit lamp available with us, and we can also have fluorescein staining for that. We should know that we do not use topical antibiotics except patient is already in pain, and we have a little bit of a safety. We feel that we can do the examination better if we use topical antibiotics. It's better to avoid it if it's just a abrasion, and better to give cycloplegics for the pain. In hyphema, we need to elevate, we need to check the intraocular pressure so that we know whether it, and we also need to check on a slit lamp examination that how much is the hyphema, because on the basis of that we would know whether we need to treat it either medically, surgically, or we can conserve, and whether we can use certain types of medications. Also important to remember that we need to keep the patient of hyphema under close observation, because even if the hyphema was stopped on that day, we know that the next 3 days are important in case of rebleeding. Other closed globe injuries are blunt trauma. For that, we have already done the initial triage where we know how the orbital rim is, and therefore we would try to do imaging if it is possible, at least at the bare minimum an X-ray, and if possible a CT scan, so that we know that exactly where the trauma is. We also can figure out from a little bit of extraocular movements and the enophthalmos and other signs which can show us what's happening there. Chemical burns, time's up. Okay, so I'll just take a minute. Yeah. So surgical management, so at that point we would decide whether we want to do surgical management or not, what would be the indications, and also then prepare and say that we need to keep him fasting, we need to get investigations done, we need to get a basic fitness done with due risk, and follow up later on. Also don't forget that the patient goes away, you have done your primary job, but please see that you follow up, because you need to look at his psychosocial and functional impact and then disability. Thank you so much.
I want that one slide where you written emergency unless it's proven, no? The same slide. Yeah, okay. Ferenc, your comments. But Ferenc, I didn't tell him, but he will be the chief discussion, because I told him he's a what do you call, flowing river of knowledge.
Yes.
So we have to take as much as we can, because we are recording it, even though it's a weekday. So I hope parents will forgive me for the audience.
Thank you.
Where is Dr. Charita, madam? Chaya, madam, sorry. Charita is all the time in my heart. Charita's father and me are very close friends.
Okay. So when I look at an eye, I look at things that you have to do in seconds or minutes, and then hours, and then a little more than hours. Chemical injury is the one where literally every second counts, especially if it's an alkali injury. Every second that elapses between injury and the start of treatment will result in damage, and many of these damages will be permanent. The minutes and hours is endophthalmitis. To me, endophthalmitis is a surgical condition, and that's true absolutely for trauma, and for me, mostly also for post-surgical endophthalmitis. I do not follow the endophthalmitis vitrectomy study recommendations, which argues for injections in the majority of the cases. And then we come to the open globe injury, where it's hours or days, and I will have a talk about this later on, where I emphasize the importance of very early intervention in those cases too. And when I say early intervention, it's not only wound closure, it's the intraocular reconstruction, where we have to pay attention to early intervention. If you have a closed globe injury, you typically have weeks to make a decision. But if I may make an additional comment, when you talk about triage, it has the word has several meanings. And for me, one of the most important meanings, especially today, when a lot of places in the world sees active conflict, war and terrorist attacks, where you have not one or two injuries coming to your department a day, but tens, if not hundreds. How do you decide which patient will go to surgery first and which can wait? That's a very difficult and complex question, which I don't have time to go into. I'm just saying, unfortunately, if you have an emergency department for the eye, you have to develop a plan what to do if you have so many patients coming with an injury. But your talk was wonderful, covering everything beyond this topic.
Thank you.
It's very, very, very important to pay attention to all those things.
Ferenc, we would like you to be there, and can I ask Ferenc to give the certificate and the memento to them, plant. They will remember you, so they want a picture with you, each speaker.
Okay?
So you can be there. So Charuta first. No, you go down and you collect your food. No, let them be there. You're going to be in the next session. Thank you, Ferenc, for doing the honors. And to Dr. Naina. So Ferenc, there's a medical college called Cooper Medical College, and she's the professor there. And next you have to give to Dr. Naina, which is another medical college. Here all the professors are here. The students, only Nair Medical and Sion are there. I hope they may be doing duty. Mayur, next you can call. Yeah. Whenever Chaya madam is here, we will give it. Right? I don't know, where is madam? Where is Chaya madam? Outside. But can you call her inside here? Where next talk we can give the certificate to her. And I also want to talk to her.
Next we call upon Dr. Usha Johari madam, and her talk is on birth trauma.
A very good morning to all of you. It gives me a great pleasure to talk on this platform, and thank you organizers for having me here. So it's a very unusual topic that's been given to me, that this ocular issues resulting from birth trauma. So there is always a tremendous pressure when the baby is passing through the birth canal. It could be a mechanical or an hypoxic injury. The commonest is the head injury and the brain hemorrhage. So what are the neonatal birth injuries? It could be the fetal presentations, like the child head could be very big. That's a macrosomia. It could be a breech presentation. It could be a transverse presentation. Or, there would be prematurity, or due to some reasons, there could be a precipitous delivery. And most important is the delivery mechanisms, which could be because of the instruments that we are applying, for forceps delivery, vacuum extraction, or sometimes both. And the maternal factors, like a person, who is multigravida, her age, and the number of pregnancy. And the most important thing is the pelvic anatomy. So in our country, institutional births are definitely going up, but the home deliveries are still a norm. So we all understand that the brain cells cannot regenerate, cannot repair, and asphyxia, especially to the brain, is a very short window to treat. So isn't it important for us to intervene early so that, we prevent the further damage? Of course, the mild damage like black eye, subcongenital hemorrhage can recover well, but severe damage require a lifelong treatment. So 2 in 1,000 premature babies suffer from higher risk of brain damage. 3 in 1,000 full-term babies suffer brain damage. So I have shown here the vacuum delivery, where 75% of these children have retinal hemorrhages, which is quite surprising. Mechanical forces sometimes by the professionals and non-professionals, and of course the forceps delivery. So you'll all agree with me that human brain is such a wonderful magical organ that begins forming prenatal 3 weeks after the conception. And you'll be surprised to know that 60% of all energy a baby expends is concentrated in the brain. The brain develops faster from birth up to 3 years of age. Imagine if the baby grew at the same age as brain, the baby would weigh 77 kgs at 1 month of age. So by the age of 3, the brain has formed 1,000 trillion connections between neurons, and the child's cerebral cortex creates 2 million synapses every second. Now, brain injury is, the third top disability worldwide, and the current annual rate of brain injury is definitely greater than problems like breast cancer and so on and so forth. So did we know this? No, I did not know it. And the traumatic brain injury in a child is because the child has a heavy head, the skull segments are still forming and fusing, the skull segments are thinner, so obviously when they're thin, the protection is less, and the brain is still in a developing state and continuing to make important nerve connections. So brain injury is more severe in a child. What are the bumps during the birthing process? There could be soft tissue injuries, there could be nerve injuries, there could be head injuries, and there could be fractures. So uterine dysfunction and the fetal, large or small, can cause this. Bell's palsy we are all very well aware of. It could be a direct pressure due to the forceps, blades, hemorrhages, and there's a pressure on the ramus of the mandible or promontory sacrum or the ischemia, causing facial asymmetry. But it's a condition which has an excellent prognosis, and in 2 months the child recovers, and 10 per 1,000 live births have this kind of a problem. Now the types of hemorrhages are different types depending on the layers which are involved. It could be a subgaleal hemorrhage, it could be caput succedaneum, and so on and so forth. And this hemodynamic instability leads to a hemorrhage, which was told way back by Toner et al. So intracranial injuries, there could be a fracture, which is very common, a depressed skull fracture, the parietal bone fracture, due to forceps or skull pushing against the maternal symphysis or the ischemia. The countercoup injury, which a childhood acquires, and this childhood brain injuries are most of the time not reported, not treated, and they're acknowledged. And remember that there are few of them last all their lives. So a countercoup injury is nothing but when there is an injury to the brain strikes on one side of the skull and then bounces back, which can cause serious damage to the neurons of the brain. Neural plasticity we are all aware of. There could be a positive side effect and a negative also. The positive being the brains are more open to learning and embracing enriching influences, but the negative side is, should there be any environmental prove unsafe, the brains are more vulnerable for developing and behavior abnormalities. So coming back to what is cerebral palsy, which is very common, undetected. It's a disorder of movement, posture resulting from permanent non-progressive defect or lesions of the immature brain due to perinatal brain damage. And thanks to our neonatologists who are taking excellent care of these babies, therefore the incidence is increasing. But what are the eye problems on which we are working? There is visual disability, which is ignored, overlooked. It's still a social stigma, lack of education and economical support, which relates to description of the limbs and limbs involved. Late detection of eye problem is very, very common in our country. So let's all think about this problem. It's a multidisciplinary specialty where it's not just the ophthalmologist. There are so many other specialists involved in this: orthopedicians, pediatricians, neurologists, psychiatrists, OTPT therapists, speech therapists. Most important, the parents and the children. So I would conclude saying that we alone cannot do anything. It's a multidisciplinary specialty, and the take-home message is prevention of birth injury. So this is a child who is wheelchair bound and just tells that I cannot speak, but does not mean that I don't have anything to say. So visual rehabilitation following brain injury is still in its infancy, and there's still a lot to learn. And the idea of being here is that we run this NGO called as the Global Vision Brain Alliance, where we are trying to detect the ocular anomaly, record the visual capacity, treat these visual problems which are neglected, and overcome the visual handicap well in time, and facilitate. The most important thing is facilitate overall rehabilitation and development. Thank you for your attention.
Thank you, Usha, and congratulations for your foundation what you made. And Usha is a past president of BOA. So, and the answer to Ferenc's point, and I think we didn't have a strategy, we didn't have planning when the Kashmir injury happened, but I think the dean, that time Dr. Kaisar and Dr. What's his name? Tariq Qureshi, the head of the department, I think they were amazing. They had 25 ophthalmologists in the faculty. So there's a Sion Hospital, Chaya Madam. Sion Hospital is a trauma center because, as I told you yesterday in Mumbai, this was suburbs of Mumbai one day, but now it's the center of Mumbai because this was close to the highway. And even now it's close to the highway. Every time we go, we cross Sion and go. So any road traffic accident, they bring here. So that's why repeatedly I'm doing this polytrauma and ophthalmic trauma as a combination. And I'm requesting ISOT to make a guideline along with the APOT and the OTSI. So it should be a global thing that what should be the, as you rightly put it, when there's a bodily injury with eye injury, which comes first? Which first is saving the life. But at the same time, the resident ophthalmologist, whoever is here, first year, second year, whoever, I can go and examine the eye when they are doing the neuro examination or neurosurgery. But I know, I don't remember whether it's this hospital or the neighboring hospital. The patient was in coma, they did the neurosurgery. 1 month nobody examined the eye. And I don't blame them because that time they were not aware. So now I spoke to the Benares Hindu University, which is a big university in Varanasi, All India Institute and Sion. We are trying to talk to the emergency and trauma head to make this as a, what should be the protocol for when there's an eye and total body injury with brain injury, what to be first, and simultaneously I'm recommending there has to be an ophthalmologist. So Justin Grant, the current president, was asking, do you mean to say every injury? I said, why not? Because every big hospital, private practitioner will not do. An American question I understood because if I go, will I get my consulting fee? But that's why I said university hospital can lead, but in a private hospital, from my side, we are 24/7 ready, my faculty is ready, and I am now trying to motivate our 200 groups. So that's the answer. So I'll request you to give the certificate to Dr. Chaya first, and then to Dr. Usha. You have some comments?
Yes, sir. I just wanted to share one good thing, that we at Nair Hospital have started a new building called as the Early Intervention and Rehabilitation Center, where we have a neurologist, pediatrician, occupational therapist, physiotherapist, ophthalmologist, everybody to examine and take care of children who are less than 12 years old. So this is a unique center and it is free of charge. So I just wanted to make everybody aware that their patients can avail the facilities there. It is at Mumbai Central. Thank you. And I really like what Madam has been doing this. It's a different venture. Congratulations. Thank you so much. Thank you.
And I think from all the talks, we talked about psychological trauma to the patient, and I think you spoke about it. So I am actually trying to get a counselor all the time. Anyhow, I refer the patient to a psychologist because most of the children are depressed, and then they lose their studies and everything. So I keep motivating them by sending to a psychologist. And I tell the parents, sending to a psychologist does not mean he's psychiatric. And I said, tell them, even if you meet a psychiatrist, don't take medicine, but counseling is important. Because first they have to get rid of the guilt that injury has happened, and I will not. All the cricket ball, somehow I lost my data. Cricket ball injury, the children never tell the parents because they are afraid of punishment. So they come 6 months later, and I made a special thing that the ball bounces and the eye has that Bell's phenomenon, the eye look goes up, and the ball hits the lower part of the 6 o'clock meridian, and there is a ragged retinal tear, and that's a characteristic which we should call it my whatever sign, but somehow maybe I have to rethink the cricket ball injury. And all the injuries you see, 6 o'clock break with the old detachment, it's an injury. And many times I coax alone with the child, and then the child will say, yes, I had an injury, but I didn't tell the teacher or the parents because they will scold me. So, Ferenc, your comments and certificate.
Thank you.
This is really a very important issue because if you have polytrauma, it is obviously not the ophthalmologist who will see the patient first. And clinical experience tells you that the trauma surgeon or the emergency room physician who treats the patient will not look at the eye, because all the other injuries are more obvious. And the eye is so small. So if you do nothing, you don't tell them, you don't educate them, your colleagues, about the importance of one, look at the eye, and two, look at the eye early, then it will be neglected until it's very late. So this is a wonderful, another wonderful initiation of making your colleagues aware of the fact that the eye should be on the very high on the list of priorities. If I may make one comment, I'm not an expert obviously in this, but I want to tell you, because this story is not only personal, but it tells you a little bit about how biased we are. So when my wife was pregnant with our second child, she needed to undergo an amniocentesis. And back then, there was no ultrasound. And the needle went through the belly. And when I heard that this was necessary, fortunately, it was not necessary in the end, I remember my very first thought was a needle will go into the uterus where the baby is. And what if it hits the eye? So I asked, the gynecologist, and the answer he gave was this: the baby will swim away. And that was the only reassurance we had, that the eye would not get injured. It wasn't, so it was a happy ending. But the point here is that we are biased towards the eye, but there is a rationale behind that bias, which I probably don't have to tell you, but I will, is that roughly 90 to 95% of the information from outside the world comes to us through the eye. And it's something good to consciously remember, because that explains why we want, again, the emergency, trauma, etc., colleagues be aware that the eye should not be the last thing. So the first that needs to be done to these patients, obviously, is the life-saving interventions. If you have a major chest issue, but the eye should come right after that, not, the extremities, etc. So again, your education efforts towards our colleagues is a wonderful thing to do. Okay?
So Ferenc, you'll be surprised to know I did 122 amniocentesis, and that time I was only a resident and finished my MBBS, and I did a study called for a respiratory distress syndrome. My professor of gynecology gave me that when I was a medical student, and then I don't know how, and this was my worry because there was no ultrasound, and I asked my assistant professor at that time, I was on the duty, I said, how do I do without injuring the child? No, the uterus is big, and then amniotic fluid is quite a lot, and don't worry, it'll nothing, and you go this much, nothing will happen. And anyhow, touch wood, we followed up all the 122 pregnant women after the amniocentesis with the delivery. All the children were normal, and the respiratory distress syndrome, whatever we diagnosed. That time we did a test called shake bubble test. We take the amniotic fluid, put it in the alcohol and shake it, and then you see if there is a thing which we can diagnose RDS to decide on cesarean. And all the 122 were normal. Fortunately, the child, but it was a blind method. So I learned from my father, being a professor, he said, in ophthalmology, nothing is a blind procedure. So don't take gynecology, take ophthalmology, he said. Then when I took up ophthalmology, if the foreign body went behind the iris, there was no way to find out in those days with no ultrasound. And we had this giant magnet. And then I remember assisting my professor, and he put there, suddenly, I don't know what happened, you're supposed to remove the speculum, all the instruments around. Yes. I don't know who, he was placing the magnet, and suddenly somebody on the electromagnet, everything, including the drape, and except the foreign body, everything came into the electromagnet. But anyhow, jokes apart, I think we learned, fortunately, we learned tissue care, but all was a blind procedure. But now we have endoscopy,
Yes.
we can see well with indirect ophthalmoscopy. And again, I quote, I forgot the author's name, what the mind does not know, eyes do not see. So that's very important for ophthalmic trauma management. We have to be aware, and I'm glad we did this today. So now, Chaya madam, we want you to take the certificate. Chaya madam, and everybody should clap. Madam, we want you to call the principal of nursing college to fill the hall, and they also will benefit in assisting the ophthalmologist. Ferenc, you have to give the certificate. Madam? Yeah. The next speaker is Dr. Twinkle. You can be there by the time. And next, thank you, Dr. Chaya. She did the entire program. Thanks to her, she spoke to every speaker, and thanks to her for the total management. And next is Dr. Usha Johari. Ferenc, one more. Dr. Usha Johari. And Dr. Usha Johari's husband is a pediatric orthopedician, works till 3 in the morning. So our co-chair, Dr. Twinkle Chokshi, is the next speaker. And Ferenc, Twinkle is a great teacher for extracapsular and small incision cataract and phaco. So Matthew did a fellowship at IIT Jodh, and he made a beautiful video. I don't know whether you've seen that video. Maybe one day I'll show you. And which Matthew Forlini has done, and Twinkle has trained. And Matthew was looking like a giant, and Twinkle so small, but she was the teacher. And she is now the additional professor along with Dr. Naina Madam in Nair Hospital. Yes, Twinkle.
Thank you so much, sir. I have grown up learning the Kuhn's classification and reading your books in my residency. It makes me so nervous to speak in front of you. Correct me if I'm wrong somewhere. At the outset, I would like to thank the MOS, the Ocular Trauma Society of India, Dr. Chaya, Dr. Natarajan, and most importantly, Dean Nair Hospital and my head of the department, Naina Madam, for giving me the opportunity to speak here. So my talk is about corneal tear suturing techniques. It's quite basic, and it would be helpful for most of the residents, where they can interrupt me, raise their hands and ask questions if they have. So we have been doing a lot of CLW repairs without much of training. So why so much training is required when we are suturing the cornea? It's because of inherent lack of elasticity, and the cornea cannot really, the tissue of the cornea cannot stretch like that of the skin. And we need to have a perfect apposition of the edges in order to have best visual outcome, to minimize the topographic changes of the cornea, minimize the scarring of the cornea, and make the wound watertight. So the first and foremost, as emphasized by earlier speakers, is to examine thoroughly. If required, we could put a drop of topical anesthetic and examine the damaged parts, see whether there are any collateral damage. And it's important for a corneal tear suture repair to classify whether it's a straight tear or whether it's a shelving, because in the suturing techniques in both of them are quite different. So what suture should we be selecting in order to suture the cornea? We have absorbable sutures like Vicryl Rapid, but they cause a lot of inflammation, increased scarring, risk of infection, and there is a short duration of tissue support. And hence we prefer a non-absorbable suture, in which we have options like nylon, polypropylene or polyester. Nylon is the one which has least memory. It's more pliable and it's easiest to handle, and hence the choice is nylon. When we talk about nylon, we have options of to use either braided or a monofilament. So in order to have decreased scarring, decreased risk of infection, we obviously choose the non-braided sutures. And as the numerical indicator increases, we all know the width of the suture decreases and the suture becomes more fine. So 9-0, 10-0 or 11-0 are good choices when we are suturing a cornea. Another thing which we need to really know before we start a corneal suturing is the anatomy of the needle. What is the switch? How is the suture really put into the switch? Which is the area which is after the switch where we should be holding with our needle holder? And what is the radius of the needle that we should be using? So a lot of needles are available, but the choice for corneal tear repair is the spatulated one, which is down. Do we have a pointer here? Do we have a pointer? Yeah, so at the extreme bottom, towards the left, we have the, yeah. So this is how a spatulated point would look like. And then we can either choose the half circle or 3/8 circle depending upon how long is the suture length that we need. Now suppose if we consider that we are suturing a perpendicular tear or a straight tear. So we all know that it should be at 90% depth. Now why should it be at 90% depth? Is because if there are shallow sutures, then that will cause wound gape at the inner part of the tear, and if these sutures are quite deep, they can actually act as a conduit for the microbial invasion and subsequent endophthalmitis. Again, it should be symmetrical on both the sides. So if it's deep on one side and if shallow on the other side, then it can result in an override, and the subsequent anatomy can be seen on ASOCT, which could be something like this. That can cause a lot of, though the tear repair looks quite clean, but it can cause a lot of visual problems and refractive error problems. Also, when we are starting to suture a corneal tear repair, if it's a little old, like say more than 12 hours, we see that the edges are edematous. So it's important so that to tighten the suture so that the edges are a bit pouting, because as the edema resolves over the next couple of days, then we see sometimes that the suture gets loose, or there is a possible devote in the tissue, and that's why it's important to keep the edges a bit pouted. Now, how to repair shelving wounds? As we know that when we pass the needle, it should be equidistant from both the ends. However, if it is a shelving wound and we keep it equidistant on both the sides, then here is what we are going to get is a possible override and a mismatch. Okay, there's a lot of it remaining. So it's important that we should have equal on both the sides at the inner edge of the tear and not at the outer edge of the tear. Again, these shelving wounds sometimes is a bit difficult to identify whether they are full thickness or partial thickness. So ASOCT is a really important tool to find out what exactly it is. The shelving wounds can sometimes be a little beneficial as compared to perpendicular wounds, because they have a long cross-sectional area and sometimes they are self-sealing and we do not need a suture. So how do we make out whether we need a suture or not? Is either we can first do a seal test and find out if there is a leak. So if there is a leak, then we surely need to suture them. And second is we draw an imaginary line joining the two ends of the shelving corneal tear. Now, if this line lies in the area of the shelving wound, then we may not suture it. It could be self-sealing. However, if the line is outside the area of the wound, then we definitely need to suture that tear. Okay, so another thing is that sometimes we come across with stellate corneal tail lacerations, like a bow and arrow or with a pencil. And then the best thing which we can do is take a horizontal mattress suture or a purse string suture. So personally, I have not tried many purse string sutures because I find horizontal mattress suture a little more easier. This is a video showing that tear repair of stellate corneal laceration. We see that the wound is quite edematous. We take out the necrosed tissue. We may send it for a biopsy. So I would require your permission if we can continue, or I can stop here. I think at the end of the video is 1 minute 41 seconds. Yeah. So that's how we take a horizontal mattress suture. It's important that we hold the edges of the suture with a non-toothed forceps in order to prevent the trauma to those wound edges. Yeah, so this is a kind of a horizontal mattress suture. Which then later we take 3-2-1 or 3-1-1 knots and close it, and then subsequent tear repair of all the other 3 edges could be done like how we do normally. So this is a little bit of a diagram which is how a purse string suture looks like, but because of shortage of time I think we'll skip rest of the presentation, and thank you for your patient listening.
Thank you, Twinkle.
Thank you.
So I request, Ferenc is going to give a talk on the rules of suturing corneal wounds.
Oh.
He's a vitreoretinal surgeon, but we are from the era from pole to pole surgeon. But from my side, I take my anti-segment surgeon like you and Kavita, whoever is with me, to our Dr. Smith, to do the anti-segment. So your comments, Ferenc, and because she's an excellent cornea surgeon, but you can, I believe the surgery was done yesterday only.
Yes, so I am a vitreoretinal surgeon. And if you do vitrectomy on an injured eye, you want to see clearly what you're doing. And therefore, in the last 25, 30 years, I spent a lot of time changing the way we suture corneas. So my technique is very different from what you saw. What you saw here is the traditional approach. Mine is completely different. So I don't want to go into the details because I will have, after the break, a fairly long talk about some basic rules of mine in corneal suturing. But what I want to mention here is something more general. Very often when you talk to a patient about the upcoming surgery, the patient will say, "Can you guarantee success?" What do you answer? Who says yes? That's good. Who says no? Okay, what about the rest of you? You say nothing? You have to answer the patient question. So what I tell my patients, I cannot guarantee success. Because things can go wrong during surgery, things can go wrong after surgery. And also you have to make a distinction between anatomic success and functional success. And we, all of us who do surgery, have to understand we restore anatomy, not function. We hope that by doing a good anatomical reconstruction, function will follow. But this is a crucial thing to keep in mind. You cannot work on function, only on anatomy. So getting back to the cornea, you want to restore the cornea to as close as the original uninjured cornea was as possible. And if you do that, then the cornea will not interfere with that patient's vision. But for that, there are many rules. So I have a 2-hour course on corneal suturing, which, as I said, I will try to summarize the most important points in 20 plus minutes shortly. Okay.
You can give the certificate. And can I invite Dr. Mansi is the next speaker? Oh, you're doing no. But Mansi, you know, you can introduce her.
So next speaker is Dr. Mansi Pathak. She's a vitreoretinal consultant at Aditya Jyot Eye Hospital, and her talk is on traumatic macular hole.
Good morning, everyone. This is my first talk here in Mumbai as a consultant. So if at all I make any mistakes, kindly pardon me. So I will be talking about traumatic macular hole. We have discussed a lot of things today about emergency ocular trauma conditions. Right now, we will be discussing about a traumatic macular hole, which is not an emergency as such. I will be discussing about the etiopathogenesis, clinical presentation and management of traumatic macular hole and how it differs as opposed to idiopathic macular hole. The most common cause of traumatic macular hole would be closed globe injuries followed by open globe injuries. Other causes include laser pointer injury, which can also cause a macular hole, iatrogenic trauma, lightning strike, and shock with electric current. So the pathogenesis of traumatic macular hole would be slightly different as compared to idiopathic ones, because there would be a countercoup mechanism involving axial shortening and equatorial expansion, leading to vitreomacular traction and subsequently a macular hole. Another pathogenesis that has been hypothesized is in cases with commotio retinae, there could be a permanent loss of photoreceptor layer leading to a macular hole. So how are these traumatic macular holes different from idiopathic ones? The idiopathic macular holes are mainly seen in elderly women in their 60s, while the traumatic ones would be commonly seen in younger male individuals, and they can develop immediately after trauma, as opposed to the idiopathic ones which would lead to a gradual progressive loss of vision. And in traumatic macular holes, there can be associated findings such as choroidal rupture, submacular hemorrhage, Berlin's edema. And these macular holes are eccentric and less circular. So the question is whether to treat or to observe traumatic macular holes. So there have been various studies and meta-analysis in literature which have shown that traumatic macular holes, majority of them close spontaneously, especially the smaller ones have higher chances of spontaneous closure, around 35 to 50% within a period of 2 weeks to 12 months. So how do we know which traumatic macular holes will close and which would not? So Shen et al. Have conducted a study about the OCT findings in traumatic macular holes, and they saw that holes with spontaneous closure were less likely to have intraretinal cyst or intraretinal fluid spaces as compared to the holes that couldn't close spontaneously. Medical management is one of the options. A few case reports have shown use of topical NSAIDs to be effective in closure of smaller macular holes with fluid. And lastly, the surgical management. So it would be same as the idiopathic macular holes. However, the larger or refractory traumatic holes would need other adjuvants such as plasma concentrate or amniotic membrane grafts or a retinal autograft. So this is a case which I have seen during my fellowship and operated during my fellowship. It was a 20-year-old male who came to us with chief complaints of diminution of vision in right eye since 6 months. He had history of trauma to his right eye with a tennis ball 6 months back. His right eye best corrected visual acuity was 20 by 125 and anterior segment findings were unremarkable. He had a full thickness macular hole in the right eye Left eye was within normal limits. So the OCT showed a full thickness defect in the neurosensory retina, and it was the minimal linear dimension that we commonly use to gauge the prognosis and which technique we could use for ILM peeling. It was 320 microns. So this is a surgical video. There could be few flaws as it was operated by a fellow, that is me. 25 gauge ports were used and core vitrectomy was done. In young males, the induction of PVD would be challenging as opposed to the idiopathic holes. So tricot assisted PVD induction is a better method. Vitrectomy is completed, and it is important to examine the periphery in any retinal cases, but especially trauma cases, to look for any dialysis or tear. Brilliant blue-green dye is injected to stain the ILM, and here I am using a pinch and peel technique to peel the ILM. So one flaw here would be that the magnification is low. The ideal magnification would be as such that just the arcade is visible within the macular lens, which we use while peeling. And another thing would be, it is like a capsulorhexis, so you have to hold closer to a flap. So this would be the ideal magnification. After this, fluid air exchange is done, and I have learned something from my mentor that it is better to dry the edges of the peeled ILM to ensure that there is no fluid around the macular hole when we are about to close the case. Then 18% SF6 was injected. I prefer injecting SF6 over C3F8 because if the hole has to close, it will close in 3 days' time. It is important to check the globe pressure before closing the case to ensure that the globe is not very tight. And at post-op 2 weeks, the vision improved to 20/80. We can see that the hole is closed with a photoreceptor layer, which is discontinuous here on subfoveally. So take clinic message would be that majority of the small traumatic macular holes can close spontaneously, and always examine the retinal periphery with scleral depression in any case of ocular trauma. Large and refractory holes might need adjuvant agents or modification of the surgical treatment. Thank you everyone for your patient listening.
Wonderful talk.
Thank you.
And I would like you to come down, and I would request Dr. Kuhn to give the memento and the certificate to Dr. Manasi.
So first of all, beautiful surgery. And you raised the most important question about traumatic macular holes, which is with an idiopathic, you really should do surgery because they will not close spontaneously. A traumatic macular hole has a chance. The problem is it's really not possible to truly accurately predict which hole will close or not. So you can look at statistics, but when you have one patient in front of you, statistics means 20% yes, 80% no. Is it really helpful for that patient? So this is something where you have to, this is one of the many instances where you have to sit down with the patient, tell the numbers, and let the patient make the decision. I act on the side of early surgery because when we hope the hole will close and it doesn't, you lose time. Another very important thing which is also something you mentioned, most of these eyes, traumatic macular hole, will have additional pathology. Commotio retinae, which is a nice way of describing death of cells, as you mentioned, but you can have hemorrhage, you can have choroidal rupture, So the question is, will the closure of the macular hole contribute to visual improvement or not? And the answer is we don't know, because even if it's only one pathology, you just have a statistical number to answer. But if you have several pathologies present, you don't know which part of the pathology contributes how much to the visual loss. So what I tell my patients is that surgery has a chance to restore the anatomy, as I mentioned before, but because you have other factors contributing to the visual loss, it's really impossible to say that the vision will improve after surgery. If you don't do surgery, you probably will not have a chance. If we do surgery, we'll give the eye a chance, but we don't know whether the eye will use that chance or not. Okay?
I would request Dr. Muskan Lalwani to please come on the dais. Dr. Muskan is a first-year junior resident at LTMMC Sion Hospital. So, Dr. Muskan, over to you for your presentation on protective wear and ocular trauma.
Morning, all respected doctors. So I'll be discussing on a very basic but yes, a very, very important topic on how does protective wear help in preventing ocular trauma. So ocular trauma poses a significant public health concern, and it can range from various workplace accidents to sports related injuries with potential consequences which can lead from complete recovery to irreversible blindness. Also, ocular trauma is a leading cause of preventable blindness. So, individuals can significantly reduce their chances of experiencing ocular trauma by understanding the potential risks and taking proactive measures. Ocular trauma encompasses a wide range of injuries, from minor irritations to corneal abrasions to more severe injuries such as penetrating wounds, blunt trauma. So, what does protective wear help? So the role of protective wear is first to prevent ocular trauma. If ocular trauma is prevented, there is also preservation of vision. So prevention of ocular trauma includes preventing the damage to the eye and surrounding structures, which can result from various accidents and incidents, and preservation of vision. Ocular trauma can lead to partial or complete loss of vision, and using protective wear aims to minimize the risk of such outcomes. So what all protective wear we can use? It includes safety goggles, spectacles, face shield, welding face shield. So safety goggles, they are tight fitting eye protection devices that completely cover the eye sockets and the facial area around the eyes, which provides protection from impact, dust, mist, splashes, and thus prevents from foreign body damage to eye. And these safety goggles can also be worn over prescription lenses. They are available with perforated, port-vented, non-vented frames, and they should be worn while working with liquids that may splash, or if vapor or airborne particulate protection is required. Safety glasses or spectacles, they specially refer to protective equipment that closely resembles our common eyewear. To meet the most national standards, spectacles must include side shields to reduce the ability of debris to get behind the lenses from the side, and they can often mount insert frames to mount prescription corrective lenses for users with suboptimal vision. And such insert frames can be mounted behind the protective lens. Sunglasses. Now sunglasses offer protection against excessive exposure to light, including its visible and invisible components. The most widespread protection is against ultraviolet radiation, which causes short-term and long-term ocular problems such as photokeratitis, cataracts, pterygium, various forms of eye cancer. Medical experts advise the public on importance of wearing sunglasses to protect the eyes from UV. Face shields. Face shields provide general protection to the entire face from various hazards such as flying debris, chemical splash, arc flash, UV radiation, extreme heat. One of the most advantage of face shield is that it can be worn over primary eye protection like safety glasses or goggles when there is potential exposure to flying fragments or objects, potential splash from molten metal or extreme temperatures. Now welding face shields. Here, during our casualty and on-call days, we have many patients who come with foreign body and eye during welding. So welding face shields can be worn and they act as a first-line defense against various dangers associated with welding, most notably the intense brightness, spark, harmful ultraviolet and infrared radiation emitted during the welding process. And its primary purpose is to protect the welder's face and eyes from these elements. So overall statistics on protective wear and ocular trauma, which from the recent studies, it shows that 90% of ocular injuries can be prevented with using appropriate protective wear, and 100% of the sports related injuries can be prevented if, like for example during basketball or golf or other sports, if protective eyewear is worn, injuries can be minimized to 100%. Workplace injuries. 75% of ocular injuries in industrial settings are due to metallic foreign bodies, with 67% requiring surgeries. And welders' eye protection, if till date only 43.6% of welders use protective eye consistently. So to summarize, occupational work with chemicals, metals, lasers, UV equipment and other high-risk exposures requires eye protection, which should be supplied by employers. So workplace mandated protective wear can essentially eliminate the incidence of workplace injuries, and public should be encouraged to wear appropriate eye protection for activities that pose a risk of eye injury. And protective wear includes safety glasses, goggles, face shields when working with tools like chemicals or machinery or participating in sports like hockey or paintball. These are the references I've used. Thank you.
Thank you, Dr. Muskan. That was an excellent presentation, and we would like now invite comments from Dr. Ferenc, and I would request you to please receive the memento from sir.
Can I ask you to put up your hand if you're smoking? Are you? Because you did this. Nobody in the room smokes? Really? Okay, but you all, I know somebody surely smokes but does not want to put up the hand. But you all know a colleague who smokes, right? So do you think that that colleague does not know that smoking causes cancers? Of course they do. So why do they smoke? Because the answer to this question is a very important one. Anybody wants to take a... It's a what? It's a kick, yes. But that's not the answer I'm looking for. So the reason why, despite knowing the risk, they take the risk is because they subconsciously think, I know it happens, but it will happen to her and not to me. It's very similar when you talk about prevention of eye injuries. Many people, not everybody, in many situations, not in every situation, know that whatever they do has some risk injuring the eye, but they still do it. And then there are those, of course, who don't think about it. So let me tell you a story of mine, which also tells you a little bit about how Albert Einstein's very famous statement about humanity is true. Do you know which one I refer to? He said, there are two things that are infinite. One, the universe. Two, human stupidity. But I'm not sure about the first. So I had a patient who had with an intraocular foreign body, and as usual, after the surgery, I said, of course, he was hammering under a car because he was a car mechanic. And so after surgery, I said, why did you not wear eye protection? Is it not mandated at the workplace? And he said, yes, it is. So I said, how did you get the injury then? Did you take it off? He said, no, I was working in my home garage. So the reason he's not wearing eye protection is not because he knows about the risk, it's because the boss will hit his head if he doesn't. But not because he knows that there is a risk at home too, so at home he doesn't. So my point is, education of the public and our colleagues is very important, but you have to fight human stupidity there too. And let me just tell you one last example of human stupidity. I'm sure you saw videos of the world's most boring sport, the American baseball. So if you look at the baseball player who's wearing a helmet, the helmet is like this because it protects the earlobe, but nothing protects the eye. Okay?
Thank you, Ferenc. And one managing trauma, so that's why the topic is fine art and science of managing ophthalmic trauma passionately. But the entire idea of doing this CME and the evening public talk is to prevent injuries, because if you prevent, there should not be any work for us. But that's not going to happen. That's why we have to educate, as Dr. Charuta mentioned, educate. We have to educate ourselves, educate the colleagues, educate the family. But I don't know whether you read the iWiki recently, few months back. They had the newsletter in American Academy, an ophthalmologist who's very particular wearing protective goggles, has some collection of 100 protective goggles, and he was wearing a protective goggles and cutting the tree in his backyard, and one branch flew the protective goggles, second branch cut his cornea, and he didn't realize immediately, and he had 6/6 vision. I think he checked like that, and few hours later he found something cloudy. He went to the ophthalmologist, and they've done a repair and got it 6/6 back, but he had a subtle tear. I don't know how it happened, conjunctiva and sclera, and nothing in the cornea, but it happened, like one threw the goggle away and the second came and sliced the conjunctiva and sclera. So occult scleral tear is a problem, and many times sometimes they have an injury, they should not squeeze the eye. Better go to an ophthalmologist, and I always tell, just don't send me WhatsApp photo and ask my opinion. Please come or go to an eye doctor. And so this is what the eye is protected. If you've seen the evolution of eye from the animals to the human, the eye is protected from direct injury by lids, eyelashes, and if you see the frog's eye, the elephants, the tiger, all are hanging this way because they have to see the predators. But here, the things have come in, but still we find a successful way to injure the eye. Nevertheless, it can be injured in a varieties of ways by chemicals, heat, radiation, and mechanical trauma. And it's a #1 ocular emergency, and I'm directly going to this is a 76-year-old male who actually did not want to disturb his wife in the night, father of a IAS officer. He is retired now, the principal secretary of Maharashtra at that time, and he had an open globe injury because he was going to the toilet and poked his eye in some sharp object. The thing went in and he had an iridia, aphakia, vitreous hemorrhage, and his vision was. He was operated for the wound repair in the locally, and then it was in Lucknow, and he came to Mumbai the next day. And you can see this is the, I think the video is, 1 second. So this was my editing has been done. So I did the wound repair, I did the tagging. I think that was a mistake. I anticipated expulsive hemorrhage, so I injected viscoelastic to make sure the eye is firm, and I used this scleral buckle with that band, but I think that was a mistake. But in spite of all the experience, I think you can make a judgmental mistake. That's why Ferenc Kuhn all the time says no dogma should be involved. You should have a evidence-based medicine. And I'm doing vitrectomy, and then I tightened the buckle, but you see a mound happening. So I, first thing as a vitreoretinal surgeon, thought it was a infusion line mistake and suprachoroidal infusion, but I think the brain didn't recognize it was an expulsive hemorrhage happening. And it happened in my own hand, and then I didn't panic, but I injected oil, I injected air to make sure that everything doesn't come out. I removed the band and then left it because there's no point in having the band, and closed the wound and left it, and then waited for 2 weeks. And then because nowadays Ferenc Kuhn, and he recommends, and after that we recommend, and we successfully did that in Kashmir, where he says the first 100 hours, that means initial repair should be done the same day, and then the second surgery should be done within 6 days. But this eye, the eye was swollen, and we gave steroids and waited 18 days. That was 10 years back. And so I have to go back to the video again. So this was the 2 weeks later. So you can see the eye was quiet, and you can see I directly went with the 23 gauge ports, and then you can see the vitreous lavage happening once I did because there was no vitreous there. I cleared all the vitreous hemorrhage, and then I see large retinal tear because of the expulsive hemorrhage was happening, and I made sure the infusion line is inside the vitreous cavity. I cleared the subretinal space, and I see the heavy oil which is there in the subretinal space. I don't know how it went, but it was you can see the last bubble being removed, and removing the pre-choroidal hemorrhage, the surface hemorrhage, and then teasing the blood from the posterior pole, and I saw a macular hole. This should not be done by anybody, but I used the retinal brush and went into the macular hole, where I didn't want to use PFCL, but I knew PFCL will go inside. I did a PFCL oil exchange, and then the patient had about the patient had a macular hole also had done laser, and laser around the break. Patient had 3/60 vision. And I remember this person knew that time the HOD of JJ that time, and he called me and said, how the hell expulsive hemorrhage happened? I told the expulsive hemorrhage is not afraid of any professor, and it happened. And I said, I know how to manage. I managed it. And this was a trauma. 24 years old person came to me after 20 days, and this was also 25 years back. You can see I took the help of that time cornea surgeon. I don't remember who was with me. I think probably Urmi Shah. And so this you can see we planned open temporary keratoprosthesis, but by the time I planned, when I saw there was a necrotic tissue in the eye, and then I had put a flaring gas ring, and I had to do open sky vitrectomy because there was no point in doing a keratoprosthesis because nothing could be seen, and I don't know what I am removing. My anesthetist that time asked me, the patient was under general anesthesia, are you doing a micro evisceration with the open sky? I said, no, I'm trying to clean the eye. I do a anterior segment dissection, but the reason I'm showing is don't give up. And I think I know you are removing some tissue with the necrotic debris, but the idea is to remove the necrotic tissue because there's no point in leaving them, and then also the infective material. And I really don't know what I'm removed. I sent for histopathology, but it showed only inflammatory cells, and we couldn't find any organism because it was 20 days with a lot of antibiotics going. But eye was terrible. And now I'm clearing the anterior segment using the forceps and scissors, and I give back to the anterior segment surgeon to do the keratoplasty. And at that time, I remember she was telling, I'm wasting a cornea. I said, no, this is a 22-year-old. Whatever it gets, you should repair the eye. It can become opaque, but if there is a possibility, I will do vitreoretinal surgery again, and with again, another graft, I probably make sure that the person may see. But I'm not sure, so I take a written consent, now a video consent from every patient, where I do a vitreoretinal surgery, that these are the consequences. You can see eye looks quiet, I give an intravitreal antibiotic, and then you can see the results were a counting finger close to face at the end of 30 days. And I think still there was a mild peripheral retinal detachment. I told the patient I can do surgery, but the patient was not willing. And this was another eye, and you can see this was the pre-op, no perception of light, and then counting finger. So no perception of light. Dr. again, Ferenc, Kuhn and Bob Morris have published several, this one is a, so I have time up, okay. So this is the last video I'll show. So this is a palate injury. I've done hundreds there, and we did about 1,000 patients, published in Indian Journal. And you can see we made a special incision between 11 to 1 and made a forceps designed by Dr. Manish Bapa in Nasik. And that's the place where the pellet knocked down and have a subretinal hematoma, and then the pellet fell down. And I usually make sure that I made an idea that the pellet should not fall on the retina. So where the pellet is within the vitreous hemorrhage, I grasp it with this specially designed forceps made by Epsilon, no financial interest. You can see the forceps is, now we grasp it, we make a separate incision, and then remove it from 11 to 1 and close the wound. And then do a fluid air exchange. If there is a macula is all right, so I think there's a good possibility of vision. And this is how the pellet is removed. And so my philosophy, my eyes with no perception of light, only in trauma, should undergo a primary repair, even when the anatomical success is estimated to be less than 1%. And I also tell this one, where a patient is in semi-coma in a road traffic accident, and he is lying on the side table in the operation theater, and the nurses are talking, hey, how are you going for the movie and all that, and then the fellow suddenly gets up and says, excuse me, can you operate me as though I'm going to live, not I'm not dead still. So even though the eye has no perception, you should do everything to salvage the eye and then salvage the vision, restore the vision. Thank you.
Thank you, sir. It takes lots of courage to show your cases which are having a little, I can say, disastrous complications. Yes, I appreciate for showing and sharing this and how to circumnavigate that issues. Thank you so much.
Thank you.
I call upon Kuhn sir to felicitate Natarajan sir. Next we have is Dr. Supriya Sharma, who is going to speak on corneal tear repair.
So, India is very fortunate to have somebody like Professor Natarajan. Very few people are this, first, enthusiastic, and two, this knowledgeable, dedicated to the cause of ocular traumatology than him. Very few. He holds the world record in the number of surgeries relating to a single conflict, Kashmir. He is traveling all over the world to make others follow the enthusiasm that he shows. And he has done a tremendous amount of contribution to make the cause of traumatology in this country better, as you already heard a few. And he said something that is very important to emphasize, which was, do not give up. We share this philosophy. What I tell my patient who has a so-called hopeless case, and I will come back to what is hopeless. And I tell them, if you don't give up, I will not give up. And if you tell that to a patient, it's extremely rare that the patient would say, okay, I don't want to take that small chance of getting my vision or at least the eyeball back. So what is the truly impossible case to work on when the eye is in pieces, when you do not have the capacity to suture something back into an eyeball? All the rest would have some chance. It doesn't mean it will be successful, but there is a chance. And if you don't take the chance and you don't do this early, you throw the eyeball away. And he also mentioned about enucleation. Very important what he said. Do not primarily enucleate again unless there is no eyeball left. Because we should never forget this is not only removing something. It is the same as cutting off your arm or leg. It's an amputation. And it has not only visual consequences, it has psychological consequences. So be enthusiastic about this field. It's more difficult than any other subspecialty in ophthalmology, but that's the beauty of it. You know, I don't want to put down cataract surgeons. I had cataract surgery in both of my eyes. I can really appreciate the good cataract surgeon. But cataract surgery you do in huge numbers. And the individual case will not give you the same reward as a difficult trauma case that you saw where others said, okay, this is hopeless. And the patient comes back with some vision. It's an enormous energy for you to carry on and repeat the same with the next patient. So nobody else like him.
Yesterday when I took Ferenc to the hospital, I entered and we saw some 4 trauma patients. I don't think they have vision. And I said, I've done four surgeries on them. But everybody came and thanked him, saying that he's a good surgeon. And I am always touched by that, because all my patients who are not blind because of me, but because of the trauma, but I operate, and after 4 surgeries also, they come and give me gifts, and they meet me, and they come regularly. And I sometimes wonder why they come, but they come. They come regularly for the last 40 years. So that's a reward, and that's why I want to prevent injuries, because after repairing also, many don't see. But doesn't mean we'll stop operating. We'll keep operating. And I learned this from Dr. Jovanovic. He said, every trauma patient you operate, you learn something, and you know how to apply to a next trauma patient.
Thank you. A very good morning, everyone. And at the outset, I would like to thank Professor Natarajan sir and Dr. Chaya Shinde ma'am for this opportunity to be talking in front of such doyens in ocular trauma. Dr. Twinkle has already gotten the ball rolling, so I'll just add on to the very lucid coverage of the basic repair of tears which she has done already. Managing corneal tears is extremely challenging. Number one, because it has a varied presentation. It can be associated with loss of iris tissue, infection, and the smaller the tear is, the more challenging the management becomes. The most important thing in managing corneal tear is to do a very thorough preoperative evaluation. It is important to assess the systemic features, because sometimes, like I've had this personal experience that a baby came to you with a history of minor trauma but had a full limbus to limbus tear. So in such cases, there may be an underlying connective tissue disease like Marfan's, Ehlers-Danlos, and these patients often have keratoglobus, and corneal rupture or tear is very common in these patients. It is important to identify preoperatively what is the extent of ocular involvement, what is the visual acuity at presentation, the type of anesthesia that you would want to choose. For adults, if it's a small tear, can be performed under local, but for children, general anesthesia is of course mandatory. This is also important to counsel the patient and to not overpromise these patients, and also to predict the long-term outcomes in these patients. So need of imaging is obviously important when there's a history of trauma with a foreign body, because you want to rule out intraocular foreign body. The common site of ruptures and the cornea involve the limbus, and any prior corneal incision like radial keratotomy marks or penetrating keratoplasty graft host junction wounds basically. In the sclera, it is just behind the extraocular muscle insertion and cataract surgery wounds. Let's see a few case scenarios here. So in cases of non-perforating lamellar trauma like tears like these, when there is no overriding of the edges and the edges are clean, non-edematous, in these, and you need to perform a 4 Seedles test in this. So in case there is Seedles positivity, you have to take this up patient for surgery. Otherwise, they can be managed with simply putting a BCL, regularly following up these patients and starting on topical and systemic antibiotics. For linear tear, my aim has always been to convert a complicated tear into a linear tear. So first, when you're, for example, a tear like these, first sutures should always be taken at these ends or the angles, so that you convert a long tear like these into multiple small linear tears, and then just go on putting interrupted sutures with either 10-0 or 9-0 nylon. Important in this is to, for example, this is a video that shows a linear tear with a scissor in a 10-year-old boy. The anterior chamber can be formed with saline or with air bubble, whatever you are comfortable with. If it is a saline, it's always recommended that you put an AC maintainer, because in the initial phases there will be repeated loss and shallowing of the chamber. Interrupted sutures are first taken at the ends, and then you go on coming towards the center. Equidistant sutures are placed at 90% involvement of the corneal depth. In the end, when you are closing, it is always important to close under saline and not air, because there may be small wound leaks which you may not come to know if you are closing under air. This has already been covered by Dr. Twinkle ma'am, so I'll just skip this in the interest of time. Coming to repair of triangular flaps, it is always important to first take an anchoring wound at the apex, so that you convert this triangular tear into 2 linear tears. And also, because if you see here, if the first sutures are taken over the edge in the radial ends, then there will be some amount of stretching of the cornea. So it is important that you oppose the apex first and then treat it as a linear tear. So this is again a triangular flap injury where the first anchoring suture is taken at the apex, and then you treat these 2 ends like simple linear tears starting from the edges of the wound. Then you gradually progress towards covering the entire extent of the corneal tear. It is important that the suturing is not tight enough and as well as not loose. If it is too tight, then it will cause the folding of the Descemet's membrane, and that can interfere with the visual recovery in the patient. Repairing limbal tears, though it may appear to be small, but it is extremely challenging, especially if they are associated with iris tissue loss. This was a patient who had injury with a pencil, and as we can see, there was presence of iris tissue in the wound. So if the iris wound looks infected, it is important that you excise the wound. If it is not infected, then you may attempt at repositing the iris, especially in children. So here a peritomy is done to assess the scleral extent of the wound, and these cases often will have some amount of vitreous loss also. So it is important that you keep a vitrectomy handy in these cases. Like for example, in this case, a limited vitrectomy over the area of the tear was performed, and once you're sure that there is no vitreous in the wound, then you go ahead with repairing. The first suture is always taken at the limbus, so that you restore the normal anatomy of the eye, and then it is followed by corneal tear repair, and then followed by the scleral tear repair. So here it is seen that the first suture is taken at the limbus, so you reposit the flap, and once that is done, the corneal tear can be performed like a routine linear tear repair, and then followed by scleral tear. If you feel that the wound is infected, I will just take a couple of few seconds. So if you feel that the wound is infected, then you do not have to put the conjunctiva back over the scleral wound, because in the post-operative period you want to assess what is the condition of the underlying scleral wound. So it is okay if you leave the conjunctiva and not reposit back over the scleral wound. Stellate tear again becomes extremely challenging. Personally, like Dr. Twinkle ma'am said, that performing a purse string suture is extremely challenging. If you can, it is a very good method of operating, and these are the two Akin methods as well as the Eisner's purse string method, suturing methods which have been described. And these tears are extremely challenging. This was due to a car battery blast injury. Because the wound looked infected and the ends were edematous, there was a peritomy performed. First, the limbus is sutured so that you restore the normal anatomy, followed by taking multiple small interrupted sutures along the entire length. So it is important that you pose the apex first, and then you treat each end or each arm of the radiate tear like a linear tear. So just to conclude, that the primary aim here is to achieve tectonic stability, and it is important to explain the patient that the surgery that you are performing for the first time is to restore the anatomy of the globe and not for visual rehabilitation. Counseling is extremely important in these patients, and always examine the unaffected eye, because we often tend to miss it. We only concentrate on the eye which has been where the corneal tear has affected the affected eye, and we tend to ignore the unaffected eye. Whenever in doubt, you always go in for a multi-stage procedure. Do not try to attempt removal of the corneal, the traumatic cataract, repairing of the tear at the same time. Thank you. And I would like to take this opportunity to invite the residents for a hands-on wet lab training program on managing corneal tears and perforations at SSEI on the 30th of March. Thank you.
Thank you, Dr. Supriya. That was an excellent presentation. Would like to have some pearls of wisdom from Dr. Ferenc, and then the memento. Dr. Supriya, you may please move now.
So again, I will have a talk on this. I don't want to go into the specifics, but I do want to mention something else for especially the younger people. When you watch somebody else doing surgery, and then when you do something, there is one thing that I found extremely useful to increase the gain I have from these two things, which is a question that you have to ask the surgeon that you're observing and then yourself. What is that question? The question is why? So I remember when I was young and I went to different operating rooms watching surgeons who were very famous at the time. And I watched them do something and I did not understand why the surgeon was doing it. So I said, excuse me, why did you do that? And I can tell you the vast majority of the times I did not get an answer. Or the answer I got was the following. The surgeon looks at me and says, because this is what I always do. Or because this is what I learned. Or the best one, which is, what do you mean? So if you follow this very simple rule, why, you will realize that a lot of the things that others do and then you do make no sense. We do it because who knows why. And that should never be done in any surgery, but especially in eye surgery. You should know everything about what you do. Give you an example. You should know why you do the surgery at that day and not 2 weeks earlier or a week later. You should know exactly why you choose one kind of surgery in trauma and not another kind. These are the so-called strategical questions, the big ones, but there are also small questions, tactical or tissue tactics questions. For example, when you do a corneal suturing, why do you have a forceps? in your hand? I don't. I will show you in my videos and I explain why. Or if you do retina surgery and you operate on an eye that is full of scars, why do you cut that membrane at that point and not earlier or later? Why do you cut it with that kind of scissor and not a different scissor? Why do you cut it at that angle and not at another angle? Why do you use right hand versus left hand to do that? Why do you cut the membrane here and not there? These are all questions you have to know the answer to. And if you ask most surgeons, why did you do that there and not somewhere else, they will say, what do you mean? But you have to know the answer. So my point is, if you develop that philosophy or attitude, your surgical outcomes will improve. It doesn't matter that this is always the right answer. There might be other answers, but at least be able to justify what you did in every case, okay? And again, I do differently, which is not criticism. I just don't follow some of the old rules, which are dogmas, which are published in every book, because nobody has said, why do we do this? Okay? So once you listen to that, you can make your own decision whether you follow that or this. Okay?
I would now like to call upon Dr. Chaya Shinde, Madam, for her talk on ocular trauma and disability.
Good morning. Ocular trauma is important because it can cause vision loss of various percentage and patient can become blind. Ocular trauma refers to the injuries to the eye, including the surrounding structures, the adnexa, and it can be caused by various accidents or incidents, potentially leading to vision loss or other complications, including permanent disabilities. So how do we calculate the disabilities? This is according to the Government of India Gazette, where both eyes' vision is taken into account. If the vision in one eye is 6:6 to 6:18, 6:24, 6:36, 6:63 by 62 by 60, 1 by 60, or hand movements close to face, to no perception of light. And then, considering both eyes' vision, the percentage is calculated by the expert panel. It also considers the visual field. If it is less than 40 to 20 degrees, less than 20 to 10 degrees, and less than 10 degrees. The patient will have 40%, 50% or 60% visual disability. Final is 100% visual disability. This is a case, 32 years male. He had left eye phthisis bulbi and it was a left eye scleral tear and facial bone fractures in November 2024. Left eye was no perception of light, and as the right eye field of vision was also normal, the patient was given 30% permanent visual disability and not likely to improve. Vision is not likely to improve. Then only we offer the visual disability percentage. This is the case, 51 years male, right eye high myopia, left eye traumatic sphincter tear, high myopia and optic atrophy. Because the patient had traumatic optic neuropathy 1 year ago. Now when the patient has head injury, because it can be direct or indirect trauma to the optic nerve. So in head injury cases, because of the impact of the trauma, the nerves are affected and patient develops optic neuropathy. Now vision was right eye 1 by 60 and left eye was no perception of light. Hence patient fell into 90% permanent visual disability. The patient also had posterior staphyloma in the right eye. Next patient, 24 years male, right eye phthisis bulbi following scleral tear in 2007. As the other eye field was normal, 30% visual disability. 43 years male, right eye myopic, and he went into amblyopia because left eye had trauma with stone while playing in the childhood, causing scleral tear. And the right eye vision was 624, hence the patient got 60% visual disability. 7 years male child, left eye optic disc atrophy following traumatic optic neuropathy following head injury. And this patient was 30% as the other eye was 6/6 vision. 18 years male, left eye total leukomatous opacity and amblyopia because of accidental Lyme injury at the age of 2 years. He was 30% visual disability as the other eye was normal. 48 years female, right eye phthisis bulbi, accidental trauma in childhood by stone, and B scan showed reduced axial length, membranous ecchosin vitreous extending from disc anteriorly, suggestive of closed funnel RD, and thickened sclera. So patient had 30% visual disability. This is 32 years male, left eye severe ptosis and phthisis bulbi, again trauma in childhood and 30% disability. 36 years male, pre-phthisis, left eye accidental trauma with grinder machine, late presentation next day after 1 day to the hospital, scleral tear with iris prolapse with metallic foreign body in October 24. Scleral tear repair was done, then vitrectomy, foreign body, intraocular foreign body removal, silicone oil insertion, and intravitreal vancomycin and ceftazidime as there was infection. Scleral patch graft was also done in the next week. Still the patient fell into 30% visual disability as the other eye was normal. These are the pictures. This is the intraocular foreign body, even in the radiological investigations and the patient's clinical photo. So the points to be discussed are trauma has to be prevented. Awareness, more and more awareness has to be created. Patient should present early. It has to be diagnosed early. Not that all doctors treat trauma. So they are not aware. Maybe sometimes there is occult scleral tear is there. Sometimes it's a seal corneal tear. And the general physician is not able to make out. All patients do not reach the ophthalmologist. So accessibility and affordability also has to be there for the patient to get the treatment. Prompt management has to be done. All hospitals do not have emergency system or small clinics. Everywhere it is not there. Teams are not available 24/7. Prompt management is not available in those cases. And we declare the disability only when all possible treatment is done. Maybe 3 months, 6 months, 1 year. When everything possible is done. And then only disability is declared. Thank you. I thank Khushi for helping me in this presentation. She is first year resident, but helped me a lot in this. Thank you.
Thank you, Chaya Madam. So next I invite Dr. Pankil Mota from Surgery Department to speak on management of head trauma with ophthalmic trauma. In accordance with the latest ATLS guidelines. And in the meantime, good news for all of you. So to listen to Dr. Ferenc Kuhn, the coffee break has been postponed to 4 o'clock. How's that? So everybody have to wait for that. Okay. Thank you, Doctor.
Yeah, hi. So in the room full of ophthalmologists, I would like to bring to your attention to a very, very important topic. As a trauma surgeon and as a co-in-charge trauma at LTMGH, the most probably important and the most probably frequent injury that accompanies the ophthalmic injuries, that is the head trauma or head injuries. So, life, limb or eyesight, a very ancient saying, probably even true in today's date. The eye is important indeed, but typically not evaluated or treated until and after the patient is medically deemed stable. Now, what is ATLS and why do we follow ATLS? Because it gives us an evidence-based framework to give a standardized approach and management and a comprehensive assessment in trauma. Also, it gives us an opportunity for utilization of the golden hour which would benefit the trauma patients in the best possible manner. It also suggests and tells us that early identification and management are crucial for minimizing long-term complications of trauma. Now, what is the ATLS approach? It is basically the primary survey, and if there are a few problems in the primary survey, we resuscitate those, and only after that we go to the secondary survey, and after that the tertiary survey. Now, of all the head injury patients, it is noted that approximately 68% of them have some kind of eye trauma. Now, which is the most common trauma which is encountered? It is just a small minor swelling or contusion of the eyelids, or a relatively serious form of ophthalmic injuries, which may include open globe injuries, orbital fractures, traumatic optic neuropathy, or chemical burns. Now, so this was there also on my opening slide, not because I like pandas or raccoons. Now, what is a panda sign or a raccoon's eyes? Okay, probably a hemorrhage around the orbital area. Yes? No, it can also mean a very, very deeper or a very serious issue, which is a fracture of basilar part of the skull or the anterior cranial fossa, which probably needs more attention at that time. Hence, ophthalmic or vision-threatening injuries can complicate the neurological assessment and management. So this ATLS protocol helps us or guides us in identifying the injuries which are probably more critical. Now, in what way the vision-threatening injuries can complicate neurological assessment and management? It can obscure clinical signs. For example, pupillary responses helps us in the brainstem assessment. And in case there is an eye injury which complicates the pupillary assessment, may not give us an accurate evaluation. Eye injury may also not let us detect anisocoria, which is an indicator of raised intracranial pressure or brainstem herniation syndrome. Altered consciousness or communication. Often the patients with severe head injuries have intense pain, leading the patients to have a more agitated behavior or altered mental status, which complicates the assessment of neurology. Also, when the patient's vision is greatly impaired, he is not able to follow visual commands, which also complicates in evaluation of neurology. Mimicking neurological deficits. A traumatic optic neuritis may lead to afferent pupillary defects, which may resemble brainstem function, but which at that time the brainstem function is normal. Delayed diagnosis of neurological injuries. Now, when there is a severe trauma of face or facial or maxillofacial region, while trying to treat that or while concentrating in that, we might, tend to ignore more severe injuries like brainstem trauma or intracranial trauma. Management challenges. Elevated intracranial pressure management may involve interventions like head elevation or hyperosmolar therapy that needs to be carefully adjusted in presence of ocular injuries. Surgical or procedural interventions for severe eye injuries, example globe rupture, must be balanced with need for neurological stabilization and monitoring. Overall vision-threatening injuries can create a diagnostic and therapeutic dilemma requiring a multidisciplinary approach involving neurology, ophthalmology, and trauma specialists. Now, any type of trauma or trauma for initial management is same, even for the head trauma and even for the head trauma with ophthalmic injuries. So the first we do is a primary survey. Now, what is primary survey? We classify it as A, B, C, D, E. A is airway, B is breathing, C is circulation, D is disability, E is exposure. Head and eye are carefully examined during the disability phase of the primary survey. So this I will just brush upon. Okay. So eye is basically in detail, eye and the neurology is basically in detail examined only in the secondary survey. Head and eye are carefully examined in secondary survey. A detailed neurological and eye examination is performed. The eye examination should be documented in 3 ways, in 3 vital signs of the eye: the pupils, the vision, and intraocular pressure. In addition, physical examination also includes the examination of anterior and posterior segments of the eye. Now, the investigations in trauma. The most basic investigations which can be done are chest X-ray, fast, non-contrast CT brain, and minimum blood workup. In case of suspecting head ocular injuries, we might also order orbital CT, which includes a 1 millimeter thin cuts of the orbit to evaluate any cranial, optic nerve injuries. Now, management of head injury. Basically, it aims to prevention of hypoxia, control of the raised intracranial pressure, and maintenance of perfusion. Why? Because, so we keep the patient in 30-degree propped up to facilitate venous drainage, sedate and paralyze to reduce brainstem metabolism. Normocapnia and normothermia is maintained to prevent vasodilatation or vasoconstriction, avoid hypotension to prevent hypoxia and edema of the brain, avoid hypertension to prevent transmission of intracranial pressure, give mannitol to decrease cerebral edema. However, it is contraindicated in extradural hemorrhage and seizure control. Of course, if required, we progress with surgery. So now this all has been already covered. So what are the long-term complications of head trauma? They include post-traumatic seizures, cognitive impairment, and post-concussive syndromes. Ocular complications like glaucoma, cataract, permanent vision loss, or strabismus. Ongoing rehabilitation and follow-up are essential for recovery. Conclusion. A thorough ocular examination in secondary survey can identify subtle ocular injuries that may threaten loss of sight if not treated right away. Head trauma with ocular involvement requires a multidisciplinary approach. Early and appropriate management according to ATLS guidelines can significantly improve outcomes. Close collaboration with trauma teams, neurosurgeons and ophthalmologists is a key in management. Thank you.
Thank you. Can I request the next chairman and Dr. Ferenc to come here so that Ferenc can... Doctor, you can wait here for the certificate. Ferenc, you can come here. Ferenc, and I request Dr. Avinash Shingole is here. Yes, please come, sir. And Dr. Kerobi Levy and Dr. Usha Johari. In the meantime, I thank Dr. Mayur, Dr. Naina, and Dr. Twinkle. So, first certificate to Dr. Mayur. Is Mayur's certificate ready? Come. You can take it from Mayur. And I think by the time they assemble, we can have a group photograph. Can I ask all the speakers to come here so that we have a quick photograph and then go to the next session? Where is the certificate? Now, where is the certificate here? And the memento? Joseph? I'll give some certificate. Yes? Pardon? Oh, no. It's Samir? Samir? Where is Samir? Ah, yeah. No, sir's presentation. Sir has to see, no? Everything is okay? First talk properly dala? He's done, he's checked it, he's saying. Yeah, but Ferenc will give. Yeah, you can give the certificate to Dr. Mayur. This is, yeah, come, center, yeah. Yeah. Dr. Pankil, thank you. A certificate for Dr. Pankil here. And be there for the photograph. We'll have a quick photograph. Yeah, to sir. Dr. Pankil, where is he? So now the next session, chairpersons, Dr. Avinash, come. We'll have a quick photograph. Yeah. All of us, we can stand here. Well, yeah, we can. Huh? No, the group photograph. Come, stand here. You are the hero of this day. No. That's the microphone. How are you? Nice. Oh yes. Okay. And all the speakers are here. Avinash? Avinash? Yes, thank you. So I thank all the chairpersons, co-chairpersons and the speakers of the morning session. And Ferenc has not checked his presentation, but I'm sure Samir has done a wonderful job like me. So we are happy to have the Ferenc Kuhn. The meeting is done only because I want to take advantage of him. He came to see only the tigers and the tigress, but I made sure that he gives us his knowledge to us, and he readily agreed. And from morning to night, he is going to educate us on ophthalmic trauma. Yes? What, do you want something? So he has 360 publications, 7 books, over 2,000 talks across 67 countries. Not bad, I have only 2,600. And Dr. Kuhn has received numerous awards and grants, including from the CDC to develop the Ocular trauma score. He serves as editor and reviewer for numerous medical journals and has performed live surgeries in 17 countries. And I think he's a PhD, and plus I think he's first of all, a great human being, and he's willing to teach. I don't know how many of you understood. He was telling all the young people here, learn to question your teacher in a nice way, and if the teacher doesn't answer, go to another teacher. Yeah, because that's the experience we had as a student, but I had an excellent teacher, Dr. Badrinath and Dr. Jovanovich. They answered all the questions, and that's why we love to answer any question, and any of the youngsters can take up the mic, and you can tell the old people to shut up, and we will keep quiet. You can ask questions to Ferenc. Thank you, Ferenc.
Thank you very much for the opportunity. So I have 3 talks. I just want to tell you I will make this one and the third one a little shorter, so I can spend more time on the cornea, because to me that's the most important thing. So timing is really a crucial issue, and remember, this is the easiest one to control. When do you do what you do? Here is one case when the surgeon decided there was no injury that he needed to attend to, and you saw that it was a gigantic rupture. So when you talk about the damage an injury causes, there is an initial one, the mechanical damage. Then you do your intervention, when do you, what and how. And finally, there is a third component, which is the reaction of the body to the injury. So I will talk of all these only about timing, and I will talk about only open globe injuries, not closed globe trauma. If you have endophthalmitis or it's a high-risk case, there is no option. You do immediate surgery. But with all other cases, you do have options. So typically, this is what happens in the world again, because this is a dogma in the textbooks. You do a staged approach, which means you do not one, but at least 2 surgeries. First, you close the wound. Hopefully, this is done as soon as possible. Don't wait the next day, do it if possible as soon as the patient comes and is able to undergo surgery. And then you do a second surgery. This is the intraocular reconstruction, whatever is wrong inside the eye. Textbooks will tell you this is done roughly around day 10. Textbooks tell you that. But the real world is very different. As I travel to many countries, to many ophthalmology institutions, the real world tells you that the wait is much longer. I need the sound. There is sound for the video and so this is what waiting does. But if your timing is off, terrible things can happen. And inside the eye, this is the typical consequence of waiting too long. What you see here is incarceration of the retina into the wound. So what happens if you have incarceration in the wound? Here is a typical image that you see. The surgeon does vitreous removal, finds the incarceration site, the potential incarceration site, and then does laser around it. And if you do that, what is going to happen? This is what is going to happen. The retina will still be incarcerated in the wound. So now you have to do a lot more when the retina detaches to try to reattach this. And then if you wait more, the typical image is what you see on the right and the surgery for it on the left. The retina is detached everywhere, and it's a closed funnel which is incarcerated in the scleral wound. I saw one child who had this on day 5 after the injury. Typically, in children, it comes much earlier than in adults, but it can happen within 8 to 10 days, even in adults. So if you see an image like that, it means even if you are the best surgeon in the world, you are going to get married to that patient. Why? Because you do surgery and the PVR, for those of you who don't do retina, PVR is our greatest enemy. It stands for proliferative vitreoretinopathy. Basically, it's scarring in the vitreous cavity. So you do surgery for it, but the PVR just comes back. And in certain injuries, the risk of PVR is up to 89%. So you can do two things. You can pray that it does not come. And I've seen many surgeons around the world, as I said, who waited and waited and waited. And when I asked them, why do you wait? And the typical answer is, I was hoping that it wouldn't come. If you're a surgeon, you don't hope. You do something. So you have two options which are superior to the traditional one. The first option is you do a primary, comprehensive intraocular reconstruction. If I see the patient first who comes in with an open globe injury, I will close the eye and continue and do everything in the same session. Now, I understand that for that, you not only have to know the back of the eye, not only the front, but you also have to have the infrastructure. You have to have the operating room available. You have to have a trained nurse. If you don't have a trained nurse, don't do this, because you don't want frustration by telling the nurse, give me something, and the nurse says, what? That is not going to contribute to the success of the surgery. But if you have those tools available for you, the best option is to do primary comprehensive reconstruction. But you have another option if you can't or won't be able to do that, which is the same traditional approach. Wound closure and maybe hyphema removal on day one, and then the secondary reconstruction, but it's not 2 weeks from the injury. It is within the first 100 hours, 4 days. Why? 2 reasons for that number. One is if the patient comes Friday afternoon, you can do it Monday morning. But more importantly, because roughly 4 days is the cutoff after which the risk of PVR dramatically increases. So that's when you do your secondary intraocular reconstruction. Because, as I said, your goal, or one of your goals, is to prevent PVR. The only real argument you have against doing this is what you see on this video, where you don't know what you are doing. You just do reflex, which is, there is some prolapse tissue here, and let's remove that. That's not the way to do this. So this, what you saw, is a typical expulsive chordal hemorrhage occurring on the operating table. But if you do your surgery properly, which means you maintain the intraocular pressure, the risk is very low. And if you do a vitrectomy, and you do have, very rare, an intraocular severe hemorrhage, you can deal with it either at that time or later on. But nothing else justifies waiting. What you see on this video is a very interesting case. This lady fell in a hospital and sustained a blunt object rupturing the eye. They called me from that hospital and they said, what should we do? I said, put the lady in an ambulance. So what you see here is 8 hours after the injury. There is a 360-degree retinal tear. So if you wait and not do surgery within a few hours, but wait a week, by the time you do the surgery, the retina again is a closed funnel, incarcerated somewhere in the wound, and it's a much more difficult surgery. You have a much higher risk of recurring problems, and the vision, of course, is much worse. So what I was discussing so far was what to do with the eyeball. But my biggest problem with this mentality is not this. It is this, because we are not talking about an eyeball. We are talking about a person who has an injured eyeball. And typically nobody cares about this. The books will never mention that there is a person attached to the eyeball. So imagine yourself with a condition. Do you want that condition to be solved now or sometime in the future? Obviously now. Why? Because normally you would worry during that period, stress. What happens at the end of the process? If this is not obvious, let me tell you an example. Let's say you are a patient and you undergo cataract surgery. Your friend will do cataract surgery on your eye. There is music in the operating room. The surgeon is asking the nurse, give me this, give me that. And then the next word, and I'm sorry, I have to tell you how it happens in life. And the next word you hear is this, shit. what happened. This is what happened. Your nucleus is in the vitreous cavity. So if you look at the literature at this point, the literature is divided. One part will say you can wait 2 to 3 weeks until the eye is not inflamed anymore, or you can do surgery now. The results are the same. I don't believe that quite, because if you have this in your eye for weeks, you will have cystoid macular edema, which requires additional things and may not recover vision fully. But let's say it's true that it doesn't matter in terms of the final visual outcome, whether you did or your colleague did the vitrectomy for this condition now versus 3 weeks from now. How do you think you will spend your next 3 weeks waiting for the ultimate solution? Are you saying it doesn't matter, or you say, I'm a little worried? Of course you're worried. So one of the reasons to do early surgery is to allow that patient to have a shorter period of anxiety between the injury occurring and the ultimate reconstructive surgery. So in summary, what are the benefits of waiting? The answer is easy: nothing. There is no benefit waiting with your reconstructive surgery. But doing early surgery means, one, it's easier technically, and two, you prevent a lot of complications which otherwise would come. So don't be late, because if you are, this is what happens. This is a bank robbery, true bank robbery in Detroit, that somebody recorded. You have to arrive on time. Thank you.
They arrived on time, but they didn't do action.
Any questions?
Thank you, Dr. Kuhn. Thank you, Dr. Kuhn. That was a wonderful talk which you had given us. And the best thing about the talk was the very humanitarian approach that you have propagated throughout your talk. And also a very important take-home key point, that do not wait for 14 days as is advocated, but do it as early within the first 100 hours. Thank you so much for these pearls, Dr. Kuhn. Any questions?
Some youngster should ask question here. There are a lot of young people. Mansi, you want to have some question? Smith. Sunil, you are the youngest here.
I wanted to ask Dr. Kuhn a question. He mentioned something about his corneal, about not using the forceps. Sir, could you highlight on it, please?
If I may defer it until my talk,
Okay,
because I will spend time on explaining why you do not need and actually should not use forceps when you suture corneas.
Hello.
Yes.
Dr. Sunil here.
Yes.
I just had a couple of questions to ask. The first question would be, when somebody comes with a detached finger, we tell him that this has to be attached as early as possible. Somebody comes with a retinal detachment, wouldn't the same analogy apply there? Or somebody who comes with a tear, most probably one of the reasons is probably because the vascularity is important here, but in a corneal tear, it's an avascular tissue. So would you, instead of 100 hours, say as early as possible as the first dictum, or would you still say that no, I mean, you may delay up to 100 years, 100 days?
Are we talking about a normal retinal detachment, not a
traumatic
trauma?
or traumatic or any?
So there is difference between the two. Trauma, usually you don't have a detached retina at the time of you first see the patient, usually. So the reason why I recommend early, and again, as early as possible, the 100 hours is the maximum, is because the signal to the body to start the PVR process is there. So you don't do the intraocular reconstruction to treat retinal detachment, you do it to prevent scarring, basically. It also helps other ways because obviously there is no blood, you can see the inside of the eye better, the patient vision instantly gets better, etc. If you talk about a normal rhegmatogenous retinal detachment, my philosophy is that's not an emergency surgery. So that's not, you stop the daily routine or you come at 8 o'clock in the evening and fix it. Because even if the macula is off, if you do it next day, the visual function can be, it's probably going to be just as good as doing it at the moment. So with that, you can wait a day or two.
The second question was how important would it be for each individual to actually get himself audited by somebody else to look at these timings issues that I operated this patient this time and this is what the outcome is, and how would that guide it?
So the problem with doing a so-called level 1 evidence study in trauma is because you can't standardize it. You will never have equal injury groups on the two sides. So you can't directly compare the early versus the delayed. You have to have a huge number of patients on both sides, and you think that overall the injuries are similar. So this is one of the many examples, especially in trauma, where common sense rules. And common sense tells you that, well, common sense and again clinical experience, because I can tell you as I travel and people bring me charts to ask for my opinion whether what they did was right or not. And I look at the chart and I see the first surgery, and then I look at the second surgery's date. And it's 3 weeks, 4 weeks. And I instantly tell myself this patient will either have PVR by now, or even after the second surgery is done, PVR is coming. And it is coming. So, again, common sense and experience tells you that waiting does not have benefits. It's exceptionally rare that a patient with such an injury will not have PVR. And if you can do early surgery, first of all, as a general rule, early surgery means easier surgery. The only caveat here is corneal transparency. That's why what I will tell you about the cornea does make a gigantic difference. So very briefly, I'm not going to go into that now. I don't do 90%. I do 100%. My suture is in the anterior chamber, which means by the time I finish suturing the cornea, my cornea is clear. I will be able to do everything in the back, everything, including peeling the ILM, because my cornea is fully transparent. So if you can do it now. And I'm not saying you will not have PVR, but the percentage of eyes with PVR with an early surgery is much lower than with the delay.
And the last question, if I have time. Yeah. So the last question is that doesn't this bring to a point where a lifelong support or a lifelong coaching of somebody senior is essential, even if I were to achieve a standard of being an expert in inverted commas. So I learned from Dr. Kuhn, from your books in the past. I started teaching my students, but now I see you evolved at least 100 times more than what I thought is what you wanted to say. So is lifelong support to the students important, and should the students actually seek lifelong support?
Well, we all of us, including me, will learn, or should be able to learn. In other words, we all are students and teachers at the same time. The older you get, you're less of a student, but you are still a student because you always see something that somebody does that it helps. But after some mentorship, being under some mentorship, and starting doing more and more on your own, eventually you reach a point where you don't need somebody sitting next to you all the time and coaching you. So I cannot tell you when it is because it depends on many factors, but once you have enough experience, you will have only occasional questions what I should do in this case, and you will do a very good job on your own. Okay.
So I was referring to Atul Gawande's lifelong coach. Cricketers, footballers, they still have coach even if they are the gods of cricket. So
no, you don't need a lifelong coach to answer with a one word. No. Yes.
That was an excellent presentation by Dr. Kuhn. As you aptly say, timing is everything. May I request Dr. Robi to please present him a small memento and.
Oh, yeah.
Yeah,
okay.
sure.
Okay.
Yes.
So in the meantime, what's the name? Sunil, the lesson from being moral from Dr. Atul Gawande, I follow him very quietly, but I have done it with Dr. Johanich, spending every time he came to India, now he's retired, he used to come watch me operating, but he'll never say a word, unlike Atul Gawande's teacher who came, but not every day. So lifelong coach is not a right word. But you have a coach, you have a mentor. See, yesterday, Dr. Mansi came to me with asking a question about a patient with a trauma, with something. I said I was busy doing something. I requested Ferenc to help and he did it. So the question is, even at this time we will get some doubt, but you should not be shy. There's no ego, that's what I have learned. I call anybody, and I operated a child where I troubled the best experts in the world. And that patient's mother is so well educated, I don't know whether she's going to come this evening. And she contacted 100 people in the world, and all top people. And everybody is finally directed, and I operated immediately with a great difficulty because 15 man-hours to talk to that family because they're well educated and well informed. So we have to have somebody to tell us, but not all the time. As you said, every time somebody cannot be sitting on our head because it's not an ego. No, lifelong coach means you don't need a coach all the time. So many coaches will observe, they will not tell you. And looking at his face, the student has to learn. Like me, we have to learn from our own conscience. And very time self-education is very important.
And there is a corollary to this from the other side. Never think that you know everything, and never think that you know everything better than everybody else. That's the worst you can do. Yes.
So there are two chapters I would like you to refer. One is the surgical self-education written by Steve Charles in microvitreous surgery, and the second one is surgical self-education written by me in my cutting-edge vitreous surgery textbook, both by Springer.
So my question is, because we are doing a comprehensive reconstruction together and not a staged procedure, would you always get an B scan and all the imaging done beforehand, even in an open globe injury?
That's an excellent question. And before I answer the question, my advice to all of you is never believe a word anybody tells you, including me. Why? Think about what I said and everybody else said, and consciously come to a conclusion whether you agree and then do it, or disagree and then don't do it. So now my answer is no. Why do I not do ultrasound? Why? I've once had the opportunity of having one of the world's most famous experts in ultrasonography looking at my patients before surgery. 50% of the time he was wrong. He told me there is no retinal detachment, there was, and vice versa. The only thing I really believe is this. So when I have a serious case with vitreous hemorrhage, etc., when you may have a detachment, is I will approach every case assuming that there is a retinal detachment. So I do cautious surgery, not assuming that the retina is where it's supposed to be. That's my philosophy. Okay.
But sir, in cases which we have a lot of vitreous hemorrhage, so all those cases you would try to clear the vitreous hemorrhage immediately, or you would clear the vitreous hemorrhage only if there is a pre-existing retinal detachment?
No. Traumatic vitreous hemorrhage is an enemy. For many reasons. One, you don't see what's going on inside the eye. Two, it's an inducement for PVR to occur. Now, technically, there is, again, I'm sorry, I'm spending time on some on things that maybe I shouldn't.
No, it's fine, because the whole idea is we all want to learn from you.
So again, here is what the literature tells you, because I have to stop before I explain that. When you have vitreous hemorrhage in an older diabetic patient, it's very different from a young patient's formed vitreous having blood in it. It's easy to remove an older person's diabetic, whatever, vitreous hemorrhage. It's not easy to remove vitreous hemorrhage from a young person's formed vitreous. So when you look at that young vitreous, because most trauma patients are young, the vitreous is infiltrating, the blood is infiltrating the vitreous. So when you look at the vitreous, for example, you can actually do it if you do open sky vitrectomy, which I don't do because of the risk of further hemorrhage. But if you do, what you see is, first of all, as Professor Natarajan said, you have no idea what you're taking out. You don't, because it's not obvious. So you can be fooled two ways. One is that there is a red streak, which you assume is a blood vessel in the retina, which is detached, and therefore you don't touch it. But it's not. It's a streak of blood inside vitreous layers. And two, you can have blood, true blood, pooled between vitreous layers. So you get there, you remove the vitreous in the front, and all of a sudden is this fluid blood everywhere. You said, oh my God, I just got into the retina. And you can be fooled on the other side, which means there is retinal detachment, but the blood vessels have no circulation. Therefore, you don't think and you don't see that you have no visual feedback telling you this is retina, and you can remove a large part of the retina. For these reasons, I don't follow what you read in the literature, which says, in this case, what you have to do is you remove, I'm quoting, horizontally moving your vitreous cutter carefully from anterior to posterior. Again, you have no idea what you're removing. So what I do in this case is just the opposite. I go to the nasal side, the macula is on the other side, and I go and dig vertically. So I'm digging a well on that side, because either I will see that there is retina somewhere in the back, or if I did not see it, I was fooled, and I went through the retina, Once you are in the retroretinal space, you know exactly where you are. You did create a retinal break, unfortunately, but it's on the nasal side, but now you know where your retina is. So technically, that makes your surgery a little easier. Okay?
Thank you so much, sir.
Okay.
Request Dr. Karobi again to present a small memento and to Dr. Kuhn. Meanwhile, Dr. Rao is there, the next presenter. Yeah, she will be present. Yeah. May I invite Dr. Rao to present her presentation on nasoorbital ethmoidal fractures.
Good afternoon, everyone. I'm Dr. Sarika Rao, Plastic Surgery Assistant Professor in this very institute. First of all, I would like to thank Dr. Chaya Shinde Madam and the entire organizing team of this conference, Dr. Mukund Jagannathan Sir, Chief of our Plastic Surgery Department, for giving me this opportunity. The topic given to me is naso-orbitoethmoid fractures. These fractures accounts for less than 5% of all maxillofacial fractures, but very rarely it occurs in isolation. It is always associated with other midface fractures. It is most difficult to treat successfully because of its three-dimensional anatomy. So this naso-orbitoethmoidal complex, it has got in the front three bones, that's the frontal nasal bones and the maxilla, which is quite strong, followed by the three bones, lacrimal, ethmoid and sphenoid, which are quite weaker bone. So it is in this complex we have three strong bones which are being held by three weaker bones. This complex basically is present at the confluence of three important cavities, that's the cranial, orbital and nasal cavity. So frontal bone, in spite of being strong, but extensive fractures can injure brain or dura. The medial wall and floor of orbit are quite weak and it commonly gets fractured. Ethmoidal labyrinth present in the interorbital space, it's made up of multiple ethmoidal air cells which makes it quite weak. Cribriform plate which forms the roof of nasal cavity, an olfactory nerve and optic nerve which is in close proximity of this complex. Coming to a closer look of this ethmoidal labyrinth, you can see it is made up of ethmoidal air cells which is quite paper thin, and the cribriform plate, how it is closely related to the olfactory nerve. So damage to this area can damage the olfactory nerve and can cause CSF rhinorrhea. Again an important picture which is showing important buttresses of our face, mainly in the naso-orbitoethmoidal region. Here you can see there are two horizontal buttresses, that's the superior and inferior horizontal buttress, and two medial vertical buttresses. These buttresses basically signify the line along which this fractures needs to be fixed. Road traffic accident, most important cause for these fractures. All these fractures have been classified mainly into three types depending upon the medial canthus tendon attachment. In type 1 and type 2, the medial canthus tendon remains intact, and in type 3 it is avulsed. The other difference is in type 2, along with the avulsion of the tendon, there is comminution of the fracture fragment. So all these patients, they basically present with gross facial edema with or without multiple facial laceration. They might have ecchymosis and subconjunctival hemorrhage. Most of the time they present with symptoms due to intracranial involvement. A very typical feature that we see on visual inspection of these patients is telescoping of central upper midface, where you can see there is an acute frontonasal angle and an obtuse columellar labial angle. They usually present with nasal bleed, CSF rhinorrhea may or may not be present, and traumatic telecanthus may be present. Orbital symptoms are mainly due to entrapment of medial rectus or inferior rectus muscles, which presents with decreased range of motion with or without diplopia. Again, we can see the signs of proptosis or anophthalmos. These are due to positional changes which occurs due to retroorbital hematoma, blow-in or blow-out fractures. They may also present with diplopia. So you can see these two CT images where there is an extensive fracture and you can see a significant increase in the orbital volume. So all these trauma patients, after following the initial ATLS algorithm of stabilizing these patients, like all these facial trauma patients tend to have cervical spine injury, cranial injury, as well as airway injury. So these patients needs to be stabilized first, followed by the initial evaluation of the naso-orbital ethmoidal region should be by a team approach by ophthalmologist, plastic surgeon, ENT surgeon, and neurosurgeon. Followed by this, the manual examination by crepitus on palpation, bowstring, and bimanual palpation. These all tests are just to identify that yes, the naso-orbitoethmoidal region is unstable. And last not the least, you have to look for CSF leak for all these patients. 1 mm axial and coronal CT scan of midface with 3D reconstruction is the investigation of choice, and it actually shows the fracture as well as what is the extent of fracture and helps us in deciding what approach to be used in case to reduce this fracture. You can see 3 CT images where I'm showing an axial cut, a sagittal, and a 3D reconstruction showing the NOE fracture. Once the decision has been taken to go ahead with fracture reduction, the vision charting and diplopia charting is must. Again, force reduction test to just assess the entrapment of the periocular muscles. Goals of management are reconstruct the skeletal framework of naso-orbitoethmoidal region, craniofacial injuries, the floor and medial wall. Re-establish the medial canthus, establish the nasal support, and along with that, whatever soft tissue repair needs to be done. So various surgical approaches have been described, like we can use the existing laceration itself, or you can open it by open sky H-shaped incision. This is the bicoronal approach which we usually use for all our NOE fracture patients. Eyelid incisions like subciliary, subtarsal, infraorbital incisions, these incisions are usually taken in order to explore the orbital floor. Coming to treatment options, if the depression is minimal and patient is not having any symptoms like no nasal obstruction or any orbital complaints, we consider putting just a dorsal bone graft to maintain the aesthetics. However, if classical features are present, we have to go ahead with the surgery. If these patients are having dural issues, like if they have a dural leak which has subsided, it can reopen if significant reduction has been done. So in these cases, careful closure of dura is must with fibrin glue, and Gallia pericranial flap may be needed in order to close this dural repair. So neurosurgery help is required. So you can see we have done the fixation along the buttress plates with our micro plates. This is one of our patient where we have done naso-orbitoethmoidal fracture patient. He already have a congenital squint. This one more patient, here we have not taken a bicoronal but used the local laceration to fix the NOE fracture. Followed by that, we have to do canthal relocation in case if it is a type 3 fracture by SS wire, transnasal wire fixation. Coming to orbital floor and medial wall fractures, they can be pure and impure blowout fractures. So we consider reduction of these fractures only if the patients are having double vision because of entrapment of the muscle, which has been confirmed by force reduction and CT scan. If they have anophthalmos or exophthalmos because of the positional change of the globe, or radiological evidence is there of extensive fracture of the floor. All these fractures, if there is a single piece fracture is there, simple reduction is enough. But in case if there is a defect in the floor, bone graft or conchal cartilage may be required. What we usually use is a prefabricated titanium mesh is used. Here you can see a picture of our patient where the mesh is in situ with rim has been fixed at the CT of the same patient. This one more patient who is having extensive fracture of medial wall as well as the floor where we have used an extended mesh. This is a CT of NOE fracture with medial and floor where extended mesh has been used. In few selective cases, we have even done endoscopic reduction of the floor fractures, where endoscopically you can put the Foley's catheter into the antrum and keep it for 5 days for the fracture to heal, and can be removed on 7 days. But if their graft is needed, the floor needs to be exposed. This is the patient where we have used endoscopically, we have reduced the fracture. So to summarize, orbital and nasoethmoid fracture are complex injuries and detailed knowledge of this anatomy is needed. Fixation of these fractures depends upon multiple factors. We always use low profile plates and screws in these regions. Bone grafts are often needed and teamwork is necessary if surrounding structures are damaged. Thank you.
Yeah. Thank you very much, madam. That was an excellent presentation. And as an ophthalmologist, I think you covered all the bones around the eye. Thank you very much. And due to shortage of time, we would again invite our next speaker, Dr. Ferenc Kuhn, to the most awaited talk, the role of suturing corneal wounds. Sarika, can you come up?
So,
So we would like some pearls of wisdom on the previous talk, sir.
indeed, I consider this the most important of my 3 talks. So if we go over time, I will skip my foreign body lecture because this is not as important as this one. So first of all, you have to realize that in life you have choices.
我台里明明老师，我都落針，一百個都做後生都跳啊！哦，我台里。你明叫我都唔會學難摸都背。做咩學跳摸嘅歌？可能我做聲聲30個。邊計黃會？
So these choices are true for corneal suturing as well. Remember what I said, half of these eyes will require posterior segment surgery. So you have to do your surgery as early as possible. But in the phaco era, nobody teaches corneal suturing anymore. Really. I go to all kinds of institutions and I ask them, do you teach residents, fellows, how to do corneal suturing? I said, no. Because it is not random introduction of sutures in the cornea until you say, okay, now it's a watertight wound, but you have to plan what you do. This is what happens if you don't plan, and this is what happens if you don't plan in the cornea. So before you start suturing, one question is how soon you should suture. This is an example of what happens if you don't suture on time. This is a very small corneal wound, 1.5 millimeters, but nobody wanted to suture it, and by the time the suture is put in, the patient already has endophthalmitis. Just want to tell you again, there is no forceps in the image. The material, of course, is tenonylon, and the needle we choose is so-called spatulated needle. But if you look at that needle, you will realize it is not spatulated. It's a combination of round and spatulated. And you have to know that if you catch this needle with your needle holder at the round part, it's going to turn. So make sure that where you grab is in the truly spatulated part. Wound toilet, I don't want to talk about it too much. I repeat what I said, don't excise the iris unless it's contaminated. But take it out from the wound, and how do you do that? You create a paracentesis at least 90 degrees away. Never push iris tissue back into the anterior chamber. Always pull it from behind by a sweeping motion. Viscoelastic, I don't have time to go into this, but I want to tell you this. Do not use viscoelastic unless absolutely necessary. Why? Because when you do that, you tend to put too much viscoelastic inside, and that means that your wound, which was, or the cornea, which was like this before, will be like this now, and therefore, when you put in your suture, you are going to fight the viscoelastic. Now, how can you don't use viscoelastic? Because when you see the patient, in almost every case, the anterior chamber is already formed. And if you need viscoelastic, it's because you lost aqueous. How do you lose aqueous? One way to lose aqueous is to use forceps. So this is the typical example. A lot of viscoelastic there. This is a teaching video from one of the most famous ophthalmology institutes in the world. And you can see the flap of the cornea does this. How do sutures work? They do work by tissue compression. And the compression is a zone. You put in your suture, and then it has maximum effect in the plane of the suture, and as you go away from it, the effect goes down. And how do you create a watertight wound? Is you have overlap between the compression zones of two neighboring sutures. If they do not overlap, you have gaping. How do you deal with the gaping? You don't create gaping. You plan where you put your suture. You plan how wide the suture or long the suture is, and therefore you will not have gaping. At a given tension on the suture, the longer the bite, the longer the compression zone. That's why you don't use tiny sutures. You use typically longer sutures. I will come back to that. What types of suture? There are two types, interrupted and running. Which one to use in the cornea? The rule is very simple. Long peripheral limbus parallel wound, that's where you lose a running suture. Everywhere else, you don't. So if you look at that image, you never do that. Why? Somebody already showed it, because a running suture will flatten the cornea. You don't want a flat cornea. You want the dome shape of the cornea to be maintained so that you have a deep anterior chamber. So no running suture except in the limbus. Let's talk about forceps. So in every other tissue or case on the human body, how do you suture a tissue? You have two things in your hand. One holds the needle holder. I'm a right-handed person, so this is needle holder. And the other hand has a needle, a forceps. Why? Because when you enter the tissue with your needle, it tends to push the tissue away. Depending on how good the needle is, and especially how massive, how strong, how thick the tissue is, it changes, but still it gets pushed away. So what your forceps does, it counteracts that. So needle comes from here, your other hand holds the tissue against it. But in the cornea, you don't need to do that. Why? One, the needle is extremely sharp, both the tip and the side. It will cut through the tissue easily. The second is you don't grab, so there is no need to grab the tissue because the cornea is soft, and again the needle will go in it very easily. Additional reasons not to do that is because it traumatizes the cornea. And traumatizing the cornea means you increase your enemy, which is edema. And as I said, you lift the tissue with your forceps, and then you lose aqueous, and now you have to use viscoelastic, and now you have to fight the viscoelastic. So this is the typical example. You grab the cornea and you put your suture in. This is a 25-year-old video. I had to resuture this cornea, and you can see I'm and the limbus, and still there is no need to use forceps. I will come back to this again later on. Now let's talk about the order of placing the sutures. Typically in the body, and that's true for most scleral wounds as well, you have the tissue, so the 50% rule. Your first suture is in the middle, now you divided the wound into two, and then you continue dividing it in equal length halves. This is what you typically do. You don't do that in the cornea. As you heard before, there are specific features, landmarks to look for. One, limbus. If your wound is corneal scleral, your first suture is in the limbus. Why? Because this is where you see where cornea is against cornea and not cornea is against sclera. The second, I'm sorry, here is a video of it, so you do this. The second one, you heard it in a talk already or twice, angle. I remember when I had to do such a corneal suturing when I was young, and of course nobody told me that this is what you do. Your first suture, as you see, is at the angle. So I did not do that because I said to myself, if you have a sausage, you don't start in the middle. You start the sausage eating from one end to the other. So that's what I did. What happens if you do that? What happens is this, so this part of the mobile part of the wound, can you see that? If you start your suturing from here and go here, by the time you get to the middle, this part will move. And now, if you want to close the wound, you can still close it, but you have to have a lot of strength, tension on your suture, which means your cornea will be distorted. And that distortion is permanent. Even if you removed your suture, it remains. You start there, just like in this case. It's not my video, obviously, because I don't use the forceps, but the location of the suture is correct. You go through the angle, come out on the other side, and now you have two simple wounds to close, which are easily done. But what if you have this, and it's not that rare, that you have a transcorneal wound from 9 to 3. The technique was developed by these two gentlemen, Rosie Hayes technique. So what you do is, again, not 50% rule, but you start where? At the two edges of the sausage. And your first sutures will be very long. Why? So the best way to explain this is you take a rubber ball and you cut it in half and you put it on the ground, and then you take your 4 fingers and you compress the ball on the two sides close to the ground. What it does, it is going to increase the middle apex, the corneal center, by doing that, and that's what you want. Again, you want to avoid a flat anterior chamber. If you do this, you are going to increase or at least maintain the depth of the anterior chamber. And so you come and eat the sausage from the two ends coming towards the center. So that's first rule. The second rule, the closer you are to the center, the shorter your bites will be. So this is what you do. And you avoid the epicenter. Why? You should never put a suture in the epicenter. Why? Very simple. If you look at a cornea where the sutures have been removed, the scars, which are not or barely transparent, will form not only where the wound was, but along your suture tracks as well. So you don't want to put a suture in the epicenter. And so this is how a transcorneal wound should be after you sutured it. Now, this explains what I said. If you do this kind of suturing, you will not, full thickness, I come back to that, you will not have a problem continuing and doing all your posterior segment work because your cornea is clear. And one thing to notice from this, how few sutures you need to close that cornea. If you look at most corneas that have been sutured, you would have twice as many much smaller sutures. So what if you don't do this? You do not use the rosy haze technique. I took these two next images from a textbook, and it was not among the bad examples in the textbook. The green curved line shows you what you want at the end of the cornea, but if you do this on the left-hand side or the right-hand side, then your cornea will not have a dome shape, it will be flat. So now let's talk about the other very crucial difference other than the forceps, is how deep your bites would be. Again, traditionally, they tell you it has to be 90%. So what's wrong with that? And my short answer is everything is wrong with that. Why? First of all, how do you know you are 90% deep? You are sitting above the cornea. You're not inside or underneath the cornea. You have no idea whether you are 90%, 85%, or 99%, or 100. You don't know. If you really want to know, what do you do? Because there is a possibility to know it, and this is what happens. You take your forceps, you put your suture in, and then you lift the cornea, and then you look. What does it do? You lose aqueous. Now you go and use viscoelastic. And it's true whether you're entering or exiting the cornea. But if you do not want to look, and remember, ideally, your movement of needle entry into the cornea is one movement. So you take your needle holder and you do this. And if you do that, again, you have no idea how deep you are. The second problem is the thickness of the cornea on the two sides is never the same. One is always a little more edematous than the other. Therefore, on one side you may be 90 degrees, but on the other it can be anything. That is a permanent distortion again. But the biggest problem, I'm sorry about the number, but on my computer it was at the right place, here it's not. So, this is the biggest problem. So look at the cornea on a cross-section. What you did was this. You closed, let's say, 90% depth, but you left 10% open. That 10% is in water. So aqueous is able to enter your corneal stroma non-stop until it closes. And there is a solution to this. What you do is you stop the fluid from coming by closing that posterior 10 segment, 10%. No fluid entering anymore. Because your suture is in the anterior chamber, you close the back as well as the front part of the cornea. So look at this image. This is a lady who lives in a farm far away from everything. She has no phone. She is cleaning the cage of the chicken, and one of the wires punctures her cornea. For 3 days, she's alone. She doesn't see anymore because she has endophthalmitis. And the 4th day, the son comes and says, "Mom, what's wrong with your eye?" And now, on the 4th day, she is taken to the hospital. And this is the image I'm showing you. I see when I do the surgery. You can see the cornea. You can see how much I see of the retina, because obviously I continued her surgery with vitrectomy. She has endophthalmitis. Very poor view. I've sutured the cornea. You can see the sutures here with full thickness sutures. 16 hours after this, this is the image. This is what happens if you close the cornea completely, full thickness. Edema disappears. So what arguments do you have against full thickness sutures? There are several. You heard one already. I'm not going to talk about the rest because of the time, but this is the most important one. The risk of endophthalmitis. Question, is it true or not? Especially knowing that the track, the channel that your needle cuts in the cornea is larger than the thread, the suture material that is inside. It seems logical that there is an opening, a channel connecting the outside world with the anterior chamber. Is it true? That is true. However, you already have edema in your cornea, and that edema will instantly compress that channel. It closes the channel. How do you know that? I told you, never believe anybody. You have to know that it's true. And one way to know that is to put a little compression on the cornea and to see if aqueous leaks along the suture tracks, and the answer is no, they will not. But there is another way to know that, and this has importance for you for the technique of burying the knot. When you see me closing a corneal wound, I put my suture in, I do the knot, and I cut it immediately. Why? Because most surgeons you will see, to save time, they will cut it at the very end. And they will have struggle burying the knot because the channel is already closed. So now they have to force it to be open again. So very simple, bury the knot immediately after you put it in. But this has significant, the full thickness suture. So no risk of endophthalmitis postoperatively, but there is a risk when you remove the suture. Because when you remove the suture, you lift it, you cut it, and when you pull, part of it, what was outside, is going to turn into the anterior chamber. So sterilize the surface the same way as you do for an intraocular injection. Length of the bite should be equal on two sides. Very simple rule. If you don't, you have a distortion. Again, this is permanent. Angle, 90 degrees. If you don't, the tissues will shift because that's what the tissue, what the suture forces the tissue to do. And again, this is not going to disappear by suture removal. How do you do the knot construction? Several ways. I will tell you what I do, I will tell you how I do it, I will tell you why I do it. The first is a triple throw. So you do this, and then I saw one of the videos, beautiful, exactly how it should be, then you cross your hands. If you don't cross your hands, you create a sphere, and your knot will be bigger, more difficult to bury. And then you tighten it. Don't make it tight with this technique. Just barely leave the thread lie on the corneal surface, because you will tighten it with the next one, which is a single throw. And notice that your angle changed 90 degrees. Why? Because this locks the knot. It will never get loose after this one. And because you left the first triple throw loose, this is how you can tighten it without tightening it too much, because you see what happens to the cornea. And then you repeat that, a single throw as a third one, just to be on the safe side. And again, you turn your hand 90 degrees. So the third one is parallel to the first one. So this is the technique. Again, no need to have forceps. You come out on the other side. If it does not want to come out, then you grab the conjunctiva. If it happens over the cornea, you simply put your forceps onto the surface so that the needle will come through the jaws of the forceps. And then you do a triple throw. And notice again that your hand has to move to the other side. So 1, 2, 3. And now you change and let it sit there loose. Single one, turn your hands 90 degrees. This now tightened it. A third single one, again turn 90 degrees. Now how do you cut it is the next issue. Because typically the nurse will give you scissors. I will show you on the last video that I prefer not to use scissors, and I will explain why. So bury the knot. This is an absolute rule, and yet you see, I see, corneals sutured like that when the surgeon could not bury the knot, probably because either the knot is too big or does it at the end of the suturing rather than after each suture. Which direction? If it doesn't work in one direction, go and use the other one. There's no rule which way you have to turn it. But it has to be buried immediately. So, this is a summary. It's a fresh wound. You can count how many sutures are used. I will show you. The first thing you do in this case is to remove every suture, because this was done without planning. Just put in sutures, even different kinds of sutures. And this is, you can see, this is an angled wound. So obviously, you go through the angle. This is more difficult than normal because you had to remove all the sutures and you lost some aqueous, but I still don't need viscoelastic. So you come out on the other side. We are very close to the end. And you put the same, let's see if I can fast forward this a little bit. So you tie the knot. Turn your hand. So I will explain to you the blade after because I don't want to interfere with the video. So you put that suture in, and then you put additional sutures in. Now you start from the limbus again because this wound is, the edges are close. So you want to maintain, as I said, the depth of the cornea, the anterior chamber. So you go from the two edges, wound edges, towards the center. And you repeat it from the other side. I did not remove the other suture, which on the video is at 6 o'clock, because that's not critical, although it's not an acceptable one. But this is how many sutures you needed, and this is how many you had. Remember, as I said, you have a scar along the suture track as well. So before, let me explain to you why it's more optimal to use blade to cut the suture and not scissors. So imagine yourself sitting over the cornea. Then here is the suture in the forceps, and now the nurse gives you the scissors. You put it down, and once you put it down, the scissors covers where the knot is, because the scissors is thick. So you don't know exactly where you cut it. So a more controlled way of cutting it is the blade. So what do? You hold up the suture one by one, and you place your blade right on top of the knot. And then you move your suture to the blade and not the blade to the suture. That way you cut it exactly where you want it, and then bury it. Okay, any questions?
Sir,
I'm sorry, let me add one more thing. So I have been preaching this for 25 years. And I often go to meetings, and because people argue with me, don't do 100% because of this or that. But most people will at least try. So I had a lot of people coming to me years after I talked about it and said, I tried it, and indeed it makes a gigantic difference. The edema is gone when you are finished suturing. So it's much better for the patient visually, and much better for you, because not only can you do, as I said, everything that you need to do in the posterior segment, but also you can follow what happens inside the eye postoperatively. Yes. Yes.
To ask one small question, you have wonderfully sutured the corneal wound, but on the first or second day, one or two sutures are loose, or maybe in the form of loop. You immediately remove it.
Well, it really shouldn't be. If you use this technique, you will not have loose sutures postoperatively, whether it's day 2 or many days, except in children. In children, the cornea is more elastic, and the sutures will become loose much faster. So for this reason, and also because healing is faster, the removal, I did not talk about it obviously, the removal time in children is much shorter for the same wound length than in adults. But as a general rule, the answer is, if you do have a loose suture, yes, remove it, because the loose suture will increase irritation, inflammation, vascularization. Any other question? Microphone.
Yeah, I think in the interest of time, we can take the questions later. We have our Dean of LTMMC Sion, Dr. Mohan Joshi here, ready for the inauguration session.
No, Twinkle, I requested Mohan, sorry, because Dr. Robert is waiting for half an hour. So, Ferenc, you can come here. We'll do it, the question answer again post-lunch. And in the meantime, Dr. Robert, our Dean is waiting, but you have give your talk. And you are not new to our audience here. Everybody knows Dr. Robert Redak from Poland. And Dr. Mohan Joshi is here, the Dean of the Sion Medical College. And we are all waiting. And after your talk, we are going to do the inaugural ceremony. Thank you, Robert.
Good afternoon, everybody. And I'm really honored to speak after Professor Ferenc Kuhn and greet him from Lublin. I think he's third home city because he spent a lot of time in Poland, and also I am the person who can repeat that I have tried, and it helped me a lot what I learned from Professor Kuhn, because I followed him since I think 25 years in Bremen, in Poland, so I attended his courses. Also, today I would like to speak about novel strategies and techniques in severe injuries of the anterior and the posterior segment of the eyeball, because I am VR surgeon, but also anterior segment surgeon. Let me share my presentation now. One moment. Excuse me, probably technicians should turn on possibility that I can share my presentation, because I have information that there is it is not possible to share my presentation. Natarajan, can you hear me? Excuse me. Okay, now it will be.
Yeah, we can hear you.
Okay.
But we can't see your slides, Robert.
Okay, yes.
And yeah, now we can see.
Okay,
yeah, we can see your slides. Thank you.
Okay, so let's start. So we collaborate also with Professor Marko Zarbin from Rutgers University, and we prepared this talk for our trainees. So again, greetings from Lublin to everyone and to Professor Kuhn. This is our hospital. We also have one of the first in Europe and the first in Poland, cornea bank at this hospital. So we deal with anterior and posterior segment trauma. And of course, trauma is really severe and urgent situation. It may lead to endophthalmitis, and this is the most severe complication. And we should always, let's say, protect patients against endophthalmitis, treating ocular trauma in a proper way. Also, in a long run, we can face glaucoma as a severe complication. And there is a, let's say, important to understand the pathology and distinguish between perforation, penetration, and blunt trauma. Of course, speaking about blunt trauma, there is a mechanism leading to various problems in the eye globe, and spectrum of ocular damage might be, let's say, really complex. And we observe Bosse's ring after the blunt trauma, angular recession, iridodialysis, cyclodialysis, lens luxation, different, let's say, spectrum of problem. Nowadays we have many techniques how to avoid, let's say, problems. So vitrectomy, we operate first dropped nucleus, and this is my favorite technique, handshake technique using 23 gauge system and chandelier light. So we can use both hands with forceps and vitreous cutter. Always I use a bubble of decaline to protect macula, and this way you can use, you can really operate the majority of cases. Of course, if nucleus is stone hard, I'm using endophacophragmaton, but my favorite technique is to elevate hard nucleus to anterior chamber and to use phaco tip to remove it from anterior chamber. And then we can use different techniques of fixation of IOL, like Yamane plunge intrascleral haptic fixation technique, or Canabrava, or iris claw. So all techniques are performed at my department. This is just an example of Yamane technique. And of course, as I learned from Professor Kuhn, lens is just color of the car, and retina is an engine. And you should start from really examination of the posterior segment and treat retina in a proper way. So sometimes on the left video you can see subluxated cataract surgery. In this case, we observed only vitreous hemorrhage, and finally we decided to perform cataract surgery, and with intracapsular tension ring and reconstruction of the pupil, and it was a really good approach because there was no problem with retina, and we had good result. On the right hand side we can see combined phaco-vitrectomy, and we do really a lot of phaco-vitrectomies nowadays in Lublin with really good results. So this is post-traumatic retinal detachment and cataract. So we perform 25 gauge vitrectomy with chandelier light and by manual technique. So this is standard procedure, but of course time is an important factor, so you should operate such patients immediately. So this is really urgent situation to avoid PVR and other problems. So at the moment, these are our standard strategies. So how to avoid endophthalmitis? Optimal wound surgery. So we heard from Professor Kuhn his really excellent talk and technique I learned from him. And of course we perform ultrasound, but the best method is CT scan cut with less than 1.5 millimeter, but you can use various techniques also. Open conjunctiva check, sclera if there are no wounds, and of course UBM is also helpful. It has so this possibility that you can check and detect small intraocular foreign bodies and locate them with respect to sclera. Sometimes it is not easy to distinguish if it is outside the eye globe or already inside the eye globe, so UBM might be helped. So endophthalmitis is an emergency. It is really dynamic situation, so don't wait until a distraction phase, especially post-traumatic endophthalmitis with, let's say, penetrating eye trauma, intraocular foreign body rupture of lens capsule or delayed tooth closure is really, let's say, worsen the prognosis. We know causative organisms, especially gram-negative rods, are really very dangerous, leading to really necrosis of the retina, and bacillus spores or Clostridium perfringens are really lead to rapid progression within 24 hours. So you should really control the patient every hour to check if there is progression. If you may use the vitreous tap and intravitreal antibiotics, but if there is no improvement, indicate vitrectomy very fast. So you see, this is the paper of Professor Kuhn. We cite here showing, so this is his approach. In fact, I learned many years ago. So always, especially look if there is a red reflex. If there is no red reflex, vitrectomy is indicated immediately, and also really intervene as soon as possible. Early vitrectomy within 6 hours and complete with PVD. Some surgeons, in fact, discuss if PVD might be dangerous, and you may induce let's say, retinal breaks, but anyhow, I try to perform PVD in cases where there is no necrosis of the retina. So my center is participating in studies in Europe, in Lublin. Also, I think there is our common paper here with Professor Kuhn, at least one. Anyhow, I would like to show you some cases. Intraocular foreign body might be not easy to detect. So we could see intraocular foreign body with CT scan, but at the moment this patient was sent by from another hospital, and the colleagues tried to find it and just pushed it into the angle. So I performed cataract surgery using gonio lens. I could find and detect this iron foreign body, and already it was quite late, so there were symptoms of siderosis. Another case, so we, as you know, we are very close to Ukrainian border. So we have patients from Ukraine after bomb explosions, and this is the case of a lady, mother of two twin brothers, 5 years old twin brothers. So she was transported from Ukraine to Lublin. So I performed immediate sequential cataract surgery on both eyes, and I could find in this case glass foreign body behind the iris. So I performed cataract surgery implanting IOL, also to protect posterior capsule. And you see now I could extract this glass foreign body from the eye. The second eye is just after penetrating injury, but there was no foreign body, so I could perform cataract surgery. So it was not easy because also you should expect posterior capsule defect. Also sometimes it is a fibrotic capsule, so you use scissors to continue capsulorhexis, not to damage the capsule, and then or zonules. So then you will finish cataract surgery, implanting IOL. So this was a really famous case. We published this case, presenting very good results on this family. Also, we are using new technologies like Siluma. This is a totally digital microscope. As you can see, we perform also ocular surgery, trauma surgery. This is another case of intraocular foreign body trauma. And so first we start from cataract surgery. As you can see, you must be very careful in such complex situations. And you finish with the first. Normally these patients are very young, so lens is quite soft. So normally you use aspiration irrigation technique, but always be prepared for vitreous cutter. So normally I use, when I see even a trace of vitreous, I'm using vitreous cutter not to pull vitreous. And you see here is a long wire, metallic wire, so also quite tricky to remove it. So in this case, I could use paracentesis to remove this long object. You must be very gentle not to injure retina. Also, of course, we plan pars plana vitrectomy, and we can find every wound in the retina during vitrectomy and to perform laser. So in this case, we could remove this wire just through paracentesis. So nowadays, we perform ocular trauma surgery also during night duties. So we have in Lublin a team of doctors prepared to perform both cataract surgery, also cornea surgery, and vitrectomy. So here we stain vitreous using new dye. This is a lutein-based dye of Bausch & Lomb, and we continue vitrectomy, pars plana vitrectomy, also with PVD, inducing PVD, and trying to find every break. Finally, so the result was really good of this surgery. I will show you the patient. Just I want to present the moment of PVD. You must be very gentle performing PVD. This is again a new dye to stain vitreous, hyaloid, and we perform PVD. So this is the patient 1 day after surgery. It is already more than 1 year, and the result is really good. So my time is, I think, is over. So we also use T-shaped pars plana scleral incision to remove large intraocular foreign bodies. You can find this technique in our publications. So really, again, don't wait too long, and because then you must use temporary keratoprosthesis. This is the technique I learned from Cesare Forlini, and we implement it in Lublin. So again, thank you very much for the invitation. It's a great honor and pleasure to meet you today. Greetings from Lublin.
Thank you, Professor Robert. And when you are going to talk during the live surgery, you are going to show the near live surgery. At that time, we'll have the question answers. Thank you very much, Robert. And I know you have to go and operate. Thank you very much. And our dean is also waiting. So we'll have a see you later when you are going to project. I think Smith will coordinate with you for the timing, and then you can see your near live surgery. Thank you, Robert. And I request Dr. Chaya Madam to bring both the deans and Joseph. Can you have the chairs?
I now invite the dignitaries for inauguration ceremony. Guest of honor, Dr. Mohan Joshi sir, Dean of LTMMC and Sion Hospital. Dr. Shailesh Mohite sir, Dean at Nair Hospital. Dr. Ferenc Kuhn sir, Professor Dr. Natarajan sir, Dr. Karobi Lahiri, Dr. Chaya Shinde, Dr. Usha Zohri, Dr. Smith Bavaria.
कॅन्डल वगैरे आणले का छान पुढे
To offer the prayer.
Hello. वक्रतुण्डमहाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
I request the dignitaries to light the lamp.
Dr. Naina ma'am and Dr. Avinash sir. And Dr. Charuta ma'am. I request Dr. Chaya Shinde ma'am to welcome Honorable Dean Sir Dr. Mohan Joshi. I request Dr. Sujit Murade sir to welcome Dr. Shailesh Mohite, Dean at Nair Hospital, Mumbai. I also request sir to welcome Dr. Natarajan sir. I request Dr. Karobi Lahiri to welcome Dr. Ferenc sir.
I request Dr. Shruti ma'am to welcome Dr. Karobi Lahiri ma'am and Dr. Usha Johari ma'am. I request Dr. Harsha ma'am to welcome Dr. Smith sir. I request Dr. Anaga ma'am to welcome Dr. Chaya ma'am. I kindly request Dr. Mohan Joshi sir to address us with his golden thoughts.
My colleague and friend, Dr. Mohite, the Dean of Nair Hospital, Dr. Ferenc from Germany, who is a guest here, Dr. Natarajan, Dr. Lahiri, Dr. Johari, Dr. Chaya Shinde, Dr. Ingole, and Dr. Naina Poddar, and my friends. I had heard way back when I was a resident doctor, one of my cousin had gone to Aditya Jyot Hospital then. This was maybe in 1984, 1985. And he said that I have met one of the biggest ophthalmologists of the city, and he has advised me X, X, Y, 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 and so on. That time I came to know that there is some center in Wadala which is catering to a very high profile people and doing extremely good work, highly reputed, doing good quantity of work as well as a very high quality of work. And especially the difficult cases were tackled there. That was the perception which I had got many years ago. And thereafter, when my daughter took ophthalmology and she graduated as MS from ophthalmology from Nair Hospital, I came little bit closer to the ophthalmic faculty of the city of Mumbai, and then Dr. Natarajan became a very prominent person in my mind, I remember. Dr. Natarajan is the third generation of medical doctors in his family. And what I remember, I have attended a couple of CMEs of ophthalmology because of Dr. Natarajan. Dr. Natarajan became emeritus professor over here. Dr. Natarajan has taken, with the help of his foundation, that is Kamala Sundar Foundation, and way back it was Aditya Jyot Hospital, ophthalmology to what is called as community ophthalmology and preventive ophthalmology. When I used to travel via Dharavi, I used to see a center of Aditya Jyot in the midst of hutments of Dharavi, where they catered to the poorest of poor population, looking after what is called as preventive ophthalmology. So this Kamala Sundaram Foundation and Aditya Jyot Hospital in particular has taken extensive pains in the city of Mumbai. They have got branches now in Mulund and other places. But what they have been doing is detecting glaucoma, detecting problems in retina on a mass scale, and probably the only ophthalmology center in the city of Mumbai, maybe in state of Maharashtra, is having a largest data of XYZ disease, and that is Aditya Jyot, that much I can tell you. And Dr. Natarajan is now fully devoted to education in ophthalmology. He is fully devoted to training of the resident doctors, junior residents of the city of ophthalmology, and he is the person who's extremely connected all over the world. That somebody is speaking in his CME from Poland, somebody is speaking from Germany, somebody is showing some live surgery from XYZ corner of the world. So Dr. Natarajan is known all over the world, and this is one of his venture in LTMMC. We have offered him an honorable emeritus professorship, and he regularly comes and teaches the resident doctors, and he is extremely interested in teaching, and this is one of his endeavor, the CME which he has organized over here. I am forced to go for another CME, so I will take this opportunity to declare the CME open over here and thank Dr. Natarajan and all heads of the departments of ophthalmology in the city of Mumbai who have come all the way over here with their residents to get some new messages in ophthalmology. Thank you so much.
Thank you, sir, for your golden thoughts. Now I invite Dr. Shailesh Mohite, sir, Dean at TNMC and Nair Hospital, to enlighten us with his thoughts.
Our senior dean who had just left, Dr. Mohan Joshi sir, Dr. Natarajan, Dr. Ferenc, faculty, ladies and gentlemen, a very good afternoon to all of you. At the outset, I thank the organizers for having invited me for this program. Mohan Joshi sir has given a brief about Dr. Natarajan and his work, his institute's work. In medical colleges, when we work as dean, our role is dual. One is medical education and second is patient care. I am happy that sir has appointed you as emeritus professor over here, and you are doing good work in the form of arranging such educational programs for our UG and PG students and giving them exposure to the international faculty and their work. Pediatric and ophthalmology related to children, everyone is very much worried. It is near to their heart. Even if your child has got mild fever, everyone is worried. And when it comes to injuries, especially of the eyes, it is a very panicky situation for the parents. So in such cases, we as administrators also face lots of pressures from the government, especially during Holi, Diwali, where such injuries are very, very common. And therefore, at that time, our ophthalmic surgeons do a great job, offer their services, handle the trauma, and I'm sure such type of CMEs will further help them to enhance their skills, looking at the international faculty, how they work. Probably some of them might be fascinated and go abroad and join these institutes, learn, and come back to the country and serve over here. Thank you very much.
Thank you, sir. I request Dr. Chaya Shinde ma'am to address us and share her thoughts about the Trauma CME.
Good afternoon. I welcome you all for this CME and especially Dr. Ferenc. He has traveled so far for us. Thank you, sir. I thank our Dean, Dr. Mohan Doshi, Nair Hospital Dean, Dr. Moite, Dr. Natarajan, our Honorary Professor Emeritus, Dr. Karobilari, Dr. Usha Jori, Dr. Smith, Dr. Nikhil, my organizing team, my department, and dear students. Ocular trauma is very important because it can lead to loss of vision partially or completely. And that is why we have gathered here today to learn about ocular trauma. All of you must have seen patients in casualty, especially during Holi, Diwali festivals. We do get trauma. This is our trauma care center, Lokmanya Tilak Municipal Medical College. So a lot of trauma patients come here, and the ocular trauma is as a result of assaults in many of the cases, fall from the train, road traffic accidents, festivities, and in children, accidental traumas while playing. So all of you are gathered here to gain knowledge with the same passion in your mind to learn more. Undergraduate students are here and postgraduates are also here. I assure you that today evening you will leave with a lot of pearls of wisdom how to manage the trauma, and my message is to keep learning. I thank Dr. Natarajan for this wonderful opportunity for our students and Dr. Ferenc once again. Thank you all.
Thank you, ma'am. Now I request Dr. Natarajan sir to enlighten us with his words.
At the outset, I'd like to thank Dr. Chaya Shinde, who always, with open hands, welcomed me to come here and share my knowledge and also learn from them. And last week, I came with Professor Wolfgang Schrader, and we saw some patients, and I decided that whatever help from our foundation, we will do. And we are already inaugurated a charitable center in Chembur, but it's getting ready. We are getting the support from Sahachari Foundation, GKB Foundation, and also ACG Foundation, and also the Subramanya Samaj. They have given a 15 crore property, not given, they are allowed us to use the 15 crore property in a posh place, but for the poor people. And we are going to do for the poorest of poor free. And for people who can pay little, they can pay little and do the surgery who cannot afford me or the private hospitals. And I told Chaya Madam that you do excellent surgery in all the medical colleges here in Sion, Nair and KEM. But I said, we have created a world-class center. We will be happy to help. Our idea is not to make money. My idea, I'm already in post-retirement age, but I work. The reason is, next 33 years I follow my Guru, that's Swami Vivekananda, and the learnings from Dr. Badrinath and Dr. Jovanovich. And as Dr. Mohan Joshi said, I'm a third generation ophthalmologist. That's my parents. My father always wanted me to do free because he was the director of the eye hospital in Madras, which is the oldest eye hospital of India. and the second in the world next to Moorfield. And he told, you're a private practitioner and you're making money, why can't you do something for the poor? And that's why we started the clinic in Dharavi 25 years back, and we are doing a lot of camps and preventive work. The idea is not to boast, but I welcome all the undergraduates, postgraduates, whoever want to do any work in ophthalmology, no, not only in ophthalmic trauma, but diabetes and any other field, including anterior segment, we are ready. And along with Professor Robert Redak, who spoke, we have made a global foundation fighting blindness, where we are creating an international training center in Chembur with the state-of-the-art equipment, and I'm planning to get a simulator, the training center for suturing, corneal suturing, scleral suturing, because me and Ferenc are part of various wet labs all over the world, and I want to bring that to Mumbai, so that already we are 3 fellows from one Kosovo, one from Colombia, and other from Mexico are waiting to join as an international fellow, but we are following the National Medical Commission rules, which has changed last year, and they take a lot of time for registering, but we will do everything legally and morally correct. And thanks to Dean Dr. Mohan Joshi for appointing me as emeritus professor. My dream is to teach and nothing to take from here. I want to only keep giving, and that's what Swami Vivekananda said. They alone live who live for others, and rest are equivalent to dead corpse if you are only selfish and keeping the knowledge or money with you. And as our Dean said, these injuries happen in Kohli and in Cracker, and I'm happy to say our foundation is supporting the Ocular Trauma Society of India. We are filing a PIL, sir, against Cracker sale in India, and we want to make sure. I know the Cracker lobby is too much because of the money, and they may threaten, but I'm not afraid of that. And we are actually going ahead with the PIL, but we are not telling to stop selling crackers, but we are telling not to buy crackers from China. And even here the government and the corporation should buy and not give it to the children or the people who have children, and it should be placed like Singapore. And China manufactures cracker, but none of the public can use it. They all, only the government can do it in the public space. I saw cracker bursting in Germany. They do it in the river, middle of the river, so that the appointed people who, with all precautions, they do it so that nobody will be injured. And I think no point in having injury, and we see a lot of facial injury. We have Dr. Rupesh Agarwal, who is originally from Nagpur, but now he is the secretary of the International Society of Ocular Trauma, along with Dr. Ferenc Kuhn as the chairman of International Society of Ocular Trauma, and I am also a board member. And where he has made an appeal along with the OTSI, with the National Human Rights Commission in India, and we have said to put a caution that eye injuries are possible and don't give it to the children, and certain things should not be given. But who reads the small letters like the statutory warning in the cigarettes? Everybody, as today morning Dr. Ferenc mentioned, people who smoke know that you can get cancer, and still they do it. But I think cracker is not a must. I know I'm a Hindu, I celebrate Diwali, but why can't it? And Diwali is a celebration of light and not celebration of sound. And it's a problem. And I think it's a noise pollution and injury which causes a lot of trauma to particularly if the children, the parents are losing their time either doing business or working. They have to take leave, take the children, and particularly eye injury. A lot of times anesthesiast Dr. Naina Poddar spoke very well. So the whole idea of CME is, one, if injury happens, to do a wonderful repair and also save the eye and the vision. And if whole idea is how we can prevent eye injuries, and there was a good talk on prevention of eye injuries using the preventive goggles, which I think we should get a standardized preventive goggles in India. And thank you very much for the opportunity, madam, for having all of us here and the students who are here. And we are going to put it in the YouTube tomorrow. It will be there so that everybody can go through it, and we'll also share Ferenc Kuhn's email ID, so whoever has anything and who wants to write or publish or work with him, we are free to do so. And we, in the lunch time, in the coffee time, and Ferenc is going to be here till 7:30 in the evening, so you can talk to him and individually, and he always, I've seen all over the world, he always talks to young doctors to motivate them. And one thing which he told is, who will operate on us if we have a problem? So that's why we want to train all of you, so that when we have a problem, we want excellent surgeons, world class in Mumbai. Thank you.
Thank you, sir, for your golden words. It is my pleasure to now invite Dr. Ferenc, sir, to share his insights.
So, as I said before, you heard an exceptional person before me. And I don't want to repeat what I said and what others said, but I want to pick up on something he said about education. So let me share you another personal story with you. About 8 years ago, I had a couple of people in my operating room from different countries, and there was a man, an old man, who came to me the day before and said, I was injured in the Second World War. And I went to different ophthalmologists in different places to help me with this eye, which was injured, and I cannot see anything with it. And they all said, there is nothing we can do. First, because after the war, the equipment, etc., was not there. Later on, they said, Second World War, it's so long ago, what do you want? And then the people around me, they said, so what's the rationale to do surgery after all these years? And I said, look, the first question I had was, how old were you when you were injured? He said, 9. Therefore, I said, amblyopia is not an issue. My second thing was to see if that eye is able to see light, and the answer was yes. So what that tells you, he has a functioning retina, therefore it's attached. He has a functioning optic nerve. When you looked at the eye, it was an absolute mess. It was very difficult to say this is a human eye, because it was anything you can imagine behind the cornea was there or wasn't there. And I said, he wants surgery. I told him, there is nothing I can promise. What I can promise is I'll try, and there is nothing to lose. That was a half an hour surgery to reconstruct the anterior segment. I didn't even have to do a vitrectomy because the vitreous was clear, retina was attached. The guy came back 2 weeks later and he said, Doctor, I can read with this eye. So then he had a secondary intraocular lens implant as well. So the point is what we all emphasized before, don't give up. But it also connects to what you heard about teaching. What you teach is not only how to do this, but you also try to convey a mentality, which is we have to provide the best we can to every patient. And here again, and this is not a typical problem in the world, but in India it is. You have so many poor people who cannot afford to undergo sight-saving procedures. So to offer a clinic where that's available is another incredible thing. So what I encourage all of you is to use him, because I'm leaving in 2 days, but to use him to learn both the attitude, the philosophy, and also the actual physical work of doing this. And I want to repeat what I said earlier. It's wonderful to do 100 cataracts, but you don't get such an incredible reward from an individual trauma case, cataract, as from a trauma case, where your emotional battery gets recharged by having a case like the one I described. And I have several stories in my life where I said, I'm so glad I went into this field. And even though I invested a lot of energy and time and money, etc., to learn and to fight dogmas, etc., but these people who gave up hope and all of a sudden they were given back the sight is an incredible thing. So follow the path that he created. Thank you.
I now invite Dr. Sunil Morekar sir on the dais.
Okay. No, I'll just finish it first.
You can sit here. He wants to leave, saying. So 5 minutes only. Then everybody will go out of time. Finish it here. Come on. No problem, sir. It's few minutes. Madam, come. You can start here. Good, because please do it. Come on, so don't waste time.
Okay.
Everybody is hungry.
Fine. I'm sorry, I'll just finish this off very fast. I'm really sorry, and thanks for inviting me. I'll just go through that. These are the hospitals in which I have done this audit, and I thought this is very important, and very thankful that I'm getting an opportunity to talk when all the people who would really implement this future will help here. No disclosures. The parameters we are talking about is epidemiology, clinical audits in terms of ophthalmic results and cosmetic, clinical audits in terms of microbiology changes, cost audits, CPD audits in terms of advocacy, and health technology assessments. Everybody knows about the world data, so I'm just going to rush through this. The rationale is I wanted to talk here because there have been 6 accidents which involved me with orbital trauma in 2 cases, and practically probably would have lost my vision had it not been for ophthalmic surgeon. I'm thankful to Dr. Natarajan for being there for all these accidents, taking care of me. The importance of data, it's basically necessary for planning custom-made preventive strategies and focus on key issues identified in geo-economical data. These are our audit cycles over 25 years. I'm not going to go into the details of it. It's roughly around 1 crore patients with major trauma over 15 hospitals, and 4 of them are MGM group of hospitals. And the data is absolutely the same as international data, so I'm going to rush through it. 75% men and all. I'm not going to go into the details of this. I'll just go to the clinical cases. Results are common in injuries in men. Close group were less severe. Everybody knows it. The thing is that the accident severity index was more in Navi Mumbai compared to Mumbai because the traffic speeds are higher there, and so you would have to probably do more interventions in New Bombay because most of the patients from Navi Mumbai used to come to Sion Hospital straight. But now we would like to have outreach people coming from Sion to those places, and probably MGM would also help. Those are the univariate analysis of this thing. I'm going to rush through the presentation so that I don't keep everybody. The issue was that multiple specialties are involved, and so I would agree to Dr. Kuhn and say that you probably deal with all of it at the same setting. So this is ptosis with lid repair with 7th nerve palsy. From pole to pole, I belong to those categories. And we compare our data with other places, and you see that trauma data in various regions are different, and 58% of all the trauma deaths are preventable. Our data compared with North India, South India, rural Nepal, but there is a lacuna about Indian data in metro cities. We also compared it with other countries, Singapore. And we realized that there's an absence of long-term data. So that is where the eye gates and what Dr. Kuhn and Dr. Natarajan do is very important. Basically, that is an audit, and that is something that is extremely important, and I would want all of you all to be a part of it. That's exactly what I wanted to say here. Long-term data is available of only one study of 5 years. The developing data, developing world data and the developed world data is completely different, and that is why everybody needs to get involved. The microbiological audit over the last 15 years has shown me that there are microbiological organisms which are different in different places, even intra-city and between two cities like Mumbai and Navi Mumbai. And so there's a role for routine microbiology in some cases. This is a patient for orbital melioidosis. So you have patients of Burkholderia pseudomallei which just do not go away unless you remove the necrotic tissue, and that is something that we see more common along the beaches. It was very prominent in Thailand, but now we see it along Juhu Beach and other places where in Navi Mumbai we see that. The infective agents differ in different countries. This is a patient who came to us 10 years, he was absolutely fine and suddenly had the eye going up and proptosis with an implant, and it turned out to be a cold abscess and tuberculosis. So tuberculosis is something that you really want to take care of around this area, because Sion and Dharavi have a lot of Hartmann's and TB is very, very, very prominent here, and that is where the medical college here needs to do. So these are the other things that we talk about. Is mensuration in Indian population is different, and so your orbits are different, and so you need to treat things differently in India and not look at just the Western population and the Western measurements and implants. I'll run through that. These are some of the cases. This is a medical student of mine who's a past student from MGM Medical College, and he was brought as a John Doe. Nobody knew who he is. And I used the statement which Dr. Natarajan said, and somebody told me he was unconscious, and somebody told me, sir, gaya hai patient. And I said, no patient is gone. Dr. Natarajan said, no patient is gone, never give up. And a weak voice came, sir, is that Dr. Morekar? And then I said, yeah, so you recognize me? Sir, I'm your student. And he didn't remember his name. He just remembered, Dr. Morekar, I'm your student. And we got him out of it. He's married. He's absolutely fine. These are the amount of plates and things that we have put in his eyes. And then there are other cases like electric saw injuries. So these are the audits which we have done. And what is important here, all I wanted to say was, when you look at these kind of injuries, degloving injuries where somebody is sitting pillion and is dragged in a street, then you look at multiple associated injuries. I will run through all of these. Canalicular injuries, NOE has already been dealt with, sac injuries with transferal, and all layers of the eye need to be seen. Orbital fracture, and we were talking about CSF leak, and then the eye looks quiet and white and nothing wrong, and white eye patient here, but you realize there's a hyphema there, and then you also realize that there is a traumatic lens dislocation. This is a presentation in which a patient came to me with this, and I, as a plastic surgeon, I have done a very good job, inverted commas, according to me, and I thought that he's not going to get a scar and he's going to look extremely wonderful, and his girlfriend was worried about how he would look. What I happened to miss in this case is there was an orbital fracture and optic nerve injury in that eye. So look at every layer is what I wanted to say. Some patients you might just have to remove the bony chip, other cases you will not. So when you look at your audits, you realize which case to touch and which case not to touch and when to touch, as Dr. Kuhn has already said. There are some hypoglobus cases. And then cases like this where it was a complete blowout, and we actually didn't look at the Glasgow scale, and we did the surgery. The patients paid 10 lakhs, but he died after 5 days. So some cases where you should not be handling. Now you want to do other things like endoscopic innovations. So we do endoscopy, and we also look at robotics. And why do you want to innovate? Because it's more precision, but you would have to look at the technology assessment and realize that I might do it at Apollo Hospital or Lilavati Hospital, but this is something that not everybody will be able to afford. There are definitely cases where I have also sutured nerves. So when we do a traumatic fifth nerve injury and a transected nerve, you suture the nerves together. You also do corneal reinnervation with a robot, and that does it. So there are newer technologies available, and they have many other advantages. They're custom-made products. I'm going to run through these. I think finally we come to look at the cost effectiveness and the cost effective analysis, and then look at how much it is going to cost, and artificial intelligence now can be used. And we also look at how we are going to talk to the press and get it. And then you look at the audits of the hospital bills and how much is it cost. And then most important here, there's a man behind the eye. And so you look at the patient satisfaction scores, and this is an audit that you need to do. So you might realize that You do some surgeries, you do it well, but you think that you did it well, so you have to audit it and get an external auditor. For me, it is Dr. Natarajan, Dr. Karovileri, and Dr. Usha Jori. Four of them are my lifelong teachers because they keep auditing me. I keep taking cases back to them. And that is what I wanted to say. Thank you very much, and thanks for the opportunity to give me to talk when all the audience is on the thing. Thank you very much. God bless you. Oh, sorry.
I would like to invite Dr. Naina ma'am on dais.
Okay.
Good afternoon, everybody of the April, and sir is candidate number 29, and along with his Parivartan panel, which I think will really make a big Parivartan in the various MMC future things. You have to vote 9 people, and if you want more insight, sir, can I request you to tell about it? And before that, let me give you a small profile, very little profile, what I know. That sir has been the Dean of Cooper Hospital, and presently he is with us at Nair. He has been the Medical Superintendent at Nair, past Vice President in Indian Academy of Forensic Medicine, ex-member Quality Assurance Committee for Maternal Deaths in Mumbai, faculty for Maharashtra Judicial Academy, faculty for Disaster Management course, past member of Curriculum Committee of MCL, expert on MPSC board. Also he is in the Board of Studies at MUHS. Sir, please guide us. Thank you.
Thank you for the opportunity. I'll just take exactly 1 minute. Why I decided to stand for MMC election is one, I planned to stand for contest for MMC elections. I had done last time also, but that time I had done it solo. This time I decided to go in a panel. The last elections were held in 2016-17 for 5 years term. Last 2 years there were no elections, so it was the administrator was looking after. Being a dean for last 3.5 years, I know what are the problems of undergraduate, postgraduate practitioners, because we have some faculty who is into private practice. So what are the issues the private practitioner faces? Cases of negligence, the number of almost 700 cases pending, how evidences are recorded, etc. With a legal background and being a postgraduate in forensic medicine, I thought I would be able to do a better job. In government service of last 35 years, we have dealt so many cases of negligence, have been on various audit boards. Recently also High Court has set up a committee for social audit of all maternity homes. I am part of that committee as well. So my request is to kindly come and vote. You can vote for any of the 41 candidates who are contesting, but I would make a special request to vote for me and our Parivartan panel. This panel comprises of, there are 2 deans, there are intensivists, there are forensic experts, pediatricians, there are past IMA presidents, etc. And all have done lots of social work and have worked on various committees, and therefore we felt that we would do a much better job together. Single-handedly, if you go to the council or anywhere, and if you do not have majority with you, you cannot take good decisions. Thank you very much. And I request you to kindly, Naina will share our flyer with you. Please spread the word among other doctors and ask them to come and vote for us on 3rd of April. Thank you.
Thank you, sir. I would like to invite Dr. Karovileri ma'am.
Hi, good afternoon. I know this is in the middle of the program, but a small vote of thanks to be given, because nothing is ever short of gratitude. Our heartfelt gratitude to Dr. Ferenc for traveling all the way from Germany to be here with us. And his visit to India not only involves sightings at Tadoba, which he did just now, but he also cited a lot of eager minds over here, small cubs who are waiting to imbibe all his pearls of wisdom that he has so patiently told us. Thank you so much, sir, for being here with us. The next person whom I'd like to thank is Sion Hospital and their Dean, Dr. Mohan Joshi, who's very close to ophthalmology, and Dr. Chaya Shinde, who has worked relentlessly to make this program happen. And thank you, Chaya. It's very nice of you to do that. And then and all the students who have helped her in this endeavor. I thank Dr. Mohan Joshi also for always being a part of our Polytrauma meetings wherever it is held. Special thanks to Dr. Sailesh Mohite for also coming, Dean of Nayar, also for coming over here and gracing this occasion. And sir, I wish you all the best for your MMC elections. I am sure your Parivartan panel will win. A special thanks to the committees which have always been our strength, that is the Maharashtra Ophthalmic Society, the MUHS, the OTSI, the ISOT, APOTS, TOSI, and these have, and all their office bearers who have always been beside us for any of these Polytrauma meetings. A special thanks to Dr. Natarajan, who makes all these things happen, and also to his Kamala Sundaram Foundation, along with Auditorium and Sundaram Blind Free India Foundation, because it helps in propagating knowledge across to all the students and the inmates of Mumbai. And other thanks to Dr. Usha Johri, Dr. Nikhil, Dr. Smith Bavaria. A special thanks to Joseph, without whom we are all lost, and also to Samir and Namrata and Ashlisha. We thank our sponsors also, Entod, Care Group, Bosch & Lomb, and Alcon, who have sort of helped us with this CPD, that is the Continuing Progressive Development Program. And with these small words, I wish to thank all you people who are here, because without you, we are nothing. Thank you so much.
So I thank Priyanka, no? No, Priyanka did. What's your name? Kushi. I thank, with both Kushi, I thank Kushi and Priyanka for doing the Master of Ceremony, and thank the Sion Hospital. We can break for lunch. It's 1:40. So we will assemble back by 2 o'clock or 2:10. Madam, 2 o'clock or 2:10?
2 o'clock.
Huh? No, 2:10 bol raha hai. Madam saying 2. No, it's 1:40. 2:10. Madam said 2 o'clock, I said 2:10. Okay, 2:10, the talk will be by Dr. Kerovilairi, and after that, Ferenc, right? So thank you very much, and please come back by 2 so that we can settle down and start the talks at 2:10. Okay? Thank you. Thank you, madam. Thank you, sir.
We talk about injuries with intraocular foreign bodies. And I want to make a distinction between foreign bodies that are acute, it just happened, or foreign bodies that are found later on. General rule, if it's an acute foreign body, remove it the same way, or treat the eye the same way as you would without an intraocular foreign body. Do the surgery, and I want to emphasize, it's a complex surgery. Foreign body removal is not the goal of the surgery. Reconstruction of the eye is the goal, and foreign body removal is part of it, because we want to preserve anatomy and vision. So this is the primary prevention. The secondary prevention, of course, is chemical injury, siderosis, and as I mentioned earlier, to prevent PVR just as you would in an eye without a foreign body. So this is an example of an acute foreign body case. Very important to detach the posterior hyaloid. This is an old video. Today I would use triamcinolone, as you saw on some of the videos wonderfully, because we are the agents of vision, and you want to see the tissue that you are dealing with. So you can see that this foreign body is actually incarcerated in the retina. You can also see how the vitreous was attached to it. I use this older video to explain certain things that you may not do today. I did use diathermy to go around to make sure that I get no bleeding. And then this is very important. I'll try to stop the video if I can here and there. So it is very important that before you try to extract the foreign body, it has to be 100% free. No connection to vitreous, no connection to retina. Because, and I want to stop here for a second and tell you something more general. To me, the very basic rules of eye surgery are three. One, you already heard this, planning. You have to have a plan, and in a trauma case especially, plan means you know where you are. In other words, you have a rough idea of the condition of the eye before you start surgery. And then as you look at the injury, you have a rough idea of where you think you can be at the end of surgery. Planning means how to get from this to this. It's very similar to driving in a city that you don't know. You don't just start driving and let's see if I get there. You want to have a GPS or a map or something that you roughly know how you will get there. But just as in this case, where there might be a street that is closed, there is an accident, so you have to change your plan. It's very similar to the eye. When what happens is not what you wanted, you change your plan. So plan is number one. Number two is control. What is control? Everything that happens inside the eye happens because you wanted it to happen, and nothing should happen that you did not want to happen. That's the ideal situation. Sometimes it doesn't. You're not successful because complications happen, but as a general rule, control is very important. The third rule, I already told you, asking the why question. So coming back to the foreign body removal, control means, again, the foreign body is completely free of any attachment to something else in the eye before you take it out. If you take it out before that, what you do is you give up control. It's not going to be you who determine what happens, it's nature, and usually nature is not your friend. So why I stopped the video is because this is something I very often see as an error. If you look at the eye wall in the back, it has two layers. It has the sclera and then it has the choroid. What you do is you take a blade and you make an incision in the sclera and the choroid. The length of the incision is determined by what? The cross-section of the foreign body. This is very important to emphasize because very often you hear how long the foreign body is. We don't care how long the foreign body is. We care about the cross-section that will present into the wound. How do you measure that? in the older literature, they said you look at the size of the disc. It's not accurate. Your instrument is accurate. You know the size of the instrument that you put inside the eye. So if you do a 23 gauge vitrectomy, we know that that's 0.7 millimeters. Next advice, never make it too small. Nobody will give you an award that you used a very small wound. What you want is the foreign body to come out at the first attempt and not get lost. So first of all, before you do your incision in the sclera, you have to know that it will be 2.3 millimeters. And again, a little bigger is not a problem. A little smaller can be a problem. But that's not enough. Because if you look at the sclera is a rigid tissue. If you cut 2.3 millimeters and then you measure it, a minute later it is 2.3 millimeters. But the choroid is elastic. So when you look into the eye, before you do anything else, after you made the incision, you will see that the choroid is already contracting, and while the scleral wound may be 2.3, the scleral will be 2.3, the choroid may be 2 or 1.8. That's why some people lose the foreign body during extraction. So what you see on this image now is once you did your perfectly sized scleral incision, you take venous scissors and you go inside and cut the choroid at both ends. So let's see if I can restart the video. So that's what you see here, cut on one side, cut on the other, and now you introduce an intraocular magnet. This is what I use. I invented this magnet because it's very powerful. It does not lose magnetism with time. It's directional, so the force is stronger in front of than on the side, and never lose a foreign body doing it this way. So this is what you do with an acute foreign body. But if you have a chronic one, something that you discovered accidentally, then another question arises whether you remove it or leave it in place. If it's a ferrous foreign body, you tend not to leave it behind because of the risk of siderosis. But even if you do, you have to follow the patient, etc. So you have to discuss with the patient whether it's preferable for the patient to leave it or remove it, because both have advantages or disadvantages. So here is a young guy who did not know that he had a foreign body. So what do you do in these cases? I discussed it with him. He said, I want surgery. He has full vision, but you can see the foreign body is very close to the fovea and it is encapsulated. The capsule does not prevent siderosis. So you do as I said, I'm sorry, let me stop this one because this is very important also. So if you look at the literature, this is one of the other dogmas. And this is one of the reasons you may read about the 10 days, 2 weeks after the surgery to do the vitrectomy, because, I'm quoting, by then the posterior hyaloid will detach. So I'm telling you, it does not detach. Forget about it. This is a very good example. We are 1 year after the injury, the posterior hyaloid is still there. And it's absolutely mandatory to remove it. So here now you see that I put triamcinolone to mark, not stain, because it doesn't stain, it marks the hyaloid. You can do the traditional technique when you aspirate In this case, I did it for a couple of seconds, it would not come. So I use an MVR blade. I put a little hook on it, and I drag the hook over the retinal surface to pick it up. Okay, so let's go back to...
What time you want me next week? What time you want me next week?
Shut up. I'm sorry, but it's difficult with this to... Okay, so here you see, and I'm using a contact lens. That's why the picture is on the left or on the right, the macula, because you need high resolution with the blade, not to go too deep. And then you detach the hyaloid. And now the next step is, as I said, to concentrate on the foreign body. In this case, because I wanted to avoid having a macular pucker, scar formation on the retina in the back to occur post-operatively, I peeled prophylactically the ILM. That's not something that you would do in the majority of the cases. And see, now you have to use sharp tools to open the capsule. And this, I'm not a very slow surgeon, but this was 10 minutes altogether to use that hook, scissors, blade, to make sure that there is no connection between the foreign body to the capsule and the capsule to the retina and the choroid, because you don't know what is under the foreign body at this stage. So you do this until you are absolutely certain that the foreign body is completely free from any connection, as I said, to all intraocular tissues. So this is scissors. I'm not cutting. I'm just using the blade to lift carefully the foreign body and get it from under the retina onto the retina. And notice that I did not use diathermy in this case, because that would just increase the size of the scotoma. Now the sclerotomy, I do not use what most surgeons do, an existing cannula. I use a fourth incision because then you have to resize the wound, which is difficult to put it back. So this is simpler. You can see again how you cut the choroid. You take the magnet, take it out, very similar to what you saw in the previous video. I'm trying to go faster because this is the same thing. Then you close this incision, and then I use this surgery which I invented about 25 years ago to prevent PVR coming post-operatively, because remember, this patient has full vision. You really don't want to destroy his previous vision. And this chorioretinectomy kills the RPE cells that would cause the PVR formation. And then I put air, nothing else, just gas into the eye. And fortunately, the vision remained the same. And what is very interesting is you can see the blood vessel that became patent even after. So, this just shows you have to know what you use your tools for. So, any questions you have about this talk or the previous one? We have maybe a minute or so. And if you're interested in this book, everything I told you is described here. Okay?
So yes, a minute for questions. And
I'm sorry, you have to use the microphone because I can't hear it. And nobody can. Yes.
So it's an encapsulated foreign body, right? And likely it has to be iron, so ferrous element. So why won't we do a ERG and see the B by A ratio and then decide for the removal of the foreign body?
It's a very good point, and the reason is, imagine yourself. You have a condition inside the eye, and your physician tells you to come back for a follow-up. And initially, I don't know how much there is science behind it, but traditionally we say come back 3 months after, and then we'll see the ERG. And you come back and there is no siderosis. You come back another 3 months later, no siderosis. Your incentive to come back for another follow-up after 3 months again, when you have to, travel, you have to take a day off from work, etc., it goes down. And then when siderosis starts, it doesn't cause any symptoms. So it's simply because of the difficulty of maintaining the patient's interest in coming back to you, why I tell the patient that's one option, but you have to promise that you will come back, or surgery. And then the patient decides. If the patient says ERG, I said fine. If the patient says I can't, I won't, let's do the surgery, then it's surgery.
Sir, when do you cut the choroid? Is there a chance of bleeding?
Okay, very good point. Very briefly. I was operating on a child 25 years ago, who was injured with a dart. The dart went in and out on the other side, the tip. So perforation of the eye. If you look at the literature, this is the injury where you have an 89% chance of PVR, and this is a child. So when you do the traditional surgery, which is you do the vitrectomy, and then you do laser around the exit wound, it looks beautiful on the table, and then the patient comes back in 2-3 weeks, and there is PVR and the eye is gone. And I still remember sitting at the operating table, and I said to myself, I have to do something different, because I want the eye to look good 10 years, 20 years, not now. And then all of a sudden the light bulb, because when I did surgery for melanoma, where you remove the tumor with the vitrectomy probe, one thing that you do is you go around and you destroy the choroid, not just retinal bleeding prevention, but choroidal bleeding prevention as well. And when I did my first case, which is 30 years ago, I expected a lot of PVR. There was no PVR. So when I did the boy, I said, what if I do this prophylactically? So what you do is you take your diathermy machine and you turn the power to 100%. And you don't just touch the tissue, you keep it there. And when you do that, you will see bubbles. The bubbles tell you that tissue evaporates. So there is no choroid, there is no retina left. When the patient comes back after a couple of weeks, you see bare white sclera. So the answer now, no bleeding risk, because the power. But the reason why you do that primarily is not the bleeding issue, it's you want to kill the cells that would cause the PVR. Okay.
So I had a question for you.
Yes. Here, you can use this mic.
Thank you, sir. So in your vast experience, is there any finite time that you've seen siderosis occurring in a metallic foreign body? And in your case, which was 1 year, it did not happen probably because of the PVD not happening, or that was just coincidental?
So it was a metallic foreign body, and the risk of siderosis is lower if you have a capsule, but it's not zero. So just by having a capsule around it does not prevent siderosis from occurring. Siderosis can occur within a couple of months, or it can occur within a couple of years. So that's why the problem of coming back for an ERG is so big, because if you tell the patient come back every 3-4 months for years, they will say, I have no symptom, why should I come back every time? Okay? Yes. So again, I'm not telling them we have to remove it. I'm telling them these are the options, and if you are okay with yourself that you will come back, that's fine. Because you have to tell the patient there is a risk of surgery. You can have a bleeding during surgery, PVR, So it's not that one is great, one option is great, the other is terrible. Both have advantages and disadvantages. Okay.
So one more question. So what is the maximum cross-section in an irregular foreign body where you would choose to do a limbal, not a scleral removal?
That's an excellent question, and now I will tell you I don't know. Because it's very difficult. So I can tell you some thoughts to consider. The first is the lens clear? Is the patient young? Now, if you have a patient who's young, if you have a patient who has accommodation and a clear lens, and you tell them lens is out, it's, it has downsides. On the other hand, if you want to make, this big an incision in the sclera, that's also not. So it's a judgment call where you really have to make a decision at that point based on these considerations. I cannot tell you in millimeters. Fortunately, it's very rare to get a bleeding from anterior uvea. So, but on the other hand, if you go and make a very long incision, the eye pressure drops, and then there is a risk of a hemorrhage too. Yeah. So, whatever you think is best.
Thank you, sir.
Yeah.
Thank you so much.
Okay, thank you very much for your attention.
Thank you, Dr. Kuhn, for another enlightening lecture and for answering the questions so succinctly. And may I invite Dr. Lahadi ma'am again for a lecture from the previous section.
Good afternoon. My talk is on pediatric trauma. Now, pediatric trauma, posterior segment trauma, accounts for about 15% of overall trauma. And injuries in children are very complex because the problems that generally relate to postoperative inflammation, the occurrence of a tractional retinal detachment, the occurrence of PVR, as sir has been suggesting till now, and subretinal membrane formation. These things make the thing very complex, and therefore it has to be done at the earliest. Now, the list of injuries of the posterior segment are, it can create a vitreous hemorrhage, there can be retinal tears, commotio retinae, choroidal ruptures or detachment, macular hole, avulsed optic nerve, subretinal hemorrhages, and retinitis sclerotiria, with or without intraocular foreign bodies, which can be magnetic or non-magnetic, and this also can be complicated by the presence or absence of endophthalmitis. Now, posterior segment injuries don't occur on its own. Most of the times there are anterior segment injuries, which include hyphema, angle recessions, iris disinsertions, lens injuries, scleral or corneal tear, orbital fracture. And what is to be done, whether it has to be done in one session, it has to be done over 2 sessions or multiple sessions, depends on your discretion, what you think is most important at that point of time to do. Now, let me just tell you kinds of trauma. Now,
this is not a general classification, but according to me, there is something visible and there is something invisible. Let's talk about the invisible trauma. The invisible trauma is in children where you can get a shaken baby syndrome. Now, as I say, in a shaken baby syndrome, there is no visible trauma. The parents don't give you the history of parents or caregivers, they don't give you the history of shaking, either because they don't know it or because they want to reveal it. It is generally a suspicion-based diagnosis, and an interrogation is always necessary for this form of trauma. Whereas the visible trauma, there is intentional, which is a battered baby where somebody does it on intent. And there is an accidental trauma, which is because of multiple causes like road traffic accidents, falls, injuries, with sharp objects, hit with pencils. Then sometimes files can give you this violence, submersion, or fires. These are all the causes for accidental trauma. Now, just to show you what a shaken baby, how it occurs. In a fit of anger, the caregiver or the parent shakes the child, and it is this effect of the child shaking which causes microbleeds from the dural vessels. These coalesce and they become a larger pocket, and these larger pockets then form a large amount of hemorrhage, which then percolates into the eye to give rise to a subhyaloid hemorrhage. These are SBS victims, which you see, the glazed kind of look that you see in their eyes, bizarre. And mind you, these are children who are born normal, and these are children who have not had any problems during their birth or the few years that they have, or few months they have survived before this incident. So suspect it if you see it. Eye findings generally run to hemorrhages in the anterior segment and hemorrhages in the posterior segment, as you see over here. And other things can be detachments, choroidal detachments, and retinoschisis. Now the types of injuries, these are several ways by which a child can get injured, either punching or a catty or a cricket ball or a pencil, or just the fingers of another child poking into the eye, or these darts which are made with paper, or files. You give just a file to a child and he just slashes his eye with it because he doesn't know what is happening. Now this is an example of a pole-to-pole surgery where the child has been hit by the cow horn, and this is the lid injury sutured, the scleral tear sutured, there was a cataract which was removed, and then the vitreous surgery was done, and the vitreous surgery with a belt buckle was done, and initially the retina settled. But over a period of time, the patient developed a fold across the macula, which had to be reoperated, and this was the outcome at the end. Now, other forms of injuries are the cracker or the blast injuries, because during our Diwali season, this is something which is known to happen. Again, it can just disfigure the entire eye. The anterior segment could be affected only, or a combination of both segments. Then there was a period where there was a Mahabharata serial going on, which was way back in the 70s, 80s, where, these children, they used to make little bows of broomsticks because they used to see it in those serials. And that is how many children had got injured with these kind of broomsticks. And it gave rise to fungal endophthalmitis. I was a fellow at Shankar Netralaya at that time. So the thing is that I have borrowed this from Dr. Natarajan, who was practicing then. And this is one of the bow and arrow injury cases, which he has gracefully given me to show in this. This is a wound of entry, and if you see that he extracts a very large, long foreign body from the eye. Now, traumatic detachments comprise of 36 to 46% of the total posterior segment injuries. The duration can be 1 day to several years. Now, why I say several years? Because many a times children, they hide the fact that they have had an injury if the parents have not noticed it. And second is because if one eye is functional, they do not realize that the other eye is this, unless, accidentally it's closed or they go in for an examination. This is more common in males, unilateral, sometimes bilateral, and greater involvement of the inferotemporal quadrant. And if you see sometimes in these late cases, you get these inflammatory membranes on the surface of the, this was overriding the macula, which then has to be peeled off because that was the only thing which was abnormal in this case. Now, this is another child who had a fall on a stone. The child was wearing his glasses. So after a primary repair, the whole surgery was done because the child had a vitreous hemorrhage, probable pieces of glass in the eye. And the thing is that there was no way of knowing how many pieces had gone in. So this is a surgery which highlights that, where the corneal grafting had to be done. First, a temporary keratoprosthesis was put to, the first glass foreign body which was visible was removed. Then the temporary keratoprosthesis was put in. And after that, the vitrectomy was commenced, where you see it through the keratoprosthesis. The view is very nice. And after clearing up the blood, lo and behold, like a Pandora's box, there's a second glass intraocular foreign body, which is there inside, which was also then, the TKP was kind of released in the upper part, and that was removed. And then you proceed with the remaining part, where this is the PFCL getting injected into the eye, and then this is completed with a corneal graft. So surgical treatments for these cases can be, depending on what kind of injury you're dealing with, what kind of patient you're dealing with, it can be done over 1, 2, or multiple sessions, which you have to prognosticate to the parent that you are doing your best for them, but you do not know how many times the child will have to come back onto the table. Generally a primary closure and a USG, followed by a second surgery after about 3 to 4 days. That is 100 hours, as Dr. Ferenc says. Earlier they used to think it was 14 days, but now the earlier you do it, the better. Dialysis without a PVR, you can only buckle and get away with it, because children, it's very difficult to detach the PVD, and also it is better. If it settles with a buckle, nothing like it. In giant retinal tears, RD with PVR, you have to do a vitrectomy, membrane peeling, FG, endolaser, silicon oil injection, gas injection, and buckle. A PFCL is normally used. If there is an IOFB, it is removed early, especially if it's iron. If the lens is injured, you do a lensectomy or cataract removal with or without IOL in the first stage, and you may put in the IOL later. If there is an endophthalmitis, you combine it with an early surgery. In a 1 or 2 stage, you have to tell the patients. And macular holes are also operated soon. So the factors which limit visual recovery are delayed diagnosis, macular involvements, pre-existing problems in the eye, injuries coexisting with the trauma, and the most important thing in the rehab is the amblyopia, which you have to tackle. So prevention of pediatric trauma is by supervision, by parents or caregivers. Keep sharp and pointed instruments away. Keep kitchen equipment, pencils, arrows, pointed sticks, broomsticks, files, all away from children. Specifically, you have to do that. Commitment by health workers, public education about firearms, automobile safety, burns prevention, pediatric life support systems have to be in place. Legal issues and law enforcements have to be energized, because many a times we find in shaken baby cases, nothing is done on the legal front. So in summary, I can say less successful functional and anatomical outcomes of RD, especially if it is delayed. Specific treatment strategies are advocated. You have to tailor make whatever you're going to do as your case requires, and you have to plan it all well in advance. Early referral and complete examination avert future and adverse events and give a better quality of life to the child. Thank you so much for your patient listening.
Ma'am, that was a very comprehensive and Very nice presentation. One quick question for you. These injuries which are preventable are the sports related injuries.
Right.
So what do you feel is the role of protective eyewear? Because sometimes the patient's parents will say if they wear glasses, the glass piece may break and go in the eye.
Yeah.
So it's a double-edged sword. What's your take on that?
No, generally a protective eyewear is always advocated, and there was one of the talks which earlier which dealt with the protective eyewear because it helps. Because see, the thing is the impact of whatever your shuttlecock or your blow ball on the eye is much lesser because there is an kind of medium to take care of that kind of impact. So I think wearing it is always a better idea than not wearing it.
Thank you. Any other questions? Any questions from the audience? I think it was very well covered. Thank you so much, ma'am.
We invite our next speaker, Dr. Abhijit Kare, Ocular Trauma versus Appendicular Trauma Priority. May I request?
I couldn't have got this plug from anybody better.
Yeah, exactly.
I'm father of ophthalmic trauma.
I think we need a couple of pictures because this is special.
Very special. Thank you so much.
Thank you, sir. Dr. Abhijit, please.
Good afternoon, everyone. I am like a cat amongst the pigeons, and thank you for the Ophthalmic Society and Dr. Chaya Madam in particular for this opportunity. So my talk is ocular trauma versus orthopedic trauma, how to prioritize. So there is no blanket rule which should be taken first, but it depends entirely on the specific nature and the severity of the injury. Seemingly a minor eye injury may be a vision threatening. However, a complex looking limb extremity injury may be stable. So this decision has to be done on case to case basis. When it comes to managing this trauma, usually these are polytrauma patients, and we follow the rule which has been taught to us right from our MBBL days. A, B, C, secure airway, breathing and circulatory thing first. Then if you find any bleeding point either on the eye side or in the upper or the lower limb, do secure hemostasis, and if the patient has an altered sensorium, it's better to manage that first. If we analyze the mortality amongst these polytrauma patients, 50% of these patients die within first few minutes of their injury, even before reaching the hospital. This is usually because of massive blood loss or neurological injury. 30% of this patient die within a short time of arriving in the hospital, mainly because of unmanaged shock, hypoxia or neurological injury. And the remaining 20% may die either because of multisystem organ failure, infection being a leading cause. So the concept of golden hour was introduced. This is the time when life-threatening injuries should be treated promptly in order to decrease the mortality and the morbidity. 60% of the deaths occurring in polytrauma patients are avoidable. This golden hour is usually the first hour when the patient presents to us. This we have been learning this chart right from our UG days. A new concept has propped up which is known as damage control orthopedics. Whenever you see an appendicular trauma, just don't rush in and nail and plate everything on day one. What is important is to assess the general condition of the patient. Say for example, a bilateral shaft femur. Just don't go in and nail both the shaft femur. Put them in external fixator, which is a 15 plus 15 minutes job. Wait for at least a period of 2 to 3 weeks. Let the inflammatory response settle down. If there are associated injuries, they should be managed first, and then go down for the second surgery. So stage definitive management followed by stabilization, initial stabilization, and then definitive treatment. Pelvic fractures initially treated on external fixators can be managed with internal fixation 7 to 10 days after the index surgery. Whereas for the lower limb surgeries, we can wait up to 3 weeks, and for upper limb up to 7 to 10 days. Now, prioritizing ocular trauma and appendicular trauma, is there any rule to be followed? Yes, ocular trauma can be divided into high priority and low priority. By high priority, we mean potentially vision threatening, whereas low priority is where, yes, the patient will need treatment, but not immediately. In a similar way, orthopedic trauma can also be divided into high priority and low priority. A high priority orthopedic trauma is the one where the limb is at risk of survival or the function of the limb is at risk. And low priority is again where the surgery is indicated, but again not on priority basis. So which are the high priority ocular traumas? Penetrating eye injuries, the globe ruptures, the sudden significant vision loss following injury, chemical burns to the eye. It has been taught to us since our UG days. This is the one condition where you shouldn't even wait for history, but take the patient in first and give a thorough wash. Severe pain in the eye following injury, a hypema, a significant eyelid laceration or entrapment of the extraocular muscles. The low priority ocular traumas are usually the superficial corneal abrasions, the minor eyelid contusions, or the subconjunctival hemorrhages. Coming to the high priority orthopedic trauma, usually open fractures with significant bleeding or contamination. They should be taken on priority basis, and a debridement is essential to prevent septicemia. Vascular injury, so a shaft femur with a popliteal artery injury, it's an emergency for the orthopedic department, and here we can't wait. We'll rush in, we'll fix in the shaft femur first, and then the vascular surgeon comes in and repairs the vessels. A nerve injury associated with a limb fracture is again a priority. Compartment syndrome. If that compartment syndrome is not released within 4 to 6 hours, the patient is at a risk of developing a permanent damage to the muscles of the limb. He tends to lose the function of the limb. This is known as a Forkman's ischemic contracture. To prevent the sequelae of compartment syndrome, it has to be prioritized. Dislocation. Usually the common dislocation in the upper limb, shoulder dislocation, in the lower limb, a hip dislocation. Again, we can't wait. If we wait, we lose the blood supply to the head of the humerus or the femur, and the patient will then require a replacement. In order to avoid that, that's in the golden hour, we should be treating it early. Crush injuries again should be prioritized. The low priority orthopedic injuries are the stable fractures without any neurovascular injuries, sprain and the strain patterns, and the laceration. So this was a case of proximal femur fracture with a vascular injury. The superficial femoral artery was injured. We went down, we stabilized the fracture, the vascular surgeon takes over, repairs the vessels, and then the injury takes its course. This was a case of D11, D12 fracture dislocation. You can see that the spinal cord has been severely compressed again, and it becomes an emergency. We go down and stabilize it early. These were the appendicular injuries associated with ocular injuries. Since we work at this high volume trauma centers, we keep getting different kind of injuries. Even literature supports the views that I have just proposed. So what is the take home message? Follow the principle of first restoring airway, breathing, circulation. Prioritize injury with the highest potential for permanent functional loss. In many cases, significant ocular trauma has a higher immediate risk of permanent vision damage than appendicular trauma. Consider the urgency of intervention, assess the neurovascular status in both the cases, ocular as well as appendicular traumas, and when in doubt, usually err on the side of caution. That was in short about the vascular, about the appendicular and the ocular trauma. Thank you for your patient hearing. Any questions are welcome.
Thank you so much. That was very interesting, and that reminds me why I didn't take orthopedics. Let's felicitate sir, please. Sir, please. After this felicitation, we are going to have one felicitation for Dr. Natarajan sir. May I request Chaya ma'am, Naina ma'am, Karobi ma'am, Usha Johri ma'am, Sujata ma'am, please come up on stage. Ma'am, you have to get the award. It's with you. Le lo photo. Sir, one step forward, please. So Manish will tell us what are we felicitating Dr. Natarajan for.
I'll Well, Bombay Ophthalmology Association is a body which has been conducting academic programs for the last so many years, and all the postgraduates as well as all the consultants are well aware. And there are certain people who have really contributed immensely to educating ophthalmologists in not just in Mumbai, not just in Maharashtra, not just in India, but all over the world. And it's a proud honor and privilege that we have Dr. Natarajan, who's one of them. And this award is called the Hall of Fame in Ophthalmic Education Award, which Bombay Ophthalmology Association is really proud to present to Natarajan sir. I will read out: a beacon of wisdom, a mentor to many, and an architect of excellence in ophthalmology. Your contribution to education is truly legendary, sir. For decades, you have nurtured young minds, instilled knowledge, and fostered the spirit of inquiry. Your dedication, patience, and passion has left an everlasting impact on the profession. With immense gratitude, we honor you for your outstanding service in shaping the future of ophthalmology with brilliance and integrity. And I would request the women power of ophthalmology in Mumbai to present it. I think it's a double honor, sir. You are getting it from them.
Facing you, facing you. Come, sir, you come. Yes.
Suddenly, Dr. Smith called me and said, come back. I was going to the live surgery, and because I have to start the live surgery. How many minutes you are delayed now?
So it's okay, we'll wait.
No, okay. Okay. No, anyhow, I have become speechless because BO is my, I don't know, I will cry. The survey. Thank you so much. No, yeah. I'm really emotional because whatever I do is for Mumbai, and I love Bombay. But I came from Madras to Bombay, and I love Bombay. And I think the day I came, I became a life member, and that's in October '88. And I also became a life member of Maharashtra Ophthalmic Society. And I did my PG. I was a life member of the AOS. So I think I'm speechless. I don't want to use the chat GPT to give me a thank you note from the heart, because I think I have got several awards. I have never become so emotional. Even when the Retina Hall of Fame I got, I know, I went to Dr. Badrinath and said, we both are in the only two Indians in the Retina Hall of Fame. And he said, what did I do? Same question I asked him. I also don't know, sir, what did I do? But I think this is really great, because coming from our own Mumbai and our own Bombay Ophthalmology Association, yesterday I took Ferenc Kuhn to city tour. Every time I learn. I've done the walking tour. I don't know any of you have done walking tour. Any of you have done?
Yes, sir. Yes.
You should do it. You have done?
Yes.
Where? Which part of Bombay?
I've done the around National College, sir. That side.
National College is Bandra.
It was an art walk, yeah.
Oh, no. That's not Bombay.
You are talking about this.
Heritage, right.
Heritage.
So the Heritage Walk, you learn a lot. Every structure. Anybody knows the story of Rajabai Tower? Okay, you should know, because Rajabai is the mother of Roy Chand Premchand, and Rajabai was blind, and they had enough money, richer than I should not, I'm in the mic, the dash British, and they donated the money. And you know what they told the British? You make the clock from London, make it work, and every 15 minutes the chime will be different. Why? Because the mother has to hear. And where was the mother's house? In the fort. And the fort wall was there, and I asked, how can you hear? She said, sir, that time there were not so many cars, so the mother was listening. Every 15 minutes with a different, she knows. And that was only from morning 6 to night, I think 10. So 10 to... Yeah, I know that. I heard yesterday. Even I promised Ferenc will go back and record. I forgot. Tomorrow we'll do it. Tomorrow we are going to... And anybody has gone to Elephanta Caves by speedboat? Yes. Speedboat. Yes. So I should go 15 minutes. But I am saying, I am proud of Mumbai. Every bit of Mumbai I have seen, right from... and how many islands make Mumbai, man? Seven. And that's what I thought till yesterday. I was shocked to learn from that girl. It is 23 islands. And everything was 23. Ferenc was making a... So what I'm saying is, so this is really, it's a surprise, and I think the best award for me in my life. Thank you so much. And I love Mumbai, and Mumbai loves me. I can feel it. Huh?
You didn't mention that you got it from beautiful ladies.
Oh. She's giving me, so for that I need a hug and a kiss. She's telling me to tell something. You know what she told? First she has to give me no. Give me no. Madam, give me. She's telling that beautiful ladies gave you, that's the best honor. I said yes. And the best is my dancing partner. And I'm happy. From Mumbai she went to Madras and I brought her back to Mumbai. And she's occupying my position in Bombay Hospital. I'm very happy. So I'm going to withdraw also from Aditya Jyoth one day and then only do the foundation work. So that's my dream. So I want to keep serving people and teach people like Ferenc. And we also saw the tiger's eyes. But one day I want to operate a tiger. I don't know how, but I will do one day. Because my friends operated in horse, elephant in Germany. So a tiger they have not operated. So I told the chief forest officer, oh, joke, okay.
I think
that one thing all the women in Mumbai should know, the tigress of Tadauba walks majestically like a royal king. Unbelievable. And the women don't walk like men.
I think one thing for all the postgraduates here to learn is, you must always be hungry to learn. And you must always have a bucket list. And, most of us would think, what else would Dr. Natarajan want to learn? But I think he rattled out 3 or 4 things right here. So that's the key to growth, that you have that hunger to keep learning, and we must always get inspired by people like him. Learning and living, yes.
I know. Live life king size, but what's the name? Ferenc Kuhn said, no, not Ferenc. So Steve Jobs said, stay hungry, stay foolish.
Yes.
And I think that's very important. And anyway, I don't like to be like Steve Jobs because I was also like him. Because unfortunately, Dr. G.N. Rao was like that. Dr. Badrinath was like that, giving bad words. Which I hope I will not, but today I did with Joseph.
I don't want to give him advice, but I do have one.
Okay.
When you do the surgery on the tiger's eye, have it under general anesthesia.
But we mesmerized the tiger, You know that tiger came so close to me. And after some time I was very worried because he was looking so staring. And then suddenly I said, okay, like that, and he went. It was so close.
So we have another award here. We would like to honor and felicitate Dr. Sujata. I request Natarajan sir and Dr. Kuhn to please join.
Yes.
Come. Don't move with my partner. Come.
Come, man. That's the idea. We are thankful to Dr. Sujata, the HOD of JJ Hospital, for being our supervisor today.
Observer.
But you are supervising us, no?
No, I'm not.
Okay, observer.
What did you observe? I observed this good community and very friendly. Thank you so much.
Oh, yes. Hi, hello, photograph. Hey, Nikhil, come, man. Manish, don't forget to take you have to be there. Ferenc, on this side. Come. Yeah, you can stay in the center, yeah.
Don't forget to take your child.
So we want this plant to go tall, and not a banyan tree. We saw a lot of banyan trees yesterday. Good. Right, I know. I'll come. I actually want to make an Amsterdam garden there.
Oh, nice.
In JJ. I used to tell earlier. What do we should do? And
Dr. Purva Date is going to be talking about trauma aajkal.
Yeah, and Purva is the best fellow from my side. And before she came to me, she had got the Dr. Venkateswamy Gold Medal for the standing first in DNB. And like Kerubi, she's a dancing partner from when she was in 5th standard? 7th standard. So, and plus her mother is a good friend. So I have 3 generations of my dance partners.
Yeah, I think we need a study on association of vitreoretinal surgeons and dance now.
We dance in the vitreous all the time. And the word vitreous is there in the sheet photo. Pardon? I know. Thanks. We have made and given it to JJ.
Very good afternoon, everyone. I thank BOA, Natarajan sir and Chaya ma'am for giving me the opportunity. I have no financial disclosures. Coming to my first case, it was a 16-year-old boy who had a firecracker injury bursting of a cracker in his hand. He consulted a local hospital and was diagnosed as a bilateral globe rupture and was referred. On examination, his PLPR was accurate and he had multiple injuries including lid laceration, lid tear, scleral tear, corneal tear with iris prolapse. For the right eye, the retina was on and the little bit vitreous hemorrhage was there. For the left eye, there was a retinal detachment. We planned both eye wound exploration, primary corneal scleral tear repair, AC wash under guarded prognosis. On the first post-op day, the vision improved 4 meter in right eye and it was HMCF and PR accurate for the left eye. In both eyes, the traumatic cataract was noted intraoperatively. We planned the second interventions like cataract surgery for the right eye and pars-plana lensectomy, vitrectomy with 240 belt buckle and silicone oil injection for the RD. Secondary interventions were planned after 2 weeks of primary tear repair. Patient was discharged on oral and topical antibiotics. Patient was lost to the follow-up and reported directly with a panophthalmitis kind of picture after a month's time. For the left eye, the vitreous was having dense echos with a high echogenicity. The CRT was raised to 2.56. We planned the piptas with Vozol intravitreally and started with medical management. Unfortunately, the left eye turned out to be a pretheisical eye with PR inaccurate, and for the right eye, we planned cataract surgery with IL implantation. His vision improved to 618. So for the take-home messages, firecracker-related injuries can cause a permanent disabilities in children. Lack of awareness, and especially among the uneducated parents, needs to be taken care of. Strengthening the public education school-based awareness program should be taken and enhance the parental responsibility for the child safety. Coming to my second case, a 30-year-old gentleman came with a gradual progressive diminution of vision in the left eye since 1 month. He had a history of blunt ocular trauma with a metal. He consulted a primary healthcare and took conservative medical treatment for the same. On examination, the right eye vision was 6.6. For the left eye, it was hand movement. Fundus was hazy due to the dense vitreous hemorrhage. To our surprise, the B-scan showed vitreous hemorrhage with total retinal detachment and an intraocular metallic foreign body. We were wondering, there was no clinical wound of entry, so how come the foreign body has lodged? After detailed history, he showed his selfie with a red eye. So at the time of presentation, you can see, and then he had a healed scleral tear at 3 o'clock. We planned a pars-plana vitrectomy with IFB removal and for the retinal detachment, endo laser with silicone oil. So here, after completion of PVD vitrectomy, we localized the IFB. Vitrectomy was completed and inferotemporal, the IFB was noted. We removed the IFB with the help of magnet. The rest of the vitrectomy was completed, the wound area was endo laser was applied and silicone oil was injected. Coming to the third case, a 60-year-old male underwent a cataract surgery in a camp in a remote place. PCR with a sulcus in IOL implantation was done. After opening up of a patch, the patient complained of total loss of vision. He consulted multiple places outside and diagnosed as a vitritis, late endophthalmitis and referred to the higher center after months' time. On examination, for the right eye, his vision was PLPR with a hand motion close to face. To notice, the eye was quiet, there was no congestion, and for the lens, PCR with IOL and sulcus was noted with a minimal vitreous haze. Other eye was normal. On B scan, it showed a dense VH, but there was no evidence of RD. So we started with the surgery, a dense vitreous hemorrhage was cleared, base shaving was done, and we noticed the inferotemporal, a whitish patch kind of thing. We cleared all the membranes and we could observe a wound of entry. So a suspicion of a globe rupture during the needle prick injury was suspected, and accidentally the block was injected inside the eye. So after clearing the everything, we did apply the endo laser to secure that area, and the case was closed. So here, the primary surgeon or a trainee must have missed the globe rupture during the block and injected the anesthetic drug partially inside the globe. Lack of identification of globe rupture or lack of glow while operating was also missed. A simple sonography on time would have saved all these efforts. Coming to my last case, it was a 43-year-old male who had a blunt trauma with a ball 6 months ago. His vision was PLPR accurate. IOP was normal. On examination, anterior segment showed a traumatic cataract, inferior pupillary defect, and posterior synechia. B-scan showed the vitreous hemorrhage and attached retina. Patient was posted for cataract aspiration, vitrectomy, pupilloplasty, and CMT flex implantation, second trial. Coming to the surgical steps, 180 degrees apart, a scleral flaps were made. Vitreous hemorrhage was cleared with a vitrectomy. Base shaving was done. To the suspicious areas, endo laser was applied. With a 23 gauge MVR blade, a partial thickness 2 sclerospony ports were made and CMT flex was implanted. The T-junction was externalized in the both sides. Single pass 4 through pupilloplasty with a 9-0 polypropylene was planned. A loop was made and it was externalized. As here we can notice there was an inferior pupillary defect was noted, so only one single through pupilloplasty was attempted to give him a round circular pupil. Just showing the post-op picture. So here's a post-op picture, and vision improved to 618 at the end of surgery. Coming to my conclusion, ocular trauma is one of the most under-recognized cause for the vision loss. It is potential preventable cause of blindness. Strategies to prevent the trauma should be done, and these patients should be closely followed up to prevent the sympathetic ophthalmia. Use of eye protection is critical to preventing such injuries. Thank you.
Thank you for a very informative series of cases, Dr. Purva. That was very well presented. And can I ask maybe Usha ma'am to please felicitate Dr. Purva?
We invite our next speaker, Dr. Abhijit Patil. He will be talking on traumatic hyphema. Where's the photographer? Thank you, Dr. Purva and Dr. Johri. Dr. Abhijit Patil.
A very good afternoon to everybody present here. I'll be talking on traumatic hyphema. So hyphema, as we all know, is just blood in the anterior chamber, and the appearance of which may range from being only microscopic, which is seen only at the slit lamp, to a total hyphema that fills the anterior and the entire anterior chamber. So it is graded according to the amount of blood that is present in the anterior chamber. It can be microhyphema, in which case there are only circulating RBCs. It can be grade 1, in which it is usually the hyphema is less than 1/3 the volume of the anterior chamber. It can be 1/3 to half, in which it is grade 2. Grade 3 is more than half the anterior chamber volume. And grade 4 is total anterior chamber volume, or 8-ball hyphema. So an 8-ball hyphema looks something like this, in which the anterior segment structures are not visualized. So etiology of hyphema I'm discussing here. It could be trauma, it could be intraocular surgery, or it could be spontaneous. If it is trauma, it could be due to blunt or penetrating trauma. If it is intraocular surgery, it could be due to intraop bleeding or post-op bleeding, which can be early or late. And spontaneous can be due to intraocular tumors, clotting disorders, iris neovascularizations and such. So coming to traumatic hyphema, approximately 2/3 of traumatic hyphemas are usually seen in closed globe injuries, and 1/3 are due to open globe injuries. Presenting symptoms often are pain, photophobia, and decreased vision. If, however, a microhyphema is present, in which RBCs are seen suspended in the anterior chamber with no layering of blood, the patient may have a presentation which is very similar to traumatic iritis. Also, in these cases, concomitant injury of the anterior chamber is often suspected. It can be in the form of iris sphincter tears, iridodylisis, cyclodialysis, or lens abnormalities such as cataract or dislocation. Now, coming to pathophysiology, what happens is basically blunt ocular trauma causes ocular indentation, which results in sudden expansion of the ocular tissues and which leads to an immediate rise in IOP. The sudden displacement of cornea and limbus posteriorly usually results in shearing of tissues. So this tissues actually basically the blood vessels in these tissues tear, which result in the hyphema. Now IOP changes, it can be either elevated, which is due to the obstruction of the trabecular meshwork by clot or inflammatory debris, or it can be low in cases of if there is ciliary body inflammation or diminished aqueous production. Slit lamp examination will often reveal the RBCs and proteinaceous debris suspended in the anterior chamber. 8-ball hyphema, the entire anterior chamber is filled and the intraocular structures are usually not identified. IOP can be, if IOP is low, often the posterior chamber cannot be visualized. In these cases, an eye wall violation should be suspected. And it's very important that at the time of initial examination, visual acuity, IOP, and the amount of blood in the anterior chamber should be documented. Also, it is of prime importance to document past medical and ocular history. Sickle cell test and hemoglobin electrophoresis is important when family history is positive. Also, a search for ruptured globe and ocular foreign body is suggested in all patients presenting with traumatic hyphema. A dilated lens and fundus examination needs to be performed. Gonioscopy is usually avoided, but if planned, needs to be done very gently to avoid rebleed. And around 4 to 6 weeks post the injury, gonioscopy can be done to reveal angle recession. And at this time also, fundus examination with scleral indentation can be performed. The goal of treatment is usually threefold. It is to improve patient comfort, to prevent rebleeding, and to monitor for any complications. Management can be medical or surgical. Usually surgery is needed in less than 5% of cases of hyphema. And also currently, majority of patients of hyphema are treated as outpatients. They are not admitted, but inpatient management may be considered in certain situations in which there is severe IOP elevation, cases in which follow-up cannot be assured, hyphema in the setting of sickling hemoglobinopathy, and very young patients with hyphema. So commonly practiced regimen that we usually follow is topical prednisolone acetate eye drops are given for 4 times a day. Cycloplegics are given. Also amino caproic acid is also being tried, which is an antifibrinolytic agent. It is usually used to reduce the incidence of secondary hemorrhage, but its use is often hampered due to frequent side effects. Also, a common question that we always have is to compare amino caproic acid with topical steroids. Now, topical steroids have been used for many years and they are readily available also. Also, they had done a study, the only study comparing the two found no difference in the rate of secondary hemorrhage. General instructions that we give this patient is to wear an eye shield at all times. Instructions are given to maintain bed rest and with minimal ambulation. Patients are often encouraged to remain upright or keep the head of their bed angled at more than 45 degrees. Warning signs are often explained to them of rebleeding and elevated IOP, and an importance of daily follow-up is usually advised. If in case hyphema related IOP elevation is seen, then pressure lowering agents are advised. Carbonic anhydrase inhibitors are usually avoided in patients with sickling hemoglobinopathies because they tend to lower oxygen tension in the anterior chamber and can lead to rapid sickling of blood cells within the anterior chamber, which can in turn lead to rise of IOP and in the trabecular meshwork. Surgical interventions are only sometimes necessary when IOP is not controlled with medical therapy or if corneal blood staining occurs. Prolonged elevated IOP can often cause progressive optic nerve injury. So criteria for surgical intervention was developed by Reed, which is of microscopic corneal blood staining if it is there, total hyphema with intraocular pressures of 50 mm of Hg or more for more than 5 days, hyphema that is initially total and does not resolve below 50% at 6 days with IOPs of more than 25, and hyphema that remains unresolved for 9 days. In cases of sickling hemoglobinopathies, the criteria is often more stringent, in which case repeated IOP measurements of over 30 mm of Hg or mean IOP of more than 24 mm Hg in the first 24 hours following surgery, following injury, they are usually taken up for surgical intervention. Surgical techniques that we follow are anterior chamber washout with or without trabeculectomy. Also of prime importance is to have minimal manipulation during surgery, and the addition of usually trabeculectomy to AC washout allows a continued egress of blood and aqueous. So it helps in lowering the IOP and allows more blood to exit the eye while relieving pupillary block if it is present. So now they had done a study published in 2022 for global current practice patterns for the management of hyphema, in which what they realized was that there was unanimity of international institutions on hyphema management is lacking. Basically, many current interventions have unconvincing evidence supporting their use. So that's that. Prognosis of a traumatic hyphema is usually dependent on the etiology of it and complications if they are present. Also, a point about corneal blood staining, it depends, can vary depending on the size of the initial hyphema and the extent and duration of elevated IOPs. It usually clears in the periphery first and can take up to months to years to completely clear centrally. Corneal blood staining can have devastating side effects in children, leading to deprivation amblyopia. Rebleeding, if it is present, can occur usually within 5 days of initial injury and is often much larger than the initial bleed. It has been known to occur in about 38% of cases, up to 38% of cases. Risk factors for rebleeding include hypotony, elevated IOP, hyphema of more than 50%, systemic hypertension, use of aspirin if it is there. Other complications, as we've already discussed, optic atrophy, peripheral anterior synechiae. So outcomes of traumatic hyphema are usually quite variable. They are dependent on the complications which are present, and approximately 75% of patients will usually have a good visual acuity of around 20/50 or better, and poor visual acuity were often seen due to in cases in which had retinal detachment, lens subluxation, commotio retinae and vitreous hemorrhage. Thank you.
Thank you, Dr. Abhijit. And may I request Dr. Vidyashankar to please felicitate him. I would like to invite our next speaker, Dr. Nikhil Nasta, who's a prolific cataract and refractive surgeon. He is also a multifaceted person. He's a current treasurer of the Bombay Ophthalmology Association and one of the rising stars and the future of BOA as well. He's presenting an interesting talk on trauma and dry eye.
Thank you, Manish. Thank you, Aditya Jyot, Natarajan sir, Smith, and everyone here. I'm speaking, it's a sponsored talk on dry eye management. We learned about trauma. From the morning we've been hearing about trauma and what all it can do to the eye, to the retina, to the vision, everything. Of course, a side effect of trauma is also dry eye, either primarily because of the eyelid or the lacrimal gland which may be injured, or it could be due to the multiple sessions that they have, or the dressings that they need, or it could be due to the multiple preservative drops that they are using, any of it. So when we come to dry eye management, there's a whole basket which is available to us. Let's go through what happens. There are many risk factors for dry eye, non-traumatic also, like a Sjogren's, a non-Sjogren's, other disorders which form aqueous deficient dry eye, ADDE. In the Sjogren type, we have rheumatoid arthritis, polyarthritis nodosa, SLE, which are very common. In the non-Sjogren type, we have intrinsic lacrimal gland deficiency, age-related dry eye, which is ADDE, it's not always just ARMD. Lacrimal gland infiltration, lacrimal gland obstruction, and hyposecretory states can also lead to this. Then there are other disorders like Meek syndrome, pseudoexfoliation. Post-operative dry eye is very common when they keep coming back to the OPD. Something is khatkofying, something is bugging. Those and systemic medications which cause a lot of toxicity. Then there is the evaporative gamut of dry eye, which is EDE. Here you have meibomian gland diseases such as meibomitis, MGD, meibomian seborrhea, obstructive MGD, anterior blepharitis. All these we usually treat with ointments and massages. Then there are systemic dermatoses like rosacea, seborrheic dermatitis, atopic dermatitis, ichthyosis, and psoriasis. These are very chronic, debilitating, and long-standing. Then we have ocular surface related evaporative dry eye, like allergic diseases. In Bombay, they are very, very common because of construction work, because of pollen, because of the dry climate that we have. Vitamin A deficiency, surprisingly, is also very common. Iatrogenic diseases. And there are other causes like wearing contact lenses, which causes corneal warpage, Parkinson's disease, which could be primarily the disease or a side effect of the drugs that they are taking to treat it. Lid disorders and blink related, which could be like a computer vision syndrome, diabetes, thyroid, and so many more. Evaporative dry eye is recognized to include both lid related and ocular surface related disorders, both of them. Now there's a dry eye wheel. Whenever there's a low and incomplete blink, that causes an evaporative dry eye. We all know that there is a blink mechanism. We blink 14 to 16 times a minute, and the more we blink, there's a lacrimal pump which washes out the old tear and brings in a new tear film, right? So whenever there is an incomplete or a partial blinking, this leads to some sort of exposure at the lower corneal part, desiccation of the cells, and some form of dry eye. It's a habit in some patients, it is pathological in some patients because of loose or a floppy eyelid, or it could be due to some habit that they have. Anything which is causing an incomplete blink will give rise to more of an evaporative dry eye. 4 out of 5 patients have an evaporative component, so it's very important to manage for optimal patient outcomes. When we look at the management of dry eye in general, we have artificial tears, we have punctal plugs, we have extreme forms as well. So when we talk about artificial tears, category of ingredients of artificial tears target different dry eye disease signs. There are wetting agents, there are multiple action tear substitutes, and there are ocular surface modulators. Wetting agents will attack the tear film instability. When there's increased evaporation, aqueous deficiency, or reduced wettability, we give these agents. They are oily, they are viscosity enhancing like PEG, PPG, and they are viscosity enhancing like CMCs. Multiple action tear substitutes are those which affect the tear film hyperosmolarity along with it, and also ocular surface cell apoptosis. So they'll have many more inclusions, and they'll also maintain the pH. Then there are ocular surface modulators which tackle the ocular inflammation. So there are a mix of products that we can use. Now what are the key features of this product called Cystane? Cystane, the main key factor here is they are using something called HP guar, which forms a mesh, and this mesh makes sure that the tear substitute is evenly distributed across the entire vertical profile of the cornea, and there is no thick or thin patches. Everything is covered efficiently. Also the pH is very well maintained, so it's tolerated better, and it has osmoprotectants as well. So it's a very complete product, and the dosage also is reduced with this because it's a long lasting effect. The Cystane adaptive meshwork with HP guar is like any other dry eye solution. It causes an interaction between HP guar, borate, and divalent ions in the tear film, and like I said, it forms a film. The guar's pH sensitivity leads to increased viscosity upon exposure to the eye, and that when it leaves solution liquid in the bottle makes it very easy to dispense. As the pH is higher in a drier eye, it causes more viscosity and it has a win-win effect. It has a whole gamut: hydration, complete, Cystane Ultra, and plain Cystane or Cystane gel. Any one we can use. So the conclusion is that Cystane is designed differently. It has a unique ability to dynamically adapt to the tear film pH, and in a dry eye, it acts even better. 4 out of 5 patients have some form of evaporative dry eye disease. Lipid-based artificial tears offer a solution in evaporative dry eye because they mimic natural tears and replenish liquids. And dry eye can impair visual outcomes and patient satisfaction after any cataract, trauma, anything it may be. So artificial tears are the mainstay and HPOR based ones work best. Thank you.
Different perspective, yeah, to chronic damage to the eye, I suppose. That's what we covered today with your talk. Can I please request Dr. Kuhn to felicitate Nikhil? And our next speaker is Dr. Bhagyashree Meshram, speaking on traumatic endophthalmitis. She here?
Okay, so very good evening all. Thank you so much Dr. Chaya and BOA for giving me this opportunity to present here. So I'll be presenting on traumatic endophthalmitis. So did you know what is the possibility of a seeing eye developing endophthalmitis and turning into a no perception of light even after your treatment? It's 33%. And is there any prognostic indicator? Is the presenting visual acuity? So let me come to my first case. It's a 24-year-old male, a mechanic by profession, had suffered a workplace injury to a left eye while he was hammering an iron nail. There was sudden onset diminution of vision which was painful, progressive since 2 days. There was no history of any systemic illness or any addiction. So let's concentrate on the left eye. Right eye examination was almost within normal limits. So on examination, the visual acuity was 2100 N9, N6, and full and free extraocular movement with minimal conjunctival congestion, as you can see in the slit lamp photograph. But as you notice in the cornea, there is a self-sealed full thickness corneal tear. The anterior chamber looks normal, it is normal depth. The pupil was sluggishly reactive, but if you see in the lens, there is a slight tiny focal opacity at one quadrant, that is in superotemporal quadrant, and there was no view to the retina. So as we can see in the B scan, the retina appears to be attached and looks anechoic. So we started topical NSAIDs and antibiotics and steroids and atropine, and we advised CT brain orbit to rule out an intraocular foreign body. The clue was the focal injury site of the lens, as well as the self-sealed corneal tear, as well as the mode of trauma. So as per the diagnosis, as per OTS, it's a zone 1 penetrating injury with suspected intraocular foreign body with a query lens injury. The next very day with the CT patient presented with a hand movement vision with the drop, and you can see here clinically there is a hypopion. We had placed a BCL for the self-sealed corneal tear. Now the diagnosis changes to zone 1 penetrating injury with a traumatic end-off and an intraocular foreign body, which we found out on a CT. So on review of literature, so when do we suspect a traumatic endophthalmitis? When a clean eye suggests of different signs like pain, reported blurring of vision, sudden onset congestion, lid edema, epiphora and photophobia. While on examination you find a hypopion, AC reaction, AC fibrin, hazy media, sudden onset basically loss of vision should trigger your radars to think about traumatic endophthalmitis. If there is any intraocular foreign body, definitely it increases the chances 4-folds to get a traumatic endophthalmitis if not treated on time. If there is any lens capsule disruption, again it increases 4.4% chances of traumatic end-off, and these end-offs come culture positive also in 86%. If you delay further invention, it increases further risk of infection. And there are multiple microbes that have been quoted in literature, but just to name a few, the most common are gram-positive staph epidermidis, because it being a skin normal commensal, then bacillus species, as well as there has been coagulase negative, gram-negative like propionibacter also that is responsible, as well as pseudomonas in some cases patients. There can be polymicrobial infections reported in 10 to 30%, and culture positivity in such cases is 66% will come positive if you send a vitreous sample for culture. So the prognosis depends on, as I said previously, a presenting visual acuity and a pathogen virulence. So the species of bacillus are very virulent as well, but the staphylococcus pathogens respond better. So we need is a primary repair, which reduces our chances to getting end-off or further progression of the end-off by 75%. Intraocular antibiotics, as well as what is the inciting factor is the intraocular foreign body. So removal within 24 hours. So we posted the patient for left eye corneal tear repair with lensectomy with vitrectomy and an intraocular foreign body, along with a vitreous biopsy for our microbiology sample and intraocular antibiotics. So on microbiology, the gram came to be gram positive bacilli. So it's just a surgical video of a corneal tear repair. So when there is a corneal tear or a scleral tear, you go ahead with a corneal tear repair followed by a lensectomy. Corneal tear repair has to be done before so that my globe is formed when I do a vitrectomy. The lens removal is done. This is a 23 gauge pars plana vitrectomy. Now I started a vitrectomy, so here the foreign body is there itself. Luckily, it was not embedded in the retina and it was just clogged within the vitreous. So I cleared the vitreous all around it. So it is very important, as Dr. Kuhn mentioned, the foreign body should be removed with all the adhesions before you even touch it. And this case is slightly complicated because now there is focal vasculitis. The vitreous over the vasculitis is so adherent, so it cannot induce a PVD. So you just have to do a shaving over it. You do not need a complete vitrectomy, but because your intraocular antibiotics will take care of it. So with the help of an intraocular magnet, anyways I had done a lensectomy, so I explanted the intraocular foreign body with the help of a main port tunnel via corneal incision itself. And I closed the case with the intraocular antibiotics, Vanco, ceftazidime and amphotericin B. So if you are sending a vitreous sample for microbiological evaluations, so we do first is a smear examination. If the culture is positive, then good, you start antibiotics and treat the case further. But if it is a culture negative, you can subject these for molecular diagnosis like a PCR or a Sanger sequencing. There are certain biomarkers for bacterial as well as fungal biomarkers. So my patient responded very well. Left eye, I repeated intraocular antibiotics. You can see focally, inferiorly, there are this retinal vasculitis as well as vitritis which is resolving. And over a period of 3 intraocular antibiotics, the patient improved well. We found a very different organism, Bacillus, which I will be reporting soon. So the patient improved to 20/20 overall after doses of 3 intraocular antibiotics with resolution, and now this patient is posted for a secondary IOL. I'll just shortly mention the case too. So this was a young girl, which came to us with the history of just a swelling in the eye, redness, and there was very less diminution of vision and watering since 3 days. So on examination, the presenting visual acuity was 2200 in 14. But if you see, she had already developed a hypopyon, and in the superior conjunctiva, when you examine, there is a small boggy swelling, which was a suspected occult scleral tear. So on exploration, we actually found a scleral tear there. But on B scan, there are already membranous echoes in the mid-vitreous cavity. So this is now a traumatic endophthalmitis. So what I approached is, first I just did a scleral tear repair, and the very next day we took the patient for lensectomy, vitrectomy and vitreous biopsy with IOAB. So the vitreous biopsy proved to be gram positive, but on the B scan on the very next day, there was a retinal detachment already. So we need to understand if these cases are already complicated with the trauma and an end-off and there is a retinal detachment, you have to act very much faster because these eyes are prone for a PVR. So this patient did well with 2 sets of intraocular antibiotics for a gram-positive bacilli. This is a picture. I'm sorry, I do not have the patient's picture post-SOR, but patient did well and improved to 20/60 and now is for a contact lens trial. So the take-home will be remove the inciting factor. If you are suspecting a traumatic endophthalmitis, it can be a retained intraocular foreign bodies. Look for any delayed wound closure. You should avoid, see for any leakages. Lens capsule disruption should point it to find out if there is any intraocular foreign body. You can utilize in culture negative samples also advanced diagnostic techniques. Poor visual outcome in cases of larger wound and if you are delaying the treatment. And if it's a retinal detachment which is complicating the endophthalmitis, it is better to treat faster. So just my doubt for the panelist was, in the case 2, could have approached this case differently? If anybody can know.
Would Dr. Karobi like to say something? She's asking whether we would have taken a different approach. She tackled the scleral tear first and.
Did the right thing by doing that, because the essence of doing these scleral tears is that if you have a very long kind of a scleral tear which is going rather posteriorly, you open it in small bits and keep suturing as you go. I mean, don't make this of opening up the entire thing and then start suturing, because it's always better that way. Better to form the thing and then go ahead with yourself.
So it's like zipping it up.
Yeah.
Yeah.
Thank you.
Excellent presentation, Dr. Bhagyashree. Thank you. And may I ask Dr. Manish Sharma to felicitate her, please? Next up is Dr. Kavita Rao, who comes with a vast experience in treating corneal disorders, to speak on chemical injuries of the ocular surface.
Thank you so much. I'll be talking about managing ocular surface chemical injuries. So why is it so important? It's important because it's a true ophthalmic emergency, and unfortunately it generally affects mostly kids and young adults and people, and it's very common in the workplace. That's why legally, medico-legally also that's very important, because especially if the person has been affected at the workplace, you need to make a note of that, when the patient comes to you and you're doing history taking. And 2/3 of the patients are affected by alkali versus acid. So the incidence, even in developing countries, is not low. It's around 4%, with so many cases being added every year. And like I said, 16% of all injuries are seen in children. In India, if you see, at least in my practice, mostly the most common cause of injury is the tuna or lime. And 1 to 5 years is most common, because the lime packet, they just play with it and it bursts open and enters usually bilaterally. And in the developed countries, it's usually the household chemicals which are more common. So as you can see, these are the agents which can affect. The alkalis would be your refrigerants, fertilizers, drain cleaners. Especially sometimes I had a patient who kept it on a top shelf, and she was just trying to get it out, and the entire bottle entered the eye. So these are the alkalis, and acids would be the glass cleaners, car batteries. These are most commonly seen. So I think we all know this, that the alkali affects the eye more because it enters the eye, because it dissolves the membrane, versus the acid, which causes lesser damage. So when a patient comes to you in practice, this is the spectrum that the patient can come with. On the left side, as you can see, there's just an epithelial defect, and down you can see it's a completely opaque cornea. So we might think that the photograph on the right side is actually less severe, but there's complete ocular ischemia, so that's actually more severe than the one which is lower. So it's important to evaluate everything very carefully. So this is the Roper-Hall's classification. Now what this looks at is, it looks at the amount of limbal ischemia, which is very important, because once the patient comes in an acute phase with limbal ischemia, you know that you're going to be very, very proactive in in managing, and just topicals is not going to help this patient. So looking looking at the ischemia, stromal clarity, like the third case, like the lower patient as you saw here, you can't really see anything out here, so that's obviously grade 4. And then you look at the conjunctival epithelial loss. So because that's not a very dynamic classification, the Dua's classification is followed, which actually looks at the amount of limbal clock hours. So it grades as per the actual amount of limbal clock hours which are affected, and this can be then changed on a daily basis or weekly basis when the patient comes. Now, clinically, there are 3 stages when the patient just comes to you: the early repair stage and the late stage. So immediate acute is considered up till 1 week when the patient is coming to you. Now, this is a very important sentence. If you can just, this can be your only takeaway, I think that would be a very successful talk, because what is important is that vision restoration requires aggressive management, not only later but the acute. How well you manage the patient in the first week is going to determine his visual potential in the rest of rest of the clinical course. So when the patient comes to you, you will wash the eye. So the washing of the eye, I've seen many times people just pick up a bottle of normal saline and wash the eye. I'm going to tell you why that's not accurate. That's not the way to do it. But these are the 4 pearls when the patient comes in an acute phase. You're going to wash the eye, so you neutralize the pH. You're going to focus on epithelial regrowth. So obviously you've seen the patient today. You're going to call the patient next day and you're noting down, has the epithelial defect gone down? And you're going to actively look at suppressing inflammation and Tenon's vessels. So if there is limbal ischemia, actively do a tenonplasty initially. So this is what I was talking about. If you have the patient come to you, please wash with a buffered solution, and obviously you're going to double evert your phonesis. Now, why buffered solution? As you can look at this, this is a study where actually the intracameral pH was measured after washing with just normal saline, and you can see it's almost as if the patient's not been treated. Whereas if you use our ringalactate or balanced salt solution, it definitely is going to reduce your pH. So that's what you're aiming to use. Now, this medical therapy, topical steroids, you'll give the patient, make sure you're tapering it. After 4 weeks, there's really not much role of steroids, lubricants, oral vitamin C, doxycycline. That's your medical therapy. Now, if the patient's epithelial defect is not going down, then you're going to look at other strategies. So either put a bandage lens, do an amniotic membrane transplant, use autologous serum, and if there's ischemia, I'm stressing this over and over, you need to do a tenonplasty. Amniotic membrane, I think in interest of time, I'm going to just skip through this. Everybody knows this. Amniotic membrane, the Cochrane review, it showed us that these are the cases where actually amniotic membrane helps most. That is in grade 2 to 3. So if the patient is in grade 1, it's going to get better with medical treatment. If it's grade 4, again, probably, no harm in doing, but it's really not going to probably affect so much, because eventually they are going to develop LSCD. Grade 2 to 3 is where there's going to affect most. So you can either use glue or suture, but I prefer to use suture because, there's so much inflammation, I feel suture works better. So this is a patient, again with a acute injury. So you just, after I've completely cleaned this, so because you can see there's, absolutely completely epithelial defect, it was thought that we'll do the chemical like AMT for this patient. Now again, in these kind of patients, when you're doing surgery, it's very important you take your consent properly, because, the patient feels that especially if you've taken in the first 7 days, the patient always attributes everything more than the injury. He attributes it to the surgery that you've done. So you have to be careful about that. You need to make sure you tell the patient that it's not the surgery which has caused all the problems. So you have to take consent, take video consent, and also make sure you explain to them that patient's going to need multiple surgeries. So this is how, at 10 days, and this is at 2 months. Now this is about tenonplasty. Like I was mentioning, as you can see, there is ischemia. So what you do is you go and dissect the tenons and you advance this tenons, and after the tenons is advanced, you suture that to the limbus, then you place the amniotic membrane. Here I did only 1 quadrant, but here the tenonplasty, as you can see, has done in more than 1 quadrant, and because there's a lot more ischemia, you can isolate the muscles, pull the tenons in all the quadrants further. suture it well at the limbus. You have sutured the tenons and then put an amniotic membrane. This is an important step. If your patient has got limbal ischemia and you don't do this, the patient's not going to do well. Now in the late stage, you correct the late conjunctival abnormalities, you restore limbal stem cells, damage stroma. So this you have to do all of these with the help of your oculoplasty colleague. And if your patient has just a corneal issue, then depending on where the damage is, if there is damage only at the stroma, then either you do a tenons patch graft, amniotic membrane again, or a keratoplasty and stem cell transplant for if there is a stem cell issue. So I just have 2 videos. This is a tenons patch graft patient with chemical injury. So you harvest the tenons, you first freshen this up. As you can see here, I've harvested the tenons, and because this patient had this melt, so here you can then use a nice mattress suture at the this is a mattress suture where you use and you place the tenon. So this is an advantage. You don't really need to do a corneal graft in these cases. It really heals well, and once the patient, you have made sure that the patient now doesn't have a stem cell injury, then you can do a corneal transplant at a later date. So stem cell deficiency, again, I'm just going to rush through because I think I'm out of time. So as we know, stem cells reside at the limbus, which if it is damaged, you will know, because this patient will have persistent epithelial defects, non-healing epithelial defect. So I'll just show, this is my last 2 videos about SLET. This is how you harvested your your limbal tissue. Obviously only if it's unilateral you can do it. You can do it from the donor cornea as well, but I have mostly done it only from the unilateral, from the other patient's other unaffected eye. This is your limbal tissue. This is very, once you've taken it, harvested it, you have to make sure you keep it carefully. This can be again placed back on the eye. And once you've created a bed, once you get a good plane, you can see it pretty much looks almost normal. Then you put your amniotic membrane with glue. Now you're going to cut this limbal bit into small pieces, and you use the glue to stick it. There's no membrane, there's no amniotic membrane which goes over this. It's just the glue, and you put a BCL at the end of surgery. And this is what I wanted to show. You can see you cut the tissue and place it, and this is how at 1 week, 2 weeks, 2 months, and 3 months. So with that I end my talk. Thank you very much.
Thank you, Kavita. It was really nice.
Thank you.
Good results.
Thank you.
Yes.
Thank you, Dr. Kavita. And may I ask Dr. Kuhn to please felicitate her? Nikhil, would you like to join her?
Yeah, Dr. Vidyashankar.
Yeah.
Come. You have not got up from that side. You will get up again.
And now we have Dr. Manish Sharma, former secretary of BOA, and another multi-talented person on the stage, a great performer, great singer. Let's have his talk on medico-legal aspects in ocular trauma.
Thank you so much, Dr. Deepti. I think a lot of this has been spoken about during the talk, and it's extremely important to be careful about the medico-legal aspects in trauma. Well, why is it important? Basically because ocular trauma is known to be a significant cause of visual impairment and disability, and extremely important that we do a thorough examination, that we document this, and we should be aware about the medico-legal protocols as well. And the failure to adhere to this could give rise to severe medico-legal consequences. And it is important that we protect both the patient's rights as well as we secure ourselves. And in cases where there is an industrial injury and there is a compensation involved, the patient would get a proper compensation only if our medico-legal work is proper. And sometimes it is in the investigations, forensic investigations, and an insurance claim as well. Well, typically, this is the definition of a medico-legal case, wherein in a case of injury or illness, if after eliciting history or examination, we find that there is some role of the law enforcement agency to fix responsibility in accordance with the law of the land. And therefore, whenever we are dealing with the case, it's important to document all the details, whether it's the MLC number, patient's complete full name, details, name of the accompanying person. Sometimes if a patient is brought unconscious, the history is being given by the accompanying person. That is also important. The date of examination with the exact time and hour of arrival, the name of the police constable, the number and date of the docket, and the date and time of sending the report to the police. In case of indoor patients, the date of admission, discharge, and at all points of time, it's better to obtain the signature or thumb impression of either the patient or the relative accompanying. Key principles, basically, we should ensure that we are not doing any kind of negligence. Standard care should be provided. Dr. Kavita also mentioned about informed consent, essentially because once you've done a procedure, the patient will not correlate it with the trauma. Sometimes it's all put onto the doctor. So we need a proper informed consent. And of course, we should not be doing any dereliction of duty. And in medico-legal cases, it's also important to mention that confidentiality is very, very important. We should not be leaking out the findings or info in cases where, there could be some kind of prosecution involved. What are the red flag signs? Well, if there is a delayed presentation, there could be a malintention there, inconsistencies in histories being given by the patient or the attendants, and in cases of assault, workplace injuries, child abuse, or road traffic accidents, because a lot of times people try to fudge up the histories here. So these are all red flag signs. What are our legal responsibilities? Well, whenever there is a case which we think is medico-legal, we must report it in the prescribed format. And it's important to maintain your records properly for at least 3 to 5 years. We need to be aware of the local laws while dealing with such cases. And we need to follow the ethical guidelines to avoid any malpractices. Two, when we are issuing medical certificates, again, extremely important to clearly state the nature and the extent of the injury. We should not be subjective. There should be no subjective opinions, but purely facts. If there is any possibility of permanent disability, it should be clearly mentioned. Probable causes like blunt trauma or penetrating injury, and the language should always be legally acceptable without any kind of ambiguity, because we are likely to be called as expert witnesses in court. In cases of assault, we should be documenting the injury very carefully and mention the weapons that could potentially have been used. Again, if it's a workplace injury, we need to assess whether it is possible that the injury happened due to the work or whether it is before or after. In insurance and compensation claims, there should be evidence-based opinion without any bias, and we need to always be ready for a court summon to testify as a medical expert. We need to know why ocular trauma is important. It's because it falls in grievous hurt. In the old IPC, it used to be 320. In the BNS, now it's section 116, wherein any injury leading to permanent loss of sight in either eye, severe prolonged damage leading to visual disability, permanent disfigurement, or risk of life-threatening complications or permanent impairment falls in this category. Therefore, the compensations or the legal punishments involved are severe. We cannot, stop by reiterating this fact has to be re-emphasized again and again, that the consent is extremely important, and informed consent. Clearly explain the risks, benefits, and possible complications. In emergency cases, implied consent does apply, but yet your documentation is critical. And you must obtain consent for all surgical procedures, intravitreal injections, and laser treatments as well. For minors or unconscious patients, the guardian or legal representatives should be signing the consent. And always note down the name of the informant. Proper examination. So you need to put the document, time, date, and circumstances, a detailed visual assessment, investigations, always look for foreign bodies, chemical exposure, orbital fractures, and photographic documentation whenever it is possible. So you would want to record the best corrected visual acuity, look for RAPDs, document any metamorphopsia, diplopia, field defects, and always compare the pre- and post-operative vision. Well, classification of ocular trauma. This helps us in documentation. I'm not going to go into details. It's been spoken about, but you should be using these words, what is blunt trauma, what is penetrating trauma, so that it is self-explanatory, and there's any other expert who's looking at it, he should be able to visualize what is the kind of injury, what is possibly the site of injury, and we can also grade the injury, whether we use the Birmingham eye trauma terminology or we use the OTS score, which was again mentioned in the previous talks as well, the zonal classification and the severity indices. So even if you don't have a photographic evidence, you can actually, based on this, get a fair assessment or idea as to what the injury would have been. This is the BETT. Then you have the OTS score with the scoring system. Blindness, this last point, the blindness certification and visual disability criteria is also important, because if a patient lands up with permanent damage, we need to know what are the criteria for blindness, what is the criteria for low vision, and this is the paper that all of us in BMC and JJ refer to, wherein we issue percentage of blindness based on this. So all of us need to have this PDF with us and based on that. And the final take-home message is that timely, detailed examination and documentation is critical. Always maintain transparency and ethical standards. Do understand your medico-legal responsibilities to avoid any legal consequences, and seek help from your peers, from legal consultants whenever you are in doubt. Thank you so much.
Thank you, Dr. Manish, for covering this very important aspect of ocular trauma. And can I ask Dr. Chaya ma'am to please felicitate Manish?
In the meanwhile, I also request all the other speakers to please come up for a group picture. Please. Johari ma'am, Karobi ma'am, everybody, please.
I request all of the speakers to join us for the photo.
तो दिसत नाही स्पीकर ये पुढे ये स्पीकर दिसले पाहिजे.
किसी का दर्द मिल सके तो ले उधार, किसी के वास्ते हो तेरे दिल में प्यार, जीना इसी का नाम है. Keep doing a good job, guys. Keep spreading smiles. Keep doing great work. And thank you so much to Karubi ma'am, to Chaya ma'am, to Natarajan sir, to BOA, MOS, and all of you all for making this event a great success. Thank you.
We'll start Dr. Robert's session, please.
I was asked to show you live surgery. Unfortunately, because of some organizational problems, I can show you, so to say, edited but real-time video I took 5 days ago, operating on the patient with endophthalmitis after intravitreal injection. So let me share the screen. Okay, so this is my team in Lublin, and the patient was presented with really severe endophthalmitis 3 days after intravitreal injection with Avastin. So I used a new system of Alcon 25 gauge hypervid 20,000 cuts per minute system. now I'm presenting you video. So there was also really massive hypopion in anterior chamber, but I started from removing this pus, taking also a specimen for microbiological examination, and now you see visibility is better through the cornea, and I started pars plana vitrectomy. So really indeed, my teacher in this kind of surgery was Professor Kuhn. I could learn from him, so to say, main strategy. Nowadays I'm using micro-invasive system, like 25 gauge system, because in my hands it is really effective and efficient. So I started from cleaning anterior chamber, taking specimen, then I took also specimen from vitreous cavity before turning on infusion. Then in infusion I have low concentration of vancomycin during whole surgery. And now I am trying to, let's say, perform core vitrectomy to gain a much better visibility, because as you know, you must see to perform really efficient and safe surgery. Sometimes adding visco to anterior chamber is helpful. Also, I always perform posterior capsulotomy to clean the capsule, also to let vancomycin to go into the capsular bag. So you cannot be in a hurry. So this surgery took me like 35 minutes, but the video is of course shortened. I'm sure it will be like maybe 15 minutes, but again, you really must be careful, not to induce iatrogenic problems to the retina. You must clean, gain visibility, also try to clean vitreous covering posterior capsule. Now we go to the vitreous cavity. You see there is a pus between retina and between hyaloid, but we start to, so normally this system is very safe. I think that the safest system of Alcon, this HyperVit 20,000 cuts, because it really does not induce big traction. But in this case, I took shaving mode, not to induce, to be careful and not to induce traction, and I try to clean first the center of the vitreous. Then the big question is if we have already necrosis of the retina covered by hyaloid and by this whitish area of pus, or it is the retina is still, let's say, intact. And this is important because my plan is to induce PVD in this case. As I told you before, I try to induce PVD always. Maybe if I see really necrosis of the retina, then I try to cut the hyaloid around, not because avoiding the retinal breaks. I also, in such cases, perform fluid air exchange to remove to clean the media and to exchange again into fluid to have better visualization. So here now I am I was not sure about details on the macula region, so that is why I decided to exchange fluid into air, to aspirate all fluid with a pass, with, let's say, opacifications, and then I come back again to fluid to continue. This is my strategy also when there is a big bleeding. It is possible to stop bleeding when you exchange fluid into air. And, but in this case, I decided to do it, and it was a good idea. After exchanging into fluid again, I could see much better. And I wanted to prepare myself to perform PVD very carefully. So also you must remove all air bubbles behind the lens, and as you can see, still there is some vitreous covering the posterior capsule. So I try to clean this vitreous. At the end, I will perform posterior capsulotomy to have again a better visualization, but also to let vancomycin act in the capsular bag. So this is at the moment we still have some in Poland some series of such endophthalmitis after intravitreal injections. We have much better situation after cataract surgery, but from time to time, from one center, we have, let's say, 1, 2 endophthalmitis. Also, new drugs, new intravitreal drugs sometimes cause like uveitis or vitritis. So it is sometimes difficult to decide what to do. Here is really no question we should perform vitrectomy immediately. So the patient was sent from another hospital, and I performed this vitrectomy, I think, 9 p.m. 9 p.m. in the evening, just after his coming to my hospital. I didn't want to wait until next morning. Even I am the head of the department, but I told, okay, I will do it. Let us save the eye of the patient, and this is also a kind of model situation in Lublin. We do if there is an urgent situation. We don't wait until next morning. We perform surgery even in the middle of the night. And this is a crucial moment here. Under magnification, I can see that this is a kind of pass area underneath hyaloid. So I try to induce PVD very gently. And in case I would have problems, I would take macula lens, and would use peak with 25 gauge needle, which is also very good idea to initiate PVD. But at this moment I could do it with vitreous cutter. So I tried around the arcades, the optic disc, but finally I could manage it at the area of this, let's say, this whitish area, like here you see, trying to open the space to cut the hyaloid, and in the moment it will be possible to induce PVD. So the eye, the patient is after BRVO, and Avastin was injected due to BRVO in this patient. You can see, so I am always gentle, I am not in a hurry. I always think that there is a risk of necrosis of the retina, so I cannot see it. So that is why trying. Yes, now I could initiate PVD. So we clean around and aspirate, being really careful. We still have like maybe 5 minutes of this video. But this is more or less real situation, how it looked during my surgery. I try to initiate PVD and continue till vitreous base, but sometimes due to poor visibility at the periphery, it is difficult to avoid iatrogenic problems. So in this case, my plan was just to leave the eye with fluid and vancomycin at the end. I didn't plan to use silicone oil. It was not so severe case for silicone oil. If I see retinal necrosis, then I consider to inject silicone oil. So also the visibility was not really perfect. Sometimes you see the trocar went out, but it is easy to. These are really gentle instruments, so I could install it again using light pipe, and we continue here. But I think the most crucial moment, risky moment also, was how to initiate PVD. Then I could clean again medium, aspirate, pass, and at the end maybe I can accelerate a little bit the video. You see now I'm going also to use flute needle to remove pus from the surface of the macula. Then after this I cleaned the periphery. I performed shaving of the vitreous base, trying to be also really careful because visibility was not so perfect. So until I could see, also then using indentation. And fortunately, I had a very good assistant. Now, one colleague from US, from Virginia, is my fellow. She is spending with us hours at the operation theater. She's helping us also during night duties. Now I would like to show you result of the surgery. So this is 5 days post-op. Best corrected visual acuity is counting fingers from 2 milliliters. It was Staphylococcus epidermidis, and as you can see, ultrasound, also Optos photography. Results look really quite good. So I don't expect any problems, and the patient is at the moment luckily came for follow-up, so we could took these photos today. Thank you very much for your attention.
Wonderful surgery, Dr. Robert. And you have explained step by step every procedure, every step you have explained very well. And it was quite challenging. I am sure all the audience has learned so much from this surgery. Dr. Ferenc, sir, any comments?
Hey Robert, this is Ferenc. I wanted to say first of all that your talk was excellent before, and about this surgery there are a couple of very important issues. The first, he had a plan, and as I said before, it's very important to have a plan. We all have to understand that when you talk about good surgery, you are not talking about how good you are with your hands. We are talking about how good your brain is. Because what your hands do is simply carry out the instructions coming from the brain. So there were a couple of things that are very important to emphasize about this case. First, he did not wait or did not choose what many people would have chosen, which is to inject antibiotics, follow the endophthalmitis vitrectomy study, and then wait to see what happens. If you kill the bacteria because you were fortunate to blindly select the antibiotic that will be effective against the organism, even then you leave behind toxins, you leave behind enzymes, and you leave behind the body's immune reaction inside the vitreous cavity next to your retina. So our goal is not to kill the bacteria. Our goal is to preserve, restore vision. Killing the bacteria is part of it, but we also want to remove that toxic mixture inside the vitreous cavity. For that you need surgery. So the first great thing was the indication, to go in and then to go in early. Another very important issue was to go from front to back. You can't just go in and start doing surgery in the back because your visibility most of the time will be very poor. So you start with scraping the epithelium, you clean the anterior chamber, which sometimes you have to redo during surgery because purulent material can reaccumulate during surgery. And then you do your vitrectomy from the front to the back. Very important in a pseudophakic eye to do a capsulectomy so the capsular bag can be irrigated. And then going more posterior than what the endophthalmitis vitrectomy study said, which was remove half, the anterior half of the vitreous. If you leave pus behind, you can't expect as good a recovery as otherwise would be possible. So he spent a lot of time carefully creating a posterior vitreous detachment. He did not mention this word, and I did not want to interrupt, but you could see there was pus sitting on the macula, that white accumulation. We call that macular hypopyon because that's what it is. Remember, these patients are sick, they are in bed. This material is heavy, it will settle on your fovea. That's why you have to create a PVD, unless, as he also mentioned, the retina is very necrotic, in which case you have to compromise, but most of the time it's not. So he created a PVD, and although it was not shown, but he vacuumed with the flute needle that purulent material sitting on the macula. So what he did, again, as I said earlier, can he promise the visual outcome? No. But he did everything possible to restore the normal anatomy in this eye so that whatever function the retina possibly had left will be able to come and improve the vision for the patient. So great surgery.
Good evening. So this is Dr. Sujata Chande. I head the department at Grant Medical College, JJ Hospital. Excellent talk, excellent surgery. Everything summed up so beautifully. All I can say is good intention always gives very good results. And you have set such a great example for your juniors, being the head. You didn't see your clock or the time, that all you saw was the need of the patient. And I think it paid off extremely well, seeing your post-op patients' results. So kudos, sir, very nice work. Thank you so much.
Very much, my pleasure.
We would like to thank you, sir, for your precious time and contribution for this conference. And I think Dr. Natarajan is waiting to show his live surgery. So we'll move on ahead for that part of the event. Thank you so much.
Thank you very much. Also, great pleasure to see Professor Kuhn, unfortunately online, but hopefully in person soon.
Good to see you too. Are we ready? Do we know? Okay, go ahead.
Like endophthalmitis vitrectomies you do in your practice. So how do you decide to put a oil?
Yes, so when I started putting oil in the eye, I remember I had a lot of people attacking me, saying that what you do is pressing bacteria against the retina. Oil has advantages, but it's not something that you do on a routine basis. There are indications in my practice to do that. And there are some conditions. So the first condition is you have to do a complete vitrectomy. So if you leave pus behind, if you do not detach the posterior hyaloid and then you put oil in the eye, indeed what you do is you keep that pus against the retina posteriorly. It's horrible. So you do not use oil unless you had a PVD and you clean the vacuum the surface. And then the rationale of using oil is two. One, if you did create a retinal lesion or a retinal detachment is already present. But there is another indication, because oil will be transparent. If you have an eye that had a vitrectomy, you look into the eye the next day, the view is very hazy. That is probably what explains the vision in this case, because probably because of the organism in this case, the visual acuity will improve with time. But right now it's poor, because just as you have difficulty looking in, the patient has difficulty looking out. But if you use oil, everything is clear. You can also, you should also inject antibiotics and corticosteroid into the oil, half to a two-thirds dose of the normal one, because nothing stays in the oil. It will leave the oil and go and work against the organism if there is anything left close proximity to the retina. So oil has multiple advantages, but it also means you have to have another surgery to remove it. So I don't routinely use the oil, but in these conditions that I described, I will use it. One thing I don't want to.
Okay. Dr. Smith? Natarajan, sir?
Yes? Can you hear me?
Yeah. Can you hear us?
Just now we are showing you the fundus photo. Dr. Mansi will tell the patient.
Okay.
At present, Dr. Mansi has placed the belt buckle, but she will tell first the patient's age and then the diagnosis.
Hello everyone. The case which we are operating is a
Can they hear you?
20-year.
Check
Yeah,
them.
I hope I'm audible.
Yes.
Yeah, so it is a 20-year-old female who has bilateral high myopia, and she was inconsistently using glasses, so probably she is amblyopic as well. She came to us with complaints of diminution of vision in both her eyes since childhood, and she was not aware about any symptoms of retinal detachment in her eyes. So bilateral high myopia with vitreopathy was seen. Also, both eyes there were multiple HSTs and retinal detachment was seen. So here we are suspecting a case of Stickler's syndrome. I have placed a 240 belt with a 70 number sleeve, and the belt has been tied in superotemporal quadrant. Minimal core vitrectomy is also done, and now sir will be continuing the surgery.
Okay.
So, did you tell the diagnosis, Mansi? Put switch here. So I'm using the Alcon vitrectomy constellation, and then using the 3D RTO. So we see, can somebody show the screen here? External camera and then internal camera, biome. Centering करो यार माइक्रोस्कोप. क्या फुट स्विच अंदर करो. नहीं ये नहीं यार. अरे ये बराबर करो, अभी निकल दिया. लाइट कम करो, ये पकड़ो सीधा. So this is a total retinal detachment. Light come karo. So partly vitrectomy done. I'm going to use steroids. Steroids. So are you able to see the screen well?
Yeah, we are able to see.
Okay. So you have any questions, Dr. Chai, you can ask me.
Yes. So for the benefit
can you show the 3D screen?
For the benefit of the students.
Where is Dr. Smith? Can you show the 3D screen and how we are sitting and both sides, can you show? No, one camera they can bring into the hand, no? The external camera. And have you shown the fundus photo in the OCT?
Fundus photo, yes sir, Mansi has shown us. She told the diagnosis, she showed fundus photo.
So right now I'm using steroids.
We are able to see external camera, means we are able to see you operating, sir.
Yeah.
And also...
Can you reduce the light more? Can you reduce the light?
Dr. Karabi, meanwhile, you can just discuss what are the various ways to visualize the retina during retina surgeries. Karabi, madam.
At present, I am using the Zeiss wide-angle observation system, Recite, and I am using the wide-angle view. And I am happy that I introduced the biome way back in 90, this part of the world first time. So I have the collection of biome from 1 to now 5.
Yeah, I remember, sir, initially we used to operate with irrigating contact lenses.
Yeah, that is in 90,
yes,
but after that immediately I have gone to wide angle.
Yeah, wide angle viewing system was not there that time. So the assistant has to hold the system continuously and balance it in such a way that the view of the retina is
Ocular has been tightened.
Good for the surgeon. So,
yeah, initially they used to have the
not only
direct viewing systems where you have a microscope and when you go to the posterior part, that is, see the anterior part of the vitreous can be seen by the microscopic light itself, and then when you go down further into the mid vitreous and posterior vitreous, you need the illumination of the microscope along with your lens, along with an endo illumination. So that used to help, but the view was limited, and thereafter the those things were possible by lenses, which
This is
were
a
there for both
induction of
phakic and
PVD.
aphakic eyes. And also they were possible by certain lenses which helped to see either the posterior pole very well or a little area around it. Then the IBOS system and the biome systems came up, and those offered a good view, but there was a learning curve to it where one had to get used to the inverted image and laterally placed image. And but once you're used to it and you're used to the magnification that it gives and also the clarity of the structures that you're seeing, if your focusing is proper. So those were the ones which helped. Now the resight is there, and the latest of all is the Ingenuity by Alcon, where you have a system where you look, and it's a 3D viewing system where you don't have to look into the microscope. You can look at what is happening because it's a highly magnified view, and you can do your surgeries looking at the monitor.
Yep, infusion of. Where is the band tie? Okay. Alabama. So I'm tightening the band tie so that I can see the periphery better. Alabama needle holder sister. Okay, sir. So we don't use any sutures for the buckle. We have all the four quadrants. We have the belt loop and then the Watsky sleeve. So there is no suture. It's a sutureless surgery. Clamp the line, light pipe. There is one.
So in which surgery band is put first and what are the benefits?
We can see the periphery well, we tighten, we can loosen, we can check the buckle height. So we want only moderate buckle height. Clamp.
So that's the benefit with Watsky sleeve.
Yeah.
Sutures are not there.
Watsky sleeve is to keep the two ends of the 240 band to be together instead of using a suture.
Yeah, 240 band, both the ends together, yeah.
Yes.
I mean, when you're placing only a 240 band, suppose you're only putting a 240 band and not a tire along with it, then the sclera itself can be dissected and the 240 band can run through it at the equatorial zone, and the end can be secured with either a Watsky clip, which you see Dr. Natarajan doing, or you can put a 50 Ethibond suture around it. I mean, you create a small kind of a loop where it sort of ties both the ends overlapping each other together. So both work equally well. So if you don't have a Watsky's clip, you can do it with a suture as well. And suppose you have a tire, then you put the tire in whichever area the break is, and it tamponades that area, and then tightening of the 240 band, you have to monitor that the pressure of the eye doesn't go up, and for that you can just tap on the surface of the cornea with a blunt instrument to see that there's just a certain amount of give, which gives you a rough idea that the pressure is okay. But the advantage is that you can always loosen it or tighten it as per need.
Infusion. A clamp. Cut off. Diaphragm and PFCL. The PFCL. So I've done the tightening of the band and then perfluorocarbon liquid to squeeze out the subretinal fluid. And I kept the buccal height high now, but I will reduce it because I'm trying to locate the break. The break is at 11 o'clock meridian. 11 and 1. Infusion on. Clamp the. Remove the. Infusion on. On, no? Laser. Now the buccal height is high, so I am completing the vitreous base excision. The retina is totally attached. There is no subretinal fluid now. So I am now doing a vitreous cutter and then using the fluid air exchange. So under air I will work some time. The idea is to squeeze out the fluid from the anteriorly and also to visualize the periphery using the air. Air pressure 30. हाँ क्या हो रहा है ठंडी ओके हिलना मत बात कीजिए हिलना मत और एक anesthesia madam can you put blanket for the patient is feeling cold PFCL clamp the lamp. Brush. Sampling. Pull the thing. Remove the balm. Dr. Mansi, I think gas should be all right, no? Gas. Laser. No, air on. Remove the clamp on. Air on. So right now you see the retina is totally attached. I can't see the break because the retina is totally attached. And it's a tiny HST. That was at 11 o'clock and 1 o'clock. So I'm going to do the laser there. Good switch barabar kare. Laser on.
Is there something at 12 o'clock meridian, Nati?
11 o'clock and 1 o'clock. Laser on. Light कम करे So I am going to do the laser in the anterior part 11 to 1. Parents? Kirby?
Yes, sir.
No, any comments from Ferenc?
Yes, the first comment I have is repeat what we discussed earlier is posterior vitreous detachment and how you see so many dogmas in the literature which are not true. So in this case, the literature would tell you that there is a PVD already, and the PVD, the process of the posterior vitreous detaching is what caused the break.
Yes.
In this case, you had no PVD. So the bottom line is, for those of you who do vitrectomy for retinal detachment, never assume that there is a PVD. Always, as you saw, use steroid analog to see really whether there is vitreous on the posterior retina or not. If yes, you have to remove that.
That's right. That's why I use the steroids after completing the vitrectomy to check whether everything has been removed. So now I interchange the instruments to do the laser on the upper temporal.
Another comment is about the vitrectomy in the periphery. If you use air, it is very helpful to, one, keep the retina back, two, it allows you to see the vitreous once your instrument submerges in the vitreous. So you don't see it before that, but once your instrument touches vitreous, it becomes very obvious. So it helps you shave the vitreous in the periphery a lot more accurately and also more safely.
Okay. So now I'm going to do the PFCL removal and removal of the
How myopic is the patient? What's the diopter?
What's the myopia, Dr. Pansi? Minus 20. No, this side?
So there is
Minus 20.
There is a posterior staphyloma because we can't judge that from the image.
Yes.
Yeah. So one, I'm just telling you,
Right.
not to the surgeon, to the people in the audience. If you have an eye with such high myopia with a staphyloma, there is always a question of peeling the ILM or not. The reason is the retina, as we know, has 10 layers. There is one layer which is not elastic, that's the ILM. The other 9 layers are. So very often when you have a detachment in these eyes, it's not the typical detachment, it's a detachment over the staphyloma, because the ILM does not allow the retina to conform to the bulging of the sclera. And if you remove the ILM, you have a very good chance of the retina being able to conform to that.
Is there a myopia seen? You have a OCT of the macula? What does it show?
Well, you should.
Remove the biome.
If you have if I see a patient with a staphyloom or spanning detachment, I always remove the ILM. Because again, that gives the retina the chance to stretch a little bit and conform to the bulge. If you don't remove it, the only other option in these cases is to buckle the macula. For that, you need special equipment, which I don't have. So my approach to that is ILM removal, but it's very difficult to remove the ILM in most cases. In this case, you don't see those huge white areas, no pigment, which would make the surgery technically very difficult.
Is there a staphyloма?
So what do you do in these this long eyes? What about the equipment? Because the instruments don't reach.
Correct. That's a very big technical difficulty. So the only option you have with the vitrectomy probe to reach into the back is to push the vitrectomy probe forward, so distort the front of the eye, hoping that the cornea will not get distorted and your vision stays the same. But unfortunately, most companies don't make the vitrectomy probe long enough. Goider used to have a 32 millimeter long one. Some companies are promising to bring back a longer version, but that is an issue, for sure. The worst is when somebody uses heavy oil.
Inject.
And to remove that, you tear your hair out, because it's technically extremely difficult and very slow. That's also, yes.
Hold this, product, Alabama, and gas I want. Alabama, needle holder. Needle holder, Alabama. Sit down. And I want more injection. Please, please. Please, yes. Hold it. Hold it. Right. Cotton. Okay. Scissor.
So that was air or pure gas?
I will put a C3F8.
Okay.
So now I'll do the closure with the glue and subconjunctival antibiotic, because I routinely do we inject antibiotic and or maybe use a suture, tooth forceps.
Nati, why didn't you ask your assistant to hold those sutures while you injected the gas?
Because I became hypertonic. That's why I made them hold it.
I don't think they were holding it. It was quite slack.
They were holding. That's why I could inject and then reform the glue. Glue. So we are using the glue for the conjunctiva. Antibiotic. Oh, this antibiotic. Scissors, give us sister. Alabama, scissors, scissors. Hold it.
So there are many many techniques how you can do this. This was a very elegant surgery. Mine is not so elegant because I'm a very inexpensive surgeon. Using heavy liquid is expensive, at least where I work. So that heavy liquid can cost $600-800 in itself. So I don't use it unless I absolutely have to, which makes the technique of surgery a lot more complicated, a lot extra tricks are necessary. But if you have enough of the heavy liquid, this is the way to go, because this heavy liquid from the back pushes the subretinal fluid forward, which first of all makes the actual redetachment faster, but it also helps you identify the location of the break.
Wonderful surgery, Nati.
Thank you. Antibiotic.
You made it look easy.
Pardon?
You made it look easy.
Okay. Good forceps. Scissors. Okay. Yes.
There's a question for the residents. Why is he cutting the tenons? When you suture the conjunctiva, do you suture it with tenons or without the tenons? That is question number 1. Anyone answer? Without. Why do you do it without? Hazard a guess.
Put can you put glue?
See, whether it is retina or any other anterior segment surgery where you are suturing the conjunctiva, never take the tenons along with the conjunctiva, because otherwise you'll get a chronically red eye postoperatively, which goes on, you know. So the patient may be wonderful where the vision is concerned, but the only complaint they'll have is a red eye.
Kamala, release this one.
You saw him cutting the tenons over there, no?
Okay. Thank you. So put the drops. So thank you all. Thank you,
Thank
Kirobi.
you.
Thank
Excellent
you, Dr.
surgery. It was wonderful watching.
Yes.
Now, with that glass, you can take the motorcycle and come back.
That's right. I'm going to do that and come and see you now in few. हो गया, अच्छा हो गया. अभी अंदर गैस भराया है, तो गैस की वजह से थोड़ा टाइम नहीं देगा, ठीक है?
Natarajan, any other surgeries?
No, because the other patient developed some. क्या? Dr. Smith.
The Smith's patient was.
Tell about your patient.
I think he developed a cough or something like that.
No problem.
So this is very important. If you have a patient who has gas in the eye, the patient cannot fly and cannot go up on mountains. Not only not fly, but even with a car cannot go over 1,000 meters.
Doctor,
because the gas will expand and the intraocular pressure will be very high.
Thank you once. We'll all go. You have a car or by taxi? I have sent the car for Dr. Mary. Mary madam. उल्टा उल्टा सोएगा अच्छा है 2-3 दिन, इसके बाद हेडअप. हाँ एक मिनट.
Evening program here or it's somewhere else?
So Dr. Kerubi, so I request all of you to, in case you can stay back, have high tea. And 6 o'clock, Dr. Ferenc Kuhn is giving my oration in my parents' name.
Yeah.
Right? So main idea is to propagate prevention of eye injuries, and then if injury happens, come to one of us immediately. Anything, KL?
No, it's we still have quite a good crowd over here.
Okay. So any questions from the postgraduates or residents?
Any questions that you all want to ask?
Me or
Dr.
you or...
Ferenc or Dr. Natarajan or any of us? Feel free, don't worry. Whatever.
Yeah, that's right. Don't worry. You can ask any question. No question is stupid because the whole idea is we are here to solve it. Because sometimes we also face some situations, but Chaya madam wants to ask.
Yeah, I want to say, if there is no question, then there are 2-3 possibilities. They have understood everything, or they have not understood anything, or they were sleeping.
So you have to tell whose students they are.
Whose students? No. I was not sleeping.
Not you, the audience I'm talking.
Audience.
So you can tell one of your students to ask question, no?
Mihir, that's what Mihir, you want to ask any questions?
And I saw you have posted some residents. I spoke to the few of them. I told I'll come back and talk to them.
Yes.
They are all just doing MBBS. So they should meet Kerubi, you, parents to talk to us because I hope somebody will take ophthalmology. I know it's a lot of competition in India. Not an easy thing.
Undergraduates, yeah.
So I don't have any questions, but I would like to add a few points to the surgery, which we just saw. So what I thought is sometimes it always helps to cauterize the edges of the breaks. So when the break settles down on the retina, we can have a nice view of the break where it exactly was.
Yes.
Unlike in pneumatic retinopexy, that is the biggest problem because we are not going actually inside the eye, and when the retina settles, if it's a very small break, we cannot visualize it. But here we can do that. And also, one of the points which my mentor always taught me that whenever you are injecting something into the eye, the final tightening of the band or the buckle should be done before that. So we can eventually achieve a pressure at the end with the tamponade which we desire. So these are the few points which came to my mind and I like to share them. Thank you, sir. It was a wonderful surgery, sir. And it was a very seamless surgery with the use of glue and for the closure of the conjunctiva, which will provide a very good post-operative comfort to the patient. That is one thing which we usually forget when we are doing band buckles and cutting the conjunctiva and all. We have to be as elegant and the patient should be as comfortable as possible in the end. Thank you, sir, for showing us such a great surgery.
Thank you, and thank you. Your points are well taken, and that's where experience counts. And as you rightly said, I think is very important, whatever points you said. And I think conjunctiva is very important. That's what tissue respect. So as a vitreoretinal surgeon, I remember in '84, Steve Charles used to say, whatever comes with the way, take it out. And we were also doing lensectomy, vitrectomy, sphincterectomy, and that is the worst surgery I have done, I think, because you're cutting the pupil because it's not dilating. But now we have pupil dilators and we can use the narrow beam in the wide angle to see. So we don't touch any of the those things. So I think you have to do the least. That's what Charles Keepan said in 1950s. Do the least to reattach the retina. That means the least number of procedures. As Ferenc was talking, and Jovanovich also said why we should use PFCL. But I think again, it's you have to. That's Dr. Ferenc also said. Don't believe whatever we say just because we are saying with the experience. You have to decide in your hands which is the best. That's why that last chapter, surgical self-education, is very important. You should know what is good in your hands and what is not good in your hands so that you follow somebody. And in case both are not possible, better to refer to somebody who's a better surgeon than myself or somebody. That's best. So that's what I do, and I'm happy with your comments. Good.
So one question, the C3 FAT you injected was an expansile of concentration?
Yeah, so 10% I used.
Okay.
So that the idea is because a young person and keeping the position patient in prone is going to be a problem. So as much as possible prone, and because the brakes are up, once the gas bubble becomes 3-4, I tell them to be head up.
Okay.
And any alternate position we can do now, head up and prone position.
Sir, do you do video recording of the consent of all
Yes.
cases?
Every patient I do. We do a written consent and we do a video consent.
Is it
But
mandatory?
after all that, patient will ask the same question. If there is a recurrent retinal detachment, they don't remember anything what you said. So we have to be calm and learn to be a good surgeon to talk to them. And that's why my counselors are very important. And the people, optometrists, the words used are in the clinic has to be proper. And sometimes the patient comes from another clinic or your own patient. And then the word recurrence also is a problem for them. So I tell them there's a subretinal fluid and we have to do something, and then somebody says something. So the idea is consent is important and you have to explain as much as possible. So in my consent everything is there, including the eye becoming phthisis and removal of the eye if required. Loss of vision and loss of eye. But I think touch wood with all the advances, that's a 1 out of 1,000 chance, and fortunately, except a recurrent which we can do re-surgery. So that's why Dr. Jovanovich taught me every patient you have to tell when you're doing a vitreous procedure, there's a need for more than one surgery. So the more than one can be 2, 3, 4, depending on. So finally we have to do the best to the patient by doing the least. Like if the retina is attached, and that's why he's talking about ILM removal. And some people have, just because they want to do and they produce more complication. So that's where you have to decide which procedure is important for which patient.
No, my question was, is it mandatory to take a video recording?
No, it's not mandatory.
Not mandatory.
But trauma, it's why medico-legally definitely will be helpful, because at the time of trauma they will say anything and they will conveniently tell the, I think there was a medical legal case where patient says, I don't remember anything. And that's a choice patient has. And in democracy, the judge also says, yes, he is right. So that's why video consent, along with a responsible relative, if it is a child, definitely a father and mother together. And if it is if the child doesn't have parents, and sometimes I recently operated a patient who had a glass injury from Delhi. They came in 5th day, and only the aunt and uncle were there, but they brought the patient, so we took a video consent.
Do you always remove your silicone oil?
I know, it depends on at the end of 3 to 6 months I decide, and if the pressure, the lens, everything is fine, I wait. And in case if the patient is going to not come at all or has a problem, then I make sure I tell the patient, if you remove the oil, again you have to wait. If there is a redetachment, we have to re-inject oil. But that we tell in the first surgery itself.
Are there any cases where you've just left the oil and not removed it at all?
We have got a one-night patient where the pressure was low, and then we removed the oil, had a recurrent detachment, then again we re-injected oil. So I changed the oil from 1,000 centistrokes to 5,000 centistrokes, monitoring the patient. And rarely I remember one patient, I think after 10 years, had a silicone oil emulsification. Then again I removed the oil, and I thought I will leave the oil without oil. But then that particular patient, I re-injected a fresh oil. In some eyes, I think very rare, these are all very, very few patients where 360-degree retinectomy done, and then the eye is looking small, pressure is 6, and then one-eyed, and then the patient has a good vision with a 636 with silicone oil, and with a low vision aid, they can read also N6. So those eyes, I think, and if there is the slightest problem of pressure or a corneal changes, then I tell the patient, if you don't remove, you have a problem with cornea, and if you remove, there's a problem of retinal detachment, but better to have a retinal detachment than have a corneal problem. But the problem is patient will ask how many times you will do. I tell them, we will do till that, because the idea is we want you to see, and this is the only way we can do. And many times, that time patient wants to take opinions, they go all around and come back. So better is to tell the first only, I tell them, So multiple surgeries, and then silicone oil is used, there's a need for removal. That will decide person to person depending. And I don't follow dogmatically that every 3 months I'll remove, and definitely not that way.
And in patients who have an emulsification, probably not removed for a very long time, do you combine a silicone oil removal with an anti-glaucoma surgery, with a glaucoma surgery?
I have used that F6H8, which dissolves the emulsified oil, but that's very expensive and it's not available easily because in India it's not approved. But otherwise, no, unless there is a glaucoma already persisting, then only. I remember 30 years back I used to do, or 35 years back, pars plana filtration. I don't know whether it worked, whether the silicone oil worked or the pars plana filtration worked, I don't know. But we used to do that. But later I think I do the silicone oil removal, and in case the pressure is still not going down, then I send to the glaucoma survey. Anyway, the glaucoma person evaluates always continuously and then decide the... But combining is a problem. Doing the same, because I can become hypertenous also.
Any other questions from the audience?
Sir, I have a question which is not related to this surgery. It is related to optic pit maculopathy.
Okay.
So, in optic pit maculopathy, is pars plana vitrectomy your first choice of surgery, or do you try barraging the pit and any other options?
That's a very good question. I think since I am doing vitreous surgery and I have seen good results with vitrectomy, I always do vitrectomy with a patient. I think I remember doing amniotic membrane graft also to close the pit, and then the patient did well with a 6/9 post-operative vision.
So you used glue along with the graft to put it in the pit, or just a simple graft which you stuffed it?
Simple graft I did.
Okay, sir.
And prone position.
Thank you, sir.
Yes. Good, I think it's already 5:20. So high tea should be ready. I think Joseph should keep it ready. And give black coffee to Ferenc. Right?
With milk. Black coffee with milk.
We'll do that. Don't worry.
Okay. So I'll join you in 10 minutes.
Come.
Thank you, Dr. Chaya, for a wonderful event. So I'm again planning to do on May 4th, Dr. Chaya, Sunday. It's the 125th anniversary of my grandfather.
Oh, sure.
Okay.
We'll do, sir. Yeah.
Thank you. Thank you. See you in 10 minutes.
Yeah. Surely, we'll have a group photo with the residents, yeah.
Okay, we'll do that, and thank Dr. Mansi. Dr. Mansi, you want to say something? And Dr. Smith?
Dr. Smith
and the OT team. I have Nitin.
And OT team.
Went away outside, I think. Okay. Thank you all.
Yes, sir.
Mansi, you have to come in the camera.
Nati, you're in the pink of health.
Yeah, I have colorful dresses because I'm a colorful personality, no?
Yeah, very good. Very colorful. Smith.
The only thing is they
Mansi,
don't like
good
that
work.
saffron which I have. All the OT staff are worried I'll become a Swamiji. But they don't know all the women of BOA are with me. And Ferenc, Dr. Kerubi is my dancing partner.
Yes, you told me.
Okay.
Yeah.
And I hope Dr. Kerubi can show that dance. I hope she has it in the pen drive.
I don't have it here.
No? Maybe Samir can show.
Samir.
He has all the videos.
I was going to say, Samir must be having.
Yeah, Samir should be having. Okay. So we'll come there.
Yes, sir.
Thank
We are
you.
waiting for you.
Thank you.
Photo. Yeah.
Thank you all.
Yeah, thank you, sir.
Thank you.
Thank you, Dr. Kuhn, for your valuable comments. And thank you all of you for patiently being there here and learning from the masters.